So, hi everyone, very good morning to everybody out there. So, good morning, and it's a new day, and we are going to start a new subject, and we are going to conquer it as well. So, is everyone ready for the class? Yes. So, I'm super happy to be here with all of you, and I'm excited to give my best, so that I can be a part of your journey. And I would just say, start off by saying thank you for giving me this opportunity. I value this opportunity and I'm going to do my best for it, right? And we are going to ensure that we not only revise obstetrics, but also know every possible key point that is required for your exams, no matter what exam you give, whether it is NESET or NEET PG. So yes, once you go through with me, you will realize that it is like a very thorough revision of entire obstetrics. And mostly touch wood, and I'm going to pray God that usually nothing comes out of the DVT itself. So let's keep it like that, and we're all ready to do our best. So now, as you all know that you have the workbooks with you, and a lot of it is already written there. So I want you to all be active and alert, okay? And we want you to sort of recall with me. Yes, thank you so much. It means a lot to me when you say that. I am going to ensure that you will say that even for this class today. So the goal is simple, that we will be talking about only the obstetrics DVT today, and tomorrow we will be covering the obstetrics PYQs and the TND. Okay. Mostly I will tell you what you need to do, but today let's focus on DVT and obstetrics. So are we ready? Audio video is good for everyone. Give me a thumbs up. Are you ready for the class? Yes. Okay, perfect. So let's go ahead now, and so we are going to start from things that we should know from the basics of pregnancy. Okay, and what all are we supposed to know? So first, as you can see here, we are talking about certain important hormones, and these are those areas that are always asked in the exam, maybe directly or indirectly. Yes, so the first one that we are talking about is HCG. So super important it is to remember that HCG is produced by syncytiotrophoblasts. In fact, please remember what I have told you. All placental hormones, you will never get confused whether they are protein hormones or steroid hormones. Whenever they ask you which cells of the placenta are producing these hormones, you will answer it as syncytiotrophoblasts. What is more important when the exams go in depth is that they want you to know that it is a glycoprotein hormone. Okay, so it is a glycoprotein hormone. Now, when we come to applied part, the first application that we ask is, what is the doubling time of HCG? So we all should know that it is 48 hours. Sometimes NEET PG will ask it in a different format. So then you have to answer it as 1.4 to 2 days. It's not exactly 2 days. It is 1.4 to 2 days. Remember the concept. When you say doubling time, this is the doubling time for a live intrauterine pregnancy. So now, are you ready for application 1? Okay, I'm going to write. I know you have space there, so I do have the workbook with me. I know where you have space, and I will take care of what you're writing and what you have to write. Are you ready for application 1? Okay, so tell me, if the doubling time increases, okay? For example, let me ask you, let's say the doubling time has become 7 days. So then can you tell me, what is it likely to be? What is it likely to be if the doubling time increases? Very good. So then it is likely to be a ectopic pregnancy. Yes. So doubling time 48 hours is only for a live intrauterine pregnancy. Yes. Which means if you do serial measurements of HCG, who is going to tell me what will happen in an ectopic pregnancy? Excellent. Yes. So what will happen? So when you do serial measurements in ectopic, remember it will increase, but it is going to show a slow increase, right? So it is going to increase, but it is going to be a slow increase. Is that clear? That is what we mean when we say doubling time increases. Perfect. So every fact के साथ I will give you some application based questions side by side. Okay. Now, very important is the next point. Almost has been a question in any set NEET PG. Okay. Now, when we say it is similar to which hormones, this is LH, FSH, TSH, and which subunit is similar? It is the alpha subunit. Yes. The beta subunit is the one that is specific. It doesn't resemble or is not identical, right? Now you have to tell me application 2. When they are asking you the same question, it is identical to which hormone? Okay. So A2 is application 2. Can you tell me what would be the single best answer? So yes, the single best answer is going to be LH. So out of all the three, the answer is going to be LH. Also, when we talk about, any set exams, they ask the same things in more depth. So now you have to tell me, right, although we are saying beta subunit is specific, if your exams ask you beta subunit is not identical but similar to which hormone, then what is the answer? So beta subunit is similar to the beta of, again, LH. Okay, it differs by only how much? Differs by only 8 amino acids. The rest of it is completely similar. That is why the single best answer is LH. Okay. Now, the next application is already written for you. This is why when we ask you which hormone maintains corpus luteum, the key word here is pregnancy. The answer is what? It is HCG. Yes. Now, please remember, when the same question is asked and I ask you which hormone maintains corpus luteum, but we are not talking about of pregnancy, what will be the answer? It is LH. Okay. Now, the questions that you will be asked are, the corpus luteum is going to be maintained by up to what POG? 8 weeks. So, up to 8 weeks, it is going to maintain it. After 8 weeks, it starts to regress. Yes. Then some factual questions come in the exam. For example, HCG, how early it is produced? So it is produced 8 days, as early as 8 days after fertilization, or we can say after ovulation. Can you tell me why they are the same? Because application 3, day of fertilization, is to be taken as same as the day of ovulation. Right? So they may try and confuse you. Don't get confused. Is that clear? Yes. So as early as 8 days, HCG is started to produce. Okay. Now, the next applications are about HCG levels. Okay. The next applications are about HCG levels. For example, where are the levels higher than expected and where are the levels low as compared to what is expected? What is most important here are these things. So gestational trophoblastic disease or molar pregnancy. Okay, HCG is high. I think everybody knows, but it is more high in complete mole or partial mole? More high in or very high in, which is more than 10 to the power 5 in complete mole. So it's going to be very high. Yes. Then super important, repeatedly asked, the levels are high in Down syndrome. Then multi-fetal pregnancy, more the number of babies, the higher is going to be the HCG level. Then can you therefore tell me, when we talk about multi-fetal pregnancy, and let me now ask you, suppose I ask you there is an entity called as hyperemesis gravidarum. It is related to which hormone? Batao. So hyperemesis gravidarum is related to which hormone? HCG. I think everybody would remember that. This is the concept why in multi-fetal pregnancy, there is more incidence of hyperemesis gravidarum. So higher the levels, higher is going to be the nausea and vomiting. Okay. Erythroblastosis fetalis is the other name for hydrops, as you can see here. Yes, so it is the other name for hydrops. And again, the HCG levels are high. But do you remember why? Because if you remember the why, you don't have to mug it up. So what is the why? The why is big sized placenta. Dekho, wherever the placenta is bigger, the HCG production will be higher. Wherever the placenta is smaller, the HCG production will be less so big placenta. Yes, that's the reason. Okay. Then super important is where the levels are low. Yes. So for example, non-viable pregnancy, which is simply a word we use for abortion. Similarly, we use the word blighted ovum. It is also a type of non-viable pregnancy. Who is going to tell me what is the new term for blighted ovum? Anyone? So now we call it as what? We don't no longer call it as blighted ovum. We call it as an embryonic pregnancy. Okay, so we are going to call it as an embryonic pregnancy. There is a sac, but there is no embryo inside. So because NEET PG is fond of asking, I want you to tell me. Now we are at A4, application 4. Can you tell me the exact criteria we have to follow to label it as an embryonic pregnancy? What do we measure? Very good. I'm happy everyone is answering. I'm very proud of you. That's what you're supposed to do. Also, can you tell me, is the speed is okay for everyone? Yes? And you can ask your doubts as many as you want. Just give me a thumbs up if the speed is okay for everyone out there. Yes? Okay, so application 4 is what we measure is MSD. Very good. Mean sac diameter. No, we don't measure CRL. CRL you measure when there is an embryo inside. Okay, in an embryonic there is no embryo beta, so you cannot measure CRL bache. Okay, so what are you going to measure? MSD, right? So mean sac diameter. Excellent. Yes. So if the mean sac diameter is more than or equal to 25 mm and there is no embryo or yolk sac inside, then yes, you call it as a blighted ovum. Okay. I will tell you what you're getting confused with when we go on to the topic on abortions. Okay. Then just like we have done here that in trisomy 21 HCG levels are high, please, sometimes the examiners confuse you with trisomy 18. So remember, in trisomy 18, the levels are actually low. All parameters are low. So whether you talk about HCG, alpha fetoprotein or UE3, the levels are going to be low in Edwards syndrome. Ectopic, again, something which is a conceptual mistake and my students sometimes have a problem. When you say ectopic, please remember that the absolute levels of HCG are lower than expected. Yes, but please remember this. What will happen if you do serial measurements? There is a slow rise. So these are two different things. Absolute values are less, but on serial measurements, there will be a slow rise. Is that clear to everyone? Okay, now before I go on to the next hormone, something that I have to ask as A5. Are you all ready? Yes, everyone. So who is going to tell me a positive pregnancy test? Okay, and when we write that, we usually mean a UPT. So a positive pregnancy test is it a presumptive sign of pregnancy, a probable sign of pregnancy, or a positive sign of pregnancy? Because I see some students get confused here. So you have to tell me, what kind of a sign of pregnancy is it? A positive UPT? Batao. So a positive UPT, please remember, is a probable sign. It is not a positive sign. It is not a presumptive sign. Very good. I see everyone has answered it correctly. Yes. Okay. It is a probable sign. What are the other areas my students sometimes get confused? So I have to ensure you don't go get confused. Uterine enlargement. Okay. So uterine enlargement, is it a presumptive, probable or positive sign? Ab batao. So uterine enlargement again, bache, is a probable sign. Okay, there could be so many reasons that why the uterus is enlarged. It could be a fibroid uterus. So it is a probable sign. Is that clear? No. Presumptive nahi hota beta. Please remember, presumptive signs are those which are felt by the woman herself. Okay. And she presumes that I am pregnant. So no, it is not a presumptive sign. It is a probable sign. Is that clear to everybody? Yes? Okay. Then we move on to since you have asked, so I will ask you now, what about quickening? What kind of a pregnancy sign is quickening? Anybody? So quickening is something which the woman has felt herself. So now quickening is definitely a presumptive sign. Okay, so quickening is going to be a presumptive sign. Is that clear to everyone? Yes? Good. What about ballotment? Yes, what about ballotment? So there is internal ballotment, there is external ballotment. What kind of a sign would be ballotment? Both, whether it is internal or external. Batao. And you have a lot of empty space on the first page of your book. So you can write all these things there, right? So first page mein below HCG bahut sari jagah hai. You can write it there. Yes, so ballotment, no, it is not positive. Again, ballotment, whether we say internal or external, both types of ballotment, they are going to be again probable signs. Okay, so they are going to be probable signs. So these are some of the areas where again, you know, either ENICET is confusing you or NEET PG is confusing you. So you are not going to get confused. My very important last question, and then I move to the next topic or next thing is, okay, you have to tell me, suppose we are giving you findings in a patient and we are saying you that there are three presumptive signs. Let's say there is nausea, there is amenorrhea, there is breast changes. They are all presumptive signs. So there are three presumptive signs and there are two probable signs. Now tell me, what is the final diagnosis? Is it probably a pregnancy or it's still presumptive? Kaun batayega? Three presumptive signs hai and two probable. Right? Let's say Shadwick's is positive and Hagar's is positive. Okay, and there are three presumptive signs. So what would be your final answer? Are these in together presumptive of pregnancy or probable of pregnancy? So probable. Even if you see one sign which is probable, you obviously will go it and mark it as a probable thing. Very good. Yes, excellent. Similarly, if you see even one sign which is positive, okay, maybe you are seeing a fetus, then yes, it is positive that she is pregnant. Okay, well done. All right. Yes, I have been seeing your query, bache. So no, blighted ovum is not same as missed abortion. They are very different things and I will talk about each one of them. I promise you I will not go without answering your queries. So as we keep moving forward, you will see that automatically every possible doubt that you have will get solved when those respective topics come. So just have some patience and I promise I will not go without solving your doubts. Okay? Chalo. So next super important hormone is going to be human placental lactogen. Okay, HPL. My first question to you is, what is the other name of HPL? Who is going to tell me? So HPL, you know, bache, is now called as HCS. Okay, human chorionic somatomammotrophine. Okay, abdominal enlargement is going to be presumptive because that is something that maybe the woman is feeling herself. Okay, uterine enlargement is probable. Okay, so there are two different things. Abdomen can be enlarged even because of ascites. Yes. Okay, so yes, human chorionic somatomammotrophine. So can you tell me it resembles which hormones? Anybody? HPL, like we have done HCG, it resembles LH, FSH, TSH. Can you tell me HPL resembles which? So it resembles growth hormone as well as prolactin. That is why, bache, it is called as human chorionic somatomammotrophine. Somatic growth, so growth hormone, mammotrophin, so prolactin. Is that clear? Okay. Now, I want to ask you, because we are saying it resembles growth hormone, yes, so does it have any role in fetal growth? Yes or no? No. Please remember, very important, when we talk about fetal growth, there is no role of HPL or growth hormone. You will answer it as yes, insulin-like growth factors. If that is not in the options, you are going to answer it as insulin. Okay. Now, again, the source, as I said, remains as syncytial trophoblast. and it also starts coming as early as 3 weeks, which is similar to that of what? Similar to that of HCG. Now, why is it a very important thing? Because it is responsible for a very important finding, and that is insulin resistance. So, the main function of HPL is insulin resistance. Yes, so yes, pregnancy is a state of insulin resistance. Yes, it is fetal insulin. Please remember, maternal insulin cannot cross placenta. Okay. Right? So maternal insulin does not cross placenta. So when you say growth, it is fetal insulin. Okay, bacha? Right, so it is responsible for insulin resistance. Now these are PYQs and factual questions. For example, when do you see maximum HPL production? Right, so maximum levels of HPL are seen in the third trimester at 36 weeks. So are you ready for the next application? So let's put it as, I think, A6. Yes. So now I want to ask you, which hormone is produced in maximum amount by the placenta at term? Can you tell me what is the answer? Is it HCG? Is it progesterone? Is it HPL or is it estrogen? Which hormone is produced in maximum amount at term? Yes. So please remember, batao kya hai answer? The answer will be HPL. Don't answer it as HCG. In fact, HCG is quite the reverse. Can you tell me when do you see maximum amounts of HCG? Maximum amounts of HCG are 10 weeks. Okay, maximum amount of HCG is 10 weeks. Minimum amount of HCG is 16 weeks. And after that, it remains a plateau. Okay, so answer is not HCG. Answer is not progesterone. It is actually HPL. Okay, now, which means, do you understand that the HCG levels keep increasing as we go further? So how will any set ask you the same question? They will ask you, what happens to insulin resistance? So it is still A6, okay? What happens to insulin resistance as POG increases? Can you tell me what is the answer? So insulin resistance would also increase as POG increases. Yes. Then yet another way, indirect way of asking the same thing, is pregnancy a state of hyperinsulinemia? Yes. So in pregnancy, you come across hyperinsulinemia. Yes. So all these are very important. And again, if I have to ask you this, I'm going to just ask you in a different format, right? For example, how am I going to ask you this? So you all have to know this, what I'm writing. I hope you all know that this time in your DVT workbooks, you can't see it right now, but at the bottom, do you see the area for keynotes? So every page has area for keynotes, and you can add these little things that we are telling you, so that for your final revision, you can use only this workbook and you don't need anything else. Okay. So now you're going to tell me, in a pregnant woman, okay. So you will tell me, in a pregnant woman, what would be the findings if you take a fasting blood sample? Can you tell me? Yes. What will happen if you take a fasting sample? So will there be hypoglycemia or hyperglycemia? So fasting mein bache, you will see hypoglycemia, and in the postprandial levels you will see hyperglycemia. Why? Because the insulin levels are high. So when she doesn't eat, it becomes hypoglycemia, and postprandial, the resistance is there. So there is hyperglycemia. Okay, perfect. Now before I go forward, one of my bachas was asking, ma'am, how is it same? Because you said HCG comes at 8 days and this you have written 3 weeks. So then you have to go back to your basics. See, HCG humne likha, it comes as early as 8 days. From where? Can you tell me? HCG के लिए लिखा था as early as 8 days, but that is from fertilization. When you say weeks, weeks is from LMP. So it is for you now. When I say 8 days from fertilization, how many days it is from LMP? चलो बताओ. How many days will it be from LMP? Plus 14. Yes, so plus 14 matlab 22 days, which is again approximately 3 weeks. Do you see why I said it is the same time? Yes? Okay, so you have to add 14. Yes, so you have to add 14. So 22 days, which means again 3 weeks. Do you now understand why I said same time? Okay, chalo. Shall we move forward now? Let's move forward. Okay, perfect. The next very important one that we are going to talk about is going to be progesterone. Yes, so now very, very important. It is a PYQ and yes, it will keep coming in the exams. What is the source of progesterone in the first 8 weeks or 2 months of pregnancy? So when we ask you first 2 months or 8 weeks, you will not answer it as placenta. Okay, so you will answer the source as corpus luteum. Okay, after 8 weeks, the placenta will take over the function. So the same MCQ has been asked multiple times. So they may say placenta takes over the function of corpus luteum by what time? So you will answer it as 8 weeks. Okay, then super important. Progesterone will decrease the uterine contractions. Yes, and this is why. So let's put it as A7. This is why progesterone is used for prophylaxis of preterm labor, right? So women who are high risk, yes, what are we going to give them? They will receive progesterone. For example, a woman with previous history of preterm labor. Yes, is she high risk? Definitely yes. What do you do in the next pregnancy? You will give progesterone supplementation. But please remember one thing. It is only used for prophylaxis. Can I say a woman is already in preterm labor and will I give her progesterone? Yes or no? The answer is no. Please remember, progesterone is not a tocolytic. Okay, once contractions start, progesterone cannot stop. So it is not a tocolytic. It cannot be used for treatment. It is only used for prophylaxis. Perfect. Very good. Okay, is that clear for everyone? Yes, we will talk about estrogen as we go further, but here let's understand some very important things because progesterone is very important for implantation. Now, who is going to tell me why? When I say A8, I am saying progesterone is important for implantation. Who is going to tell me why? Jaldi batao. Because progesterone is the one which converts the endometrium into decidua. So decidualization is under the effect of progesterone. It's a secretory change which is brought about by progesterone, right? So it is one of the most important things for implantation and that the baby is not aborted. Okay. Then very, very important, when they ask you about this early pregnancy, all exams are asking about something around implantation. Yes, so please remember, when we ask you the conceptus enters the uterine cavity, in which form? The answer is morula. So it enters as a morula. Morula is to be answered as a 16 cell stage, and we are fond of asking when does it enter. So you will say it enters on day 4. Okay, so it enters on day 4. Whenever we use the word days, we are calculating from fertilization. We are not calculating from LMP. Okay, so we are calculating from fertilization. Yes, then what happens? The morula will convert into a blastocyst. Can you tell me why is it important? Because when we ask you about implantation, in which form does implantation happen? So A8, implantation will happen as a blastocyst. Okay, so it is going to be a blastocyst. No, blastocyst is 32. It is the next stage. So it is 32 cells and beyond. Okay. What are the previous year questions that have been asked here? So remember, blastocyst is formed on day 5. Day 5 is also the time when zona pellucida is lost. Now this process, when the zona pellucida is lost, what term, fancy term do we use for it? We call it as zona hatching. तो आपके नीट पीजी वाले आपको कंफ्यूज करते हैं, राइट? सो व्हाट इज जोना हैचिंग? इट इज द लॉस ऑफ जोना पेलुसिडा. व्हेन डज इट हैपन? डे 5. यस, ओके. Then before I go to the implantation days, whenever I am talking about zona hatching, what is the next application? So A9, are you ready? Yes. So can you tell me, if we ask you prevention of polyspermy? Yes. So when I ask you prevention of polyspermy, what would be the single best answer? Is it zona reaction or is it the cortical reaction? Batao. What would you mark? So prevention of polyspermy is going to be a zona reaction. Okay, that is the single best answer. Yes, very good. This is what is called as slow block. So in humans, we don't have fast block, we have slow block, right? And this is what is zona reaction. So many of you are answering it wrong. No, cortical reaction is the signal, yes, which leads to zona reaction. But cortical reaction is not the event which is by itself preventing polyspermy. Do you understand? The cortical reaction is the signal which leads to zona reaction. The final step which prevents polyspermy is zona reaction. So if both are in the options, what are you going to mark? You are going to mark zona reaction. When do we mark cortical reaction? When zona is not in the answers. Then you will mark cortical reaction. Yes. And now I want to ask you here. When I say zona reaction, okay, what exactly do you mean by it? Who is going to tell me what happens in zona reaction? Hardening of zona pellucida. Okay, so what happens is the hardening of zona pellucida. Okay, so please remember this. I don't want anyone to do this wrong. So there is hardening of zona pellucida. Okay, just give me a moment. I'm going to be back in a second. Okay, just a second. Yes, so as I Yes, okay, so I'm back. So as I said, cortical reaction is the signal for zona reaction. Okay, and when I say zona reaction, it is the hardening process. All right, so now I want to take you next thing is to know about implantation. So again, these are PYQs and they have been asked in your exams. For example, we are very fond of asking on when does implantation begin. So it is day 6. If it's not in the options, yes, you will mark it as day 7. When is it completed? Day 10, right? So day 6 se shuru hota hai and it will end on day 10. Now I want to ask you, suppose in your exams, I want to ask you the same thing in a new format, then I will ask you the question as implantation window. Yes, are you all with me? Okay, so when you say implantation window, yes, it is from day 6 to day 10, but this is post-fertilization. In your exams, when they ask you about implantation window, they are asking you days of menstrual cycle. Can you give me the answer? What day of the menstrual cycle is considered as implantation window? So from day 20 to day 24. Am I right? This is the only time when implantation can happen. So be very careful. This is also days, but we are asking you days of menstrual cycle. When we say 6 to 10, it is days post fertilization. Is that clear to everyone? Give me a thumbs up. Perfect. Very good. The last application that I will ask you here and then move forward is A10. Okay. Whenever we talk about implantation, we are wanting to know, especially NEET PG, about superfetation. How would you remember superfetation? So remember it like this. I have written here superfetation. So superfetation, you have to remember this means there is already a fetus there in the pregnancy and another one comes. So fetus is already there. Okay, and another one comes. So which means it can only happen in different cycles. Do you understand this? Yes, aise yaad rakhna hai. Very good. So John actually remembers the words I have used in the class. Yes. So another one comes on top of it. Yes, super. So this is going to be a different cycle, because I know these are the areas where you forget, because these are recall errors, but your exams are asking it. Now you will not make a difference, you do it wrong, and therefore they will have different gestational age. Am I right? Yes, they will have different gestational age. The minimum gap that the two babies will have will be 4 weeks. Yes, so the minimum gap will be 4 weeks. Also, please remember, when you say superfetation or superfecundation, superfecundation therefore is going to be the same cycle and same gestational age. But both of them, do you understand that the father can be same or different? Yes, so they can be heteropaternal. They're not always heteropaternal, but yes, they can be heteropaternal. Okay, suppose I say one baby is black and one is white, then it is definitely heteropaternal. Is that understandable? Yes, so these are important things that NEET PG has been asking. Are you all good with this? Chalo. So now whenever we talk about the process of implantation, this period is very important. Yes, because soon after there is this teratogenic period. So now I want to ask you, when you are talking about teratogenic period, from what weeks to what weeks it is? Can you tell me? So from 3 to 8 weeks, but it is again post-fertilization, right? So from 3 to 8 weeks post-fertilization is the teratogenic period, most teratogenic. Some teratogenicity can happen even after up till 12 weeks. But the most teratogenic is from 3 weeks to 8 weeks post-fertilization. Okay, so now this is again a topic that all your exams are very fond of asking. Again, both INICET as well as NEET PG. So the first teratogen that I want you to see here is ionizing radiation. Yes. Now, please remember, up till 5 rads, okay, so up till 5 rads, there is no risk to the baby. Okay, so it is considered as not a risky exposure at all. Okay, but yes, beyond 10 rads, okay, there is definitive evidence of fetal damage. Between 5 to 10, it is the gray zone. Something can happen, it may not happen. Yes, but we can't ever be sure. So less than 5 rads is okay. Now, what is the application for this? So A11 is the application. Yes. So please remember all diagnostic radiation. So X-rays, yes. So usually even if you do multiple X-rays, the exposure will be still less than 5 rads. So if there is an accidental exposure in this time frame, what will your answer be? Your answer has to be, we will continue the pregnancy. Okay. Then this is a older PYQ. For radiation injury, the most teratogenic period is 8 to 15 weeks. Okay, as I said, it's a PYQ, a little older PYQ, but yes, it has been asked a couple of times in the exam. So for ionizing radiation, the most teratogenic period is 8 to 15. Don't say, ma'am, you had taught us 3 to 8 weeks. So for ionizing, 8 to 15. Okay. Also, when I talk about A11, we are talking about diagnostic radiation. I want to ask you, can we do MRI in pregnancy? Is it safe? Yes. So MRI is safe, but we will not use what? I'm sure Dr. Sumer has already taught you. We will not use gadolinium contrast, right? So no gadolinium. Okay. Also, what about ultrasound? Ultrasound is absolutely safe. It can be done, multiple times. There is no damage at all. But what about Doppler? So please remember, Doppler is not very safe in early pregnancy. So Doppler, when we talk about early pregnancy, it should not be done routinely. Okay. So avoid in early pregnancy. So this is why we are fond of asking, can we do, yes, so see, Doppler can be done after the first trimester is over any number of times. So generally we will not do it routinely in the first trimester. So for cardiac activity, do we use Doppler? The answer is no. To look for cardiac activity, we use M mode of ultrasound. It is the motion mode of ultrasound. Is that clear to everyone? Yes? Okay, perfect. Then there are certain syndromes that your exams are fond of asking. Again, both exams. So let's look at this now. So alcohol. It has a very high probability of repeating in the exams. Remember, it causes FAS. FAS is fetal alcohol syndrome. Okay, and there is a triad. Yes, so triad is what? It is IUGR, growth restriction. Sab kuch chota, everything is small. So growth restriction, hypoplasia and microcephaly. Yes, now when we say exactly what is the problem in the facial features, we are going to remember it as short palpebral fissures, a smooth philtrum and a thin vermilion border. The details can come in the INI-SET exam. So for NEET, you should know it's a triad of everything small, right? But INI-SET may go further and ask you what exactly are the facial features. So these are the ones that you have to remember. All right, that's an interesting name that I have in the chat box, and that's James Bond. So no, there is no specific reason. Sometimes it is just a factual information that you have to remember, bache. Okay. Yes, CT scans are to be avoided in pregnancy. They are not considered as safe. Okay. Chalo, let's go further. The one that has been asked multiple times in the exam is diethyl stilbestrol. Super important for all exams, right? So you have to remember it can cause a T-shaped uterine cavity. Okay, so T-shaped uterine cavity. Very importantly, clear cell cancer of vagina. Now, sometimes when you remember it as clear cell cancer, they will not give it in the exams. So you have to know that when you say clear cell, it is a type of adenocarcinoma. So sometimes they will specifically write it as adenocarcinoma of vagina, and that is also correct. Okay. Yes, as far as a male fetus is concerned, this is going to cause hypospadias and renal anomalies. So what is specific to male baby is hypospadias and renal anomaly. Yes. Lithium, multiple times asked in almost all exams. I'm sure you remember it is Epstein's, but can you tell me, if I give you an application question, let's say a newborn baby, and I'm showing you a chest x-ray of the newborn baby, can you tell me, okay, can you tell me what would be the findings in the chest x-ray? What shaped heart? Yes, sometimes you get confused in basic things. So it is not boot. This is not boot shaped. It is a box shaped heart. Very good. Okay. Now also, since we are talking about this, typically, you get confused in these two things. For example, your patient has a bipolar disorder. So it's still A12 and she is on lithium. And we are asking you, what will you do to the lithium dose in the third trimester? Now, what is the problem? You people think of anomalies. Please remember, we are talking about third trimester. Anomalies happen in the first trimester. Okay. So when we are asking you, what do you do to the dose of lithium in the third trimester? What is the answer? Yes, you have to increase the dose because the renal clearance increases. So you will have to increase the dose. There is no problem of anomalies here. Is that understandable? Okay. Then, again, multiple times asked in the exam, phocomelia is by thalidomide. I want to ask you, is it a proximal limb defect or a distal limb defect? It is a proximal limb defect, right? Which means the entire arm is absent. It's called as what baby? A flipper baby. The hands will be attached here at the shoulder. So it's look like a flipper baby. It's a proximal defect. Then valproate, again, multiple times asked. It is a category X drug. Okay. Should not be given in pregnancy. It typically causes neural tube defects, especially you have to know it is linked to spina bifida, it is linked to cleft lip. Yes, so spina bifida you have to remember for valproate. What about warfarin? Yes, so yes, the syndrome is called as chondrodysplasia punctata. But can you tell me what exactly will you see here? So I have given you. Sometimes they will not give you the name. They will ask you, what do you see? Or give you the finding. Yes. So please remember, what you see here is nasal bone hypoplasia. And you will see stippled epiphysis. Okay. So you will see stippling of epiphysis and nasal bone hypoplasia. So this is chondrodysplasia punctata. Now I want to ask you, okay, so I want to ask you, is warfarin contraindicated in pregnancy? Yes or no? Yes. Okay, so please remember, warfarin is also a category X drug. It is contraindicated, but please remember, there is only one condition for which it is approved. What is that condition? It is approved for what? It is approved for, yes, prosthetic mechanical heart valves. This is the only condition for which warfarin is approved. Otherwise, it is not to be used. Now, therefore, you do mistakes in when we give you these questions. Suppose you want to give thromboprophylaxis in pregnancy. or you want to give thromboprophylaxis in purpurium the first 6 weeks when the chances of thrombosis are very high. Which drug will you give here? Please don't answer it as warfarin. Okay? It is still prophylaxis, even in purpurium. You don't need to give warfarin. The answer will remain as low molecular weight heparin. So when you want to give thromboprophylaxis, you are going to give LMW. It is enoxaparin. Do not answer it as warfarin. Is that clear to everyone? Okay. Then some of the other things that we are fond of asking, again specifically NEET PG has been asking, is a very important drug called indomethacin. So you all have to remember, we will not give indomethacin beyond 32 weeks because it can cause premature closure of ductus arteriosus. You can give it at less than 32 weeks. What do we use it for? Anybody? Indomethacin is used as a tocolytic at less than 32 weeks. Now I'm going to ask you something more. So this is A13 and now I'm going to ask you application 14. Suppose you are giving indomethacin to someone as a tocolytic. You should give for only short duration, which means 48 hours. Can you tell me the why behind it? So now they could ask something new, right? So this could be the something new. What will happen when you give indomethacin for longer time periods? क्या होगा? बताओ. It will cause oligohydramnios. It reduces the renal blood flow. So it will cause oligohydramnios. So you don't give it for long durations. And this is what we will ask further. Therefore, okay, indomethacin can be used in which condition? No, PDA tha only if you are giving it after 32. I am saying you are giving it at less than 32 weeks. If you give it for long duration, what will happen? It will cause oligo. Okay. Therefore, can indomethacin be used in treatment of polyhydramnios? Yes or no? Yes. So therefore, it can be used in the treatment of polyhydramnios, but only less than 32 weeks, not beyond 32. Okay. Perfect. Very good. Then, yes, as I said, if we are focusing in what things NEET PG is fond of asking, it is specially vaccines which are contraindicated in pregnancy. The best answers are MMR, varicella and HPV. Although we also put yellow fever in this list, but it is not the best answer. Why? Because yellow fever vaccine comes with a rider. Okay, what is the rider? Yellow fever can be given if she is traveling to endemic area. Yes, so then you can give yellow fever. So agar question hai all are contraindicated except, and you have to choose one of these, you will go with yellow fever. It can be given. Okay. Then if INICET has to ask you the same question, they will say a pregnant woman's little child, she's pregnant for the second time. Let's say she's 8 weeks pregnant. Her first baby has developed varicella. So which means she is exposed to the virus. What will you do now? Don't answer it as acyclovir. Okay. Don't answer it as vaccine. You have to answer it as varizig, varicella zoster immunoglobulin. Okay, so varicella zoster immunoglobulin. All right, certain other things that I want you to know, so I'll put them as A15. Who is going to tell me what will isotretinoin do? Anybody? Because this is again likely to be asked in the exams. Isotretinoin. So remember it as microtia and anotia. These are the specific things. It may cause other things as well, but these are specific to isotretinoin. Remember the minimum gap, right, for stopping the drug and trying to conceive. So minimum gap in trying to conceive is how much? It is 1 month. You have to answer what is the minimum requirement. So it is 1 month for isotretinoin. Okay. Then suppose I am saying your patient has taken some drug for MTP, but she did not abort, and now the baby has Mobius syndrome, which is 6th and 7th nerve palsy. Yes, can you tell me the drug exposure? So do you answer it as mifepristone, do you answer it as methotrexate, or do you answer it as misoprostol? So the single best answer is misoprostol. Although the patient has received a combination of mifi and miso, but the syndrome is more characteristic to miso. So that will be your single best answer. Then two others which any set are fond of asking. So can you tell me about chloramphenicol, and can you tell me about tetracyclines? They are again contraindicated in pregnancy. Chloramphenicol, you know, is gray baby syndrome. Tetracyclines or fluoroquinolones, they are going to cause staining of teeth. What about aminoglycosides? Auto and nephrotoxicity. So these are the other areas that have been recently asked in the exam. So you have to know this. Are we all good? Should we move forward? Chalo. So the next thing we talk about is early development of the baby. Yes. So very, very important, again, almost always asked in the exam. So when we talk about paramesonephric ducts, remember they are the other name for Mullerian ducts. Yes, so they are the other name for Mullerian ducts. Yes. Now, certain things we are very fond of asking. So remember the gonad, okay, which gonad? It is testes. So testes is going to secrete MIS, Mullerian inhibiting substance. It is same as AMH. Yes. Can you tell me what cells secrete this? I am saying gonad, but what cells? So very important. We will write here, it comes from the Sertoli cells. So you remember how I have taught? So MIS ends with S. So Sertoli cells. Now they cause regression of the Mullerian ducts, and this is a neat PGPYQ. The gene is present on chromosome 19. Yes, the gene for MIS is present on chromosome 19. Is that clear? Okay, the important application which would be needed maybe for any set because they go into more depth, I'm going to write it as A16. Yes, they definitely cause regression of Mullerian ducts, but what is the little more thing you have to remember? They cause regression of only which duct? Of only ipsilateral duct. Which means the MIS released from the right testes can cause disappearance of only the right Mullerian duct. It cannot cause disappearance of the left duct. Is that clear to everyone? Okay. Then mesonephric ducts are also called as Wolffian ducts. Yes. So Wolffian ducts. And what is required for development of Wolffian ducts? So first thing that you have to know is Wolffian ducts will form the male internal genitalia. So the male internal genitalia comes from Wolffian ducts. And what is required for formation of male internal genitalia? It is going to be testosterone. Yes. Now a very important application which is required when you go for higher ranks. Can you tell me this testosterone is very important for development of male internal genitalia? Can you tell me what is the first stimulus for release of testosterone from fetal testes? Who is going to tell me? What is the first stimulus for the release of testosterone? Anyone? So this is HCG. The first stimulus, very good. It is going to be HCG. Yes. So the male internal genitalia, I hope you all remember. I've told you to remember it as seed. Yes, that's the mnemonic, seed. And these are seminal vesicles, epididymis, efferent ducts, and ductus vas deferens. Okay, so these are important when it comes to male internal genitalia. Again, nowadays they are asking a lot about this development, so you should know the male external genitalia as well. They have been asking which hormone is required. So now the answer changes to dihydrotestosterone, okay, DHT. So be very careful. Are they asking about internal or external? This has again been asked in the exams. The enzyme required for this conversion is 5-alpha reductase. Yes, it is 5-alpha reductase. Okay. Now, since I am telling you this, I want you to tell me the next application, which is A18. So if I am saying there is 5-alpha reductase deficiency, can you tell me what would be the presentation, or can you tell me what kind of pseudo-hermaphrodite is it going to be? So deficiency leads to male pseudo-hermaphrodite. Why? Can you tell me? Because the karyotype is XY and they do have a testes, right? The testes is also producing testosterone and MIS. Yes, so they do have testes, they do have testosterone. What they don't have is dihydrotestosterone. So external genitalia are going to be female. Now quickly tell me, will uterus be present or absent? Absent. Yes, the uterus is absent because they will have MIS. So how will the girl, so when this child is born, they are going to be labeled as a girl child. So this girl will present as primary amenorrhea. Okay, so she will present as primary amenorrhea with absent breast development. This is how you differentiate it from AIS. Unme breast development is present. Is that clear to everybody? Okay, let's go back now. So sometimes they are fond of asking, how will or when can the sex of the child be differentiated? So whenever they ask you about sexual differentiation or sex identification, it has to be done through external genitalia. You will answer it as 12 to 14 weeks. Okay. Then typically when you say testes or ovary, we are talking about gonads. Yes, we are talking about gonads. Gonads do not come from Wolffian duct or paramesonephric ducts. The gonads come from genital ridge. Sometimes you do this wrong. Okay, so they come from genital ridge or gonadal ridge. Remember, testes comes by 7 weeks, ovary comes by 8 weeks. Now, what is the deciding factor? The testes will come or the ovary will come in the female, in the child or in the fetus? The deciding factor is SRY. And it is a Aniset PYQ. Where is SRY located? Short arm of Y chromosome. Yes, so when SRY comes, it will result in the formation of a testes, which means we can say, that the breast, okay, I'll talk about breast development in a moment. The gonad is bipotential till 7 weeks. Okay, so the gonad is bipotential till 7 weeks. Is that clear? Okay, beta, I said here the breast development is absent because this testosterone can act on its receptors. So testosterone at puberty gets used up. There is no excess. So it is not converted into estrogen like in AIS. In AIS, it cannot act on its receptors. So it converts into estrogen and causes breast development. Here, this testosterone can act on the receptors. So it gets used up at puberty. There is no extra testosterone. So breast development is absent. Okay? Chalo. The next thing that we are going to talk about are the physiological changes, always you will have one or more than one MCQs in all exams, right? So it's a very important topic. So among the changes, the most probable things that they ask in the exam, number one are cardiovascular changes. Okay, so remember, मैं अपने बच्चों को ऐसे बताती हूँ, cardiovascular system में everything increases except two things. Can you tell me what are those two things? So everything increases except one is blood pressure, the other is peripheral vascular resistance. These are going to decrease. So as I said, the blood pressure decreases. Diastolic blood pressure decreases more than systolic blood pressure. Okay. Then, as I said, vascular resistance is also going to decrease. These are the two things which decrease. All exams have been asking about cardiac output, especially when it is maximum, when it is minimum. So remember, cardiac output is lowest when the woman goes in the supine position. INICET has been asking a lot of why. Why is this happening? Why is that happening? So the reason here is not aortic compression. Remember, it is IVC compression. Okay. Then similarly, when we talk about when is cardiac output highest, the order has to be immediate postpartum and then in the second stage of labor. Right? Then it is highest at 32 weeks. So when I talk about application here, if I ask you what happens to cardiac output at term, this again decreases. This is an old PYQ from INICET. So do not get confused. Overall, the cardiac output increases, right? But if they are specially asking about it at term, it slightly decreases in comparison to 32 weeks. So till 32 weeks, it was increasing. Then it's a plateau. Then at term, it slightly decreases and then it increases again in labor. Okay. So when asked at term, it slightly decreases. Yes. Then still, if I am talking about the application, I want to ask you, what is the best position for you to do a cesarean section? Can you tell me? If we are doing a cesarean, how should we position the patient? So you have to say supine with wedge under right hip. We want a slight lateral tilt, a 15 degrees lateral tilt. Yes, a tilt to the left. So which will happen when you put a wedge or a pillow under the right hip. Is that clear? Very good. Good. The next questions that have been asking in the exam or that have been coming in the exam are hematological changes. Again, both exams, INICET and NEET PG. The first very important one is there is a massive expansion in the plasma volume. Can you tell by how much? 40 to 50%. That's the expansion. Yes, so this is because of water retention. So now I am going to ask you A21. Are you ready? Can you tell me what is the reason for volume expansion? Why is that going to happen? Kaun batayega? As I said, sometimes they will ask you facts, sometimes they will ask you whys. So why, what is the answer here? So for why, the answer is estrogen. What is the mechanism? Mechanism is estrogen is going to increase what? Yes, so estrogen is going to increase the activity of RAS. So renin, angiotensin, aldosterone. But please remember, it also increases the ADH action. Yes, so ADH का action भी increase होता है. So this is the reason for volume expansion. Is that clear to everyone? Okay. Now, although there is a volume expansion, I hope you all remember that when we talk about hemoglobin and hematocrit, they are going to decrease because of hemodilution. Yes. So, anemia in pregnant women, yes, is the cutoff 11 or 12? So, remember, in non-pregnant, the cutoff is 12. In pregnant, the cutoff is 11. or hematocrit less than 33%. Yes. Similarly, in the hematological systems, ESR has been asked previously. It's a little different answer, but still related to what we are talking about. So remember, ESR is going to increase. Now, what AIMS did was they asked the why behind it. So when we ask you the why, the answer is increase in fibrinogen. Can you tell me which other thing increases? Also because of increase in globulin. But what is the best answer if we have to mark one answer? It is increase in the levels of fibrinogen. ठीक है? Albumin and globulin में क्या होता है? Albumin decreases, globulin increases. Is that clear? Is fibrinogen a clotting factor? Yes. So now can you tell me why fibrinogen increases? So again the reason is estrogen. Okay, so what is 822? Estrogen is not only responsible for volume expansion, it is also responsible for increasing all clotting factors. When I say all clotting factors, your exams are fond of asking except. So what is the answer for except? Yes, 11 and 13. So 11 and 13 will actually show a decrease. Please remember protein S also shows a decrease. Okay, so protein S also shows a decrease. When I ask you about this, what is, as I said, this has been again asked in both exams. What would also be asked is, can you tell me what happens to platelet count in pregnancy? So there is a slight decrease. Yes, we call it as gestational thrombocytopenia. So this is the most common reason for a low platelet count. It doesn't have to be bothered about. It is gestational thrombocytopenia and it is only mild decrease. So levels are between 1 to 1.49 lakh. They do not go below 1. If they go below 1 lakh, it is no longer gestational. You have to find out an underlying cause. Is that clear to everyone? Yes? Okay. Now, in the pulmonary category, we should know what all increases, decreases, but most importantly, your exams have been fond of asking things which show a no change. Yes? So please remember, definitely tidal volume increases, minute ventilation increases. When it comes to respiratory rate, when it comes to vital capacity, these typically show no change. So vital capacity, maybe there is no change. Is that clear? Okay. What about residual and reserve volume? So these are going to decrease, typically the IRV. Okay. Now, जैसे मैंने बोला, remember, especially the next part that I'm going to tell you, it could be a probable MCQ. So what happens is PCO2 decrease करता है और PO2 increase करता है. So your exams are fond of asking what kind of respiratory or metabolic alkalosis or acidosis it is. Okay, so remember, it is primarily a compensated respiratory alkalosis. So basically the kidney is going to do the compensation and the pH will show a no change. Yes. Total lung capacity, again the best answer is no change, although there is a very slight decrease. Yes. Now from this part, what is the application I want to ask you? Okay, so when you say these respiratory changes are happening, we are going to ask you why. So why is there an increase in the depth of respiration? So when you say increase in the depth of respiration, do you know what that means? There is going to be increase in diaphragmatic excursions, which is the up and down movement of the diaphragm. Can you tell me the why behind it? So Why is there an increase in the depth? You have to now answer it as not estrogen but rather progesterone. See, majority of changes are primarily because of progesterone. Only some are because of estrogen. Okay. Two we have seen because of estrogen. One is volume expansion. The other is clotting factors. I'll tell you the others as well. Okay. So progesterone क्या करता है? It increases the sensitivity of respiratory center to carbon dioxide. Yes, that is why the depth of respiration increases. Am I good? Yes, are you clear? Give me a thumbs up if you're good to go. Okay, then we talk about the renal changes. Now, renal बहुत सारा है, but we are going to restrict to what is likely to be asked in the exams. Everyone should know that ureters can show a dilatation in pregnancy. So yes, it is possible to come across hydroureter and even hydronephrosis. If we ask you why, okay, now listen to me very carefully. If we ask you why there is hydroureter or hydronephrosis, your answer again remains as progesterone, okay, because it's a relaxant. But the tricky or the twisted part they ask is, this hydronephrosis is seen more commonly on the right side, less commonly on the left. It can happen, but less. They will ask you the reason for this. Please do not answer it as progesterone. Understand, progesterone is present systemically. So it will act on the right side also, it will act on the left side equally. So it is not the reason why right is more than left. It has to be a local cause. The reason here now becomes dextrorotation of the uterus. So because the uterus is dextrorotated, tilted to right, it compresses right ureter more. NEET PG has also been asking more things. When we say it compresses the right ureter more, do you know where is this compression happening? This compression is happening on the or at the level of pelvic brim. So proximal to the pelvic brim, the ureter will show dilatation. Okay, is this clear? So you should know what, why to answer where. Yes? Okay, the next thing is GFR. Very, very important. Definitely this increases significantly, and that is why serum levels of urea, nitrogen, creatinine, they are all going to decrease. Okay, that is physiological. Is that clear to everyone? Okay. Now, moving on to the endocrine changes, especially when we talk about prolactin, this is NEET PG's newfound love, right? So remember these things. There is a massive increase in the size of the pituitary gland. So it has a massive vascular requirement. Yes. Most of this size is coming because of expansion of lactotrophs, right? So the cells which are secreting prolactin. Okay. These are important PYQs and NEET PG. They do ask applied parts as well. So levels of prolactin are highest in the third trimester. Okay, they are not high during lactation in third trimester. In fact, after delivery, the levels are going to decrease by 50%. So now, please remember, when we say prolactin, it definitely comes from anterior pituitary. But in pregnancy, do you all know there is another source of prolactin? Who is going to tell me what is the other source? It is decidua, right? So decidua is also producing the prolactin. Is that clear? Okay. Now, despite the prolactin levels very high, why there is no breast milk, I would say, expression rather than production in pregnancy? So you have to answer it as there is a negative feedback by progesterone and estrogen on prolactin receptors on the breast tissue. Okay, they do not let the receptors become sensitive. Yes, so the receptor remains insensitive. Is that clear? Okay, same question asked in a different format. So what will be the first stimulus for initiation of lactation? The answer is not touch of the baby or the feel of the baby. It has to be a sudden fall of estrogen and progesterone. The next part, which I think everyone knows, so I'm just going to put it here as A24. Which of the two hormones is called as milk ejection hormone and which is called as milk production hormone? So when you say milk ejection, we can also write it as milk let down. So then the answer is not prolactin. I am sure you all will remember that here the answer changes to oxytocin. Okay? Yes? So, okay, as I said, bache, everywhere where you have to pick one of the two, progesterone or estrogen, you always answer it as progesterone, except for 4 things which are because of estrogen, right? So, one is volume expansion, one is clotting factors, the others we will talk about. It is hyperpigmentation and increase in the levels of thyroid binding globulin. Everywhere else, a better answer is progesterone, okay? Very, very important. What is the reason for lactational amenorrhea? So remember, prolactin has a negative feedback on GnRH. Yes, and this is why there is going to be no LHFSH. So there will be lactational amenorrhea. Now, the next application is already written here. So we write it as A25 and that is NEET PG ka one of the favorite topics. It is Sheehan syndrome. Please understand, Sheehan's is very specific. It is to be answered when the cause is severe PPH. You cannot answer it anywhere else. So this is necrosis of anterior pituitary alone. Yes. If we ask you what is the most common presentation, the first one is failure of lactation. The second is amenorrhea. Is that understandable? So first most common is failure of lactation. Second is amenorrhea. But if your exams ask which is the first hormone to be affected, then you answer as growth hormone. The symptoms of growth hormone come later, but it declines the first. Is that clear to everyone? Yes? Okay. Then as I said, there are 4 things that I want you to know that estrogen does. So apart from the 2 that I have told you, the third thing where the best answer is estrogen is increase in the levels of thyroid binding globulin. Okay? Super duper important for all exams. When we ask you what happens to total T3 and total T4, what is your answer? It is increased. When we ask you what happens to free T3 and T4, it is no change. So be very careful, okay, whether they're asking you free or total. Yes? What about TSH? Now listen to me again carefully. When we say no change, it is a better answer because what we are trying to say is it remains in the normal range. But what happens in comparison to pre-pregnancy values? There is a slight fall. So if you compare with pre-pregnancy values, there is a fall. But it is still in the normal range. So it is a euthyroid state. Is that clear? Yes? Okay. Then, super important, multiple times asked. Yes? So, drug of choice for hyperthyroidism in first trimester is propylthiouracil. In second and third trimester, it is methimazole. So now you people ask me, ma'am, if both methimazole and carbimazole are in the options, what should you mark? What will you mark? What I have written here in DVT is methimazole. Similarly, aplasia cutis, if both are on the options, what do you mark? Methimazole. Why? I am sure you all know. Do you know that carbimazole is a prodrug? Yes. So eventually it will be converted into methimazole. Okay. Now, coming to next application. Are you all ready? So do you see here, this is the important part. Although we are saying PTU is the drug of choice or methimazole is the drug of choice, do they cross placenta? Yes or no? The answer is yes. So all these drugs cross placenta, and yes, they can cause fetal hypothyroidism or fetal goiter. Is that clear to everyone? Yes? Okay. No, we don't continue with propyl thiouracil. You have to switch to methimazole. It is a better drug. Is that understandable? That is why we have definitive answers. Is that clear? Okay. Then, when we talk about drug of choice for thyroid storm, what will you answer? Can you tell me? Drug of choice for thyroid storm, let's say in pregnancy, or even if they don't say in pregnancy, what is the, yes, PTU also crosses. That's what we are writing here. But it is still the safest one. So that is why it is the drug of choice. Okay. So what is the drug of choice for thyroid storm? Yes. Please do not answer propanolol. No. Do not answer methimazole. You are going to answer it as propyl thiouracil. Bachche, propanolol is only for symptomatic control. No, your concepts are wrong. It is not treating the disorder, right? So it is for symptomatic control. So it is an adjunct. Definitely it is a first line drug, but it is not the drug of choice. Have I made myself clear? Yes? Okay. The next thing, so as I said, estrogen is responsible for 4 things. So far we have done 3. What is the 4th thing that estrogen does? The 4th thing is pigmentation. So all the excess pigmentation that you see in pregnancy, okay? So whether it is cloasma, whether it is linea nigra, the answer is estrogen. Can you tell me the why behind it? Who is going to tell me? So estrogen causes upregulation of melanocytes. So there is more melanin production. Is that clear to everyone? Okay. So that is the mechanism. Then a very specific thing that NEET PG is fond of asking, not INICET, and that is something called as pregnancy tumor. So remember, pregnancy tumor, number 1 thing is not a tumor. Okay, it is a false name. Yes, it's basically granulation tissue. And because it is vascular and irregular, it looks like a tumor. It is also called as pyogenic granuloma. It is also called as granuloma gravidarum. Now, the application I want to ask you is, where would you see this tumor-like growth? Can you tell me? Where would you see? So, because that will be your hint that if this is the site given, it is not actually a tumor. What is the site? So, oral mucosa. In the oral mucosa also, typically we write gingiva or gums. Okay? So, gingiva or gums. Remember, yes, it is going to bleed, but despite the fact no excision is to be done, the management will be conservative. Is that clear? Okay, perfect. Now, once we have done this early pregnancy, we are going to next talk about some very basic things, because I have included this because I don't want that anyone should do this wrong. These are very scoring parts. So you should ensure that just because they were values, you don't forget them and you remember to revise them close to the exam. Are we ready to go? Is it going okay for everyone? The speed is okay for everyone? Are you able to recall your concepts? Are you able to learn the application? I would want a feedback. Yes, because it is a good time that I ask and I can do whatever modifications are required. Are we all good? Okay, so till the time you write your answers, I'm going to proceed on to what basics should we know, which have a very high probability of being asked in the exams. Okay, so if you are good, so am I. So let's go forward now. Okay. Now, when we talk about basics and memory-based things that they are asking, these are the confusing areas and I don't want any confusions. Okay. So please remember, when we talk about extra calories, the latest guidelines are only this. 350 kilocalories is the extra calorie per day and it is typically required in the second and third trimester. If they are specially asking you about the first trimester, okay, then you should say no extra calories. Is that clear? Okay. Then areas which I see some of the students doing wrong. When should you give TD1? So now we prefer TD1. We don't give TT, we give TD. But when should you give TD1? So look, what is the topic? Injection TD1 has to be given at the first antenatal visit. Doubt. Can it be given in the first trimester? The answer is yes. So it has to be given at the first antenatal visit. The second dose has to be given after 4 weeks. Okay. In which condition will you give a booster? So you will give a booster if the pregnancy is within 3 years and it was a fully immunized previous pregnancy. Okay. Then if she is coming to us in the first trimester, what drug are we going to give it? We are going to give 0.4 milligrams of folic acid. Yes, this is when she comes in the first trimester. If she comes to us beyond 12 weeks, we are going to give her a IFA tab. Okay, so we will give her a IFA tab. Yes, TDAP is not the national guideline. That is what they follow in the US. Okay, so TDAP is something they are following in the US. We so far are following TD. Okay. Right, so we are going to give IFA. Everyone should know or remember the constituents of IFA tab. So it is 60 milligrams, not micrograms. Please correct this. It is 60 milligrams of iron and 0.5 milligrams of folic acid. Okay? Then all pregnant women in the second trimester will also receive calcium tab. Okay, so calcium tab hai 500 milligrams and it is given twice a day. All women will also receive albendazole in the second trimester, which is 400 milligram, again a single dose. Yes. So now my question is, how many IFA tabs are to be given? So please remember, when you say prophylaxis, okay, so when you say prophylaxis, it is only 1 tab per day. Okay. But when you talk about treatment of anemia, then how many tabs are you going to give? Batao? So when you talk about treatment of anemia, then we will give 2 tabs per day. Yes. Okay. Then what is the folic acid dose in certain other scenarios? So for example, a woman with previous neural tube defects or a woman on anti-epileptics will receive a high dose of 4 milligrams per day. Now I want to ask you, if you are giving high dose in a woman with previous NTD or anti-epileptics, this high dose has to be given up to what time period? So this is given up to 12 weeks. Beyond 12 weeks, you will again switch to IFA tab. They don't need a higher dose. Chalo. Who is going to tell me what about sickle cell anemia? Do you remember? What is the high dose? Here it is going to be 5 milligrams per day. But what is the difference? This high dose now has to be given throughout pregnancy. Okay. What about folic acid deficiency? Now it is 1 milligram per day and you will give it up till the correction of anemia. Okay. Then you can give prophylactic dose, right, to build the stores. Is that clear to everyone? So these are some very basic things and important things which we should not do wrong. Okay. Then some more basics that are important for your exams. Okay. So now you are going to tell me which investigations are mandatory when it comes to first antenatal visit. So remember, we have to do a blood group, RH typing. HIV has to be offered to all women. What is the screening protocol? So remember, for HIV, we do universal screening and the method is called as opt-out. So you have to write the test for everyone. VDRL is again mandatory. Should we do a 2-hour OGTT at the first antenatal visit? Yes, this is an Indian guideline. Please don't search internet or chat GPT and do your basics wrong. In US, they are not doing it at first antenatal visit. We are doing, and again, this is universal. So 2-hour OGTT is also universal at first antenatal visit. Should we do a urine dipstick? Yes, especially for glucose and proteins. Okay, preferably also for ketones. Yes. Remember, we write HBS antigen for everyone. Okay, but it is not mandatory. But even in government hospitals, we are writing HBS antigen for everyone. Is that clear? Beta, आपने सुना नहीं? I said you will give 1 milligram per day till the correction of anemia. Once you correct anemia, then she does not require the high dose. Okay, so till the time you correct anemia, you will keep giving 1 milligram per day. Okay. Super important, and they are PYQs. Right, so minimum number of antenatal visits, there is no change in this. As per the Government of India, it is 4. As per WHO, it is 8. Can you tell me what is the ideal number of visits? The ideal is around 12 to 14. Yes, so ideal is around 12 to 14. Take next important thing. When we say gravida, some very basic things, but sometimes you do it wrong. Yes, so first thing, when you say gravida, yes, you include the current pregnancy. But when you talk about parity, it is number of completed pregnancies, pregnancies which have an outcome, right? So current pregnancy is not included. Okay. Whenever you count parity, it has to be completed pregnancies beyond viability. What is the period of viability in India? There is no change. It is still 28 weeks. Okay. Please, another very basic mistake that I have seen. When we talk about L, it is the number of currently living children, not live born, right? So please remember, when the examiner is saying there was a stillbirth, what should you know? It will be counted in parity, but it will not be counted in living issue. Is this clear to everyone? Yes? Okay. Also, some very basics that I want you all to know. When we say EDD, it corresponds to how many weeks? कौन बताएगा? 40 weeks. Always calculated from first day of LMP. Only 3 to 4% of pregnancies deliver exactly on EDD. Okay. So, baki either 1 week before or 1 week after. Also, please remember, when we use the universal formula, it is different from the obstetric formula we are using in India. Can you tell me what is T and what is P here? So T is number of completed pregnancies at and beyond 37 weeks. So the T here is number of term deliveries. Okay. The P here is number of completed pregnancies between 20 to 36 weeks, which means number of preterm deliveries. For twins, everything is to be taken as 1 because it is considered as one pregnancy. But what will change? L. If both babies are delivered and they are both alive, the L will become 2. Is that clear to everyone? Also, please remember in T and P, term pregnancies and preterm deliveries, do we include current pregnancy? Yes or no? So, no. Current pregnancy is not included in both of these. Is that clear to everybody? Yes? Perfect. When you calculate EDD, which is what we have written here, I'm sure you all know we use the Negley's formula. But what are the mandatory things for us to know that we can use Negley's formula? It can only be used if the cycles are regular. The calculation is precise only when cycles are 28 days. So they have to be regular cycles. They have to be a 28-day cycle. Yes, is that clear to everyone? Okay, you cannot use Negley's formula for irregular cycles. You cannot use Negley's formula if LMP is not known and if she has conceived using or while she was on OCPs. Right? So these are very, very important. Abhi to maine bola beta, twins mein everything is taken as 1. The parity is also taken as 1 because it is one pregnancy. In parity, you are not counting number of babies. ध्यान से देखो क्या लिखा है. We are writing number of pregnancies, not number of babies. ठीक है? So this is why I decided I must include some basics even in revision. Yes, because these are so important that you can't afford to do these things wrong. Okay? Chalo. So then we move on to the next phase, which is the prenatal management part of the pregnancy. Okay, again super important for all exams. Something or the other is always coming. Yes. Now gestational age assessment is always an MCQ in your exams. Okay. All right, we will talk about it a little later, right? So I have done, how do you do the calculation in IVF pregnancies? Okay. So, you know, sometimes I feel you should go back and do the regular classes because we cannot cover, I'm covering a lot, okay, a lot in DVT. Please remember, when you say IVF, you do not take it as 40 weeks, you take it as 38 weeks. Yes, so can you tell me 38 weeks is how many days? So into 7. So now it is 256 days. So remember, if you are doing a day 3 transfer, okay, so then to know EDD, you will have to add on the date of the day 3 transfer, not 256 days, but 253 days. Okay. If you are doing a day 5 transfer of the embryos, then you will have to add 251 days. Yes. So you know the date of transfer. So when you know the date of transfer, you have to know, is it a day 3 embryo transfer or a day 5 transfer? Yes. So please remember. Yes. Sorry. 266. Just correct it. Okay. So 266 days. So please remember this. Okay. So here you will add 263 and here you will add 261. ठीक, is that clear? Who asked the doubt? A small mathematics mistake. Yes, is that okay for everyone? So at least give me a thumbs up if I've sorted your doubt. Yes, February, it doesn't matter. February is also 28 days except the leap year. So Nagli's formula doesn't take into account the leap year. Okay. All right. Perfect. So now coming back to ultrasound basics. Yes. So as I said, when we talk about gestational age assessment, the most important parameter we have to know is crown rump length. This is what we are going to use. Okay. Now, no, it is not possible. In DVT, it is strictly going to be only what is written, no A's and no extra things. Because this is DVT boot camp, we are giving you ample time. I want to clear basics also. I want to tell you the application part also. So, boot camp is going to be concepts plus application plus content. DVT is a revision mode. So, it will be only the revision of what content we are already giving to you. Okay. Chalo. So yes, we are going to ask you what is the ideal time. So although we can use it up to 14 weeks, the ideal time for doing CRL is 7 to 9 or even 7 to 10 is okay. Yes. Now, please remember this. Beyond 14 weeks, if the patient is coming for the first time beyond 14 weeks, then you can't measure CRL. Then you will have to measure biparietal diameter. Now a very basic concept which my students sometimes do wrong. Suppose she has come in the second trimester. Do you understand what are combined parameters? So combined parameters are HC plus BPD plus AC plus FL. So when you put them together, they will give you a better estimate than BPD alone. Is that clear? But now I have to ask you, is CRL better than this? Yes or not? Is what I want to ask you. Yes. CRL is still better than the combined parameters. Why? Because CRL is done in the first trimester. The accuracy of gestational age is best when it is done in the first trimester. The accuracy of gestational age reduces beyond the first trimester. Yes, very, very important applications because you do these things wrong in the exam when asked in an MCQ format. Is this clear? Will you promise you will not do this wrong now? Okay. Then, please remember first trimester ultrasound, although these days we write it for everyone, okay, but please remember that first trimester ultrasound is not mandatory. Usually done hai. Yes, always. Single best answer is always CRL, provided CRL is done in the first trimester. CRL in the second trimester is not reliable. Okay. So this is not mandatory, but it should always be done if my patient has certain complaints. For example, the first thing, for gestational age, let us say the LMP was not known, as I mentioned previously. Or let me say patient conceived while on OCPs. So in these cases, will I have to do a first trimester ultrasound? Yes. Yes. Because you have to do the gestational age. Second, we are usually offering a first trimester ultrasound to confirm the viability. Whenever you use the word viability, we are looking for cardiac activity. Okay. Whenever my patient is in the first trimester and she has suspicion or we have suspicion of ectopic like pain, or if she comes with bleeding in early pregnancy. So in all these conditions, I have to do a first trimester ultrasound. Then usually we say PV examination in the first trimester is not mandatory. But any time if you feel there is a discrepancy between the size of the uterus and pregnancy dating, you should always do an ultrasound. because now it could either be a molar or a multi-fetal pregnancy. Okay. Also, if it is a multi-fetal pregnancy, what are the other things you want to know? You want to know how many babies, is it twins, is it triplets, and you want to know chorionicity. So the best time for chorionicity is in the first trimester. Do you know when? So chorionicity के लिए the best time is 10 to 14 weeks. Okay, so it is the first trimester. Then whenever you want to do certain procedures like a NT scan, again these days we are doing a NT scan for almost everyone, but it is not mandatory. Yes. Similarly, chorionic villus sampling. Remember, it is an ultrasound guided procedure, so we would need an ultrasound. Okay. Now, generally, do we say first trimester is an anomaly scan? Yes or no? The answer is no. So the exam is going to confuse you. Yes, please remember the only anomaly. What is the full form of GCA? Gross congenital anomaly. So the only anomaly that can be diagnosed in first trimester, you know what you do? You go and answer it as Down syndrome. The first thing, Down's is not an anomaly. Second, it is not diagnosed on ultrasound. It is only screened on ultrasound. So when we ask you only anomaly to be diagnosed in first trimester, the best answer is anencephaly. Okay, sometimes we can look out for even encephalocele, but the single best answer is anencephaly. You can diagnose it as early as 10 to 11 weeks. Okay, so very important, right? Then, screening for Down syndrome. My first question to you is it universal or is it selective? So, now it should be a universal screening. Yes, it is preferred, but it is not mandatory. So, ideally, yes, everyone should undergo a screening, but it is not mandatory. These are very important things to know. Now tell me, what is the best time to do the screening? Is it first trimester or is it second trimester? The best time to do the screening obviously will be which one? Batao? First trimester. The earlier you do the screening, the better it is. Okay. Now we want to ask you, if the best time is first trimester, what are you going to use? So what will you answer? You will answer it as combined test. So currently combined test is the most commonly used method of screening. Okay. What are the components? It includes a dual test and it includes a NT scan. You should know not just first trimester, you should know the time also. So it is done between 11 to 13 weeks. Yes. Then some of the application questions that we are fond of asking you. Suppose you do a NT scan, and we will do the details of NT in a moment. Can you tell me what will you do if it is increased? So should I do karyotyping as I have written here, or should I do NIPT? So please remember, the best answer is karyotyping. So karyotyping is what is preferred. Alternative is NIPT. Okay, so NIPT is only a alternative. Is that clear? Yes? Okay. Now, when I am saying we have to do a karyotyping, what would be the method that I would use in the first trimester? So in first trimester, you can do only one thing, and that is chorionic villus sampling. Okay, chorionic villus sampling. What about quadruple test? Now there is a doubt. Suppose you have done a first trimester screening and that is normal. Okay, let's say it is normal. Should I again do a quadruple screening in the second trimester? Yes or no is what I want to ask you. Batao? The answer is no. If the first trimester screening is normal, you don't need a quad test. So, a quad test is a screening that you will do in the second trimester. So if the patient comes directly in the second trimester, then yes, you can't do dual test or a combined test. So you will do a quad test. Quad test has been a repeated MCQ in your exams. You should not be doing it wrong. What is included in the quad test? So it's HCG, which everyone knows. It is E3, estriol, alpha fetoprotein and inhibin A. Now, repeatedly AIMS is asking this. They give you what is not a part of quad test. Okay, quad test ka except पूछते हैं. Now, there are two problems. One, they will write inhibin B. The other, they will write estradiol. Do you agree both are wrong? Yes, both are wrong. But I cannot mark two answers. Then what should I mark? Please stick to inhibin B. It is more wrong. So it will be a better answer. Is this clear? Yes, they have done it twice. AIMS has done this twice. Is this clear to everyone? Clear? Okay. Now some of the details we need. So remember, when we say dual test, it includes HCG, which is going to be increased, and it includes PAP-A, which is going to be decreased. As I said, the time is 11 to 13 weeks. So it is a maternal serum test. Yes? Nuchal translucency is ideally done between 11 to 13 plus 6 weeks. Okay? You should all remember that the cutoff we use is more than or equal to 3 mm. Yes? Now, what is the first thing you should think if NT is increased? So, sabse pehle you will think of aneuploidy. What is the second thing you will think of? The second thing you have to know is cardiovascular anomalies. Yes? What is the third thing? Maybe it is twin-twin transfusion syndrome. Okay? Now, I want to ask you this. So I will put it as A32. If there is increased NT, yes, which aneuploidy should you mark? Suppose all options are with aneuploidy, which one should you mark? The highest association is with which? It is with trisomy 21 followed by monosomy X. Okay, that is the answer. The third important thing, which is what we have written here. Suppose I ask you, so we will continue this as A32. Suppose there is increased NT, let's say it is 5 mm. But now I am telling you, karyotype is normal. What should I do next? कौन बताएगा? So if karyotype turns out to be normal, what should I do next? So as I said, next you have to think of cardiovascular anomalies. So your answer should be, we will do a level 2 ultrasound and we will do what? Fetal echo. No, why are you still answering it as CVS? I am already giving you karyotype is normal, which means the diagnostic test has been done, right? So now you have to think of cardiovascular anomalies. So you will do a level 2 ultrasound and a fetal echo. Is this clear to everyone? Yes? Perfect. Okay, so the next thing we will talk about is these procedures. Again, they are repeatedly being asked in your exams. So chorionic villus sampling, remember, it can be done any time beyond 10 weeks. Mostly it is done between 11 to 13 weeks. Okay. The examiners are fond of asking the why. Why are you not doing it before 10? So remember, if you do it at less than or equal to 9 weeks, you have to answer it as it will cause limb defects. Okay. Please remember, when it comes to chorionic villus sampling, it gives us the earliest results. Okay. It gives us the earliest results. But please remember, it has a fetal loss rate of around 1%, a post-procedure abortion. Okay. What about second trimester now? So now in the second trimester, we all know we are using the quad test. When do we do it? It can be done any time from 15 to 22 weeks. Very important. But most commonly we do it between 16 to 18. Why is it this important? Because we will ask you, when do you do quad test? So one option will be 15 to 18. Another is 18 to 22. Another option is 22 to 24, and then another is 24 to 28 weeks. So these are the options you have. What will you choose? So you have to go with the concept. The earlier you do the screening, the better it is. Is it clear how to mark the answer when two answers seem more correct? Yes? Okay. Remember, the levels of alpha fetoprotein and UE3 are decreased, but alpha HCG and inhibin A are increased. Okay. Also remember, triple test is not done now, but it is also a test of second trimester. It is also done between 15 to 22 weeks. Yes. So the answer is same even for triple. It does not include what? Inhibin A. Now the answer is inhibin A. The older names for triple test are BART and Kettering. Okay, so BART test and Kettering test. Are you ready for the application? So another one that I want you to know is, suppose you have done a quad test for a patient, and in the quad test we are saying the reverse. HCG is normal and AFP is increased. What will you do next? So remember, this is reverse of what we have taught you right now. Here HCG normal aa raha hai, AFP high aa raha hai. What should you do next? You will answer it as level 2 ultrasound. Can you tell me why? Because when you say high AFP levels, you are suspecting, yes, either neural tube defects or abdominal wall defects. So please remember, raised alpha fetoprotein, think of neural tube or abdominal wall defects. Is this clear for everyone? Perfect. What diagnostic test do we do in second trimester? So in second trimester, as you can see, we will be doing the amniocentesis. Very simple, we do it at and beyond 15. Usually it is done around 16 to 18 weeks. Yes. Now, a very specific thing that AIIMS has been asking in the NESET exams is early amniocentesis. We are not doing it any longer, because if you do early amniocentesis, it has a high fetal loss rate. So we don't do it, but you should know what is early amnio. Also remember, amniocentesis takes time for the results. So it takes around 10 to 14 days for the result, but it is more reliable than chorionic villus sampling, and it is also more safe than chorionic villus sampling. Okay, so the fetal loss rate is less than 0.5%. So it is more safe. Is that clear? What cells do you take out? So remember, in amniocentesis, it is either amniocytes or the fetal dermal fibroblasts, the cells which are shed off from the skin. Can you tell me which cells do you use in chorionic villus sampling? So when you were talking about chorionic villus sampling, what cells? You will answer them as trophoblasts. There we are using trophoblasts for karyotyping. In amniocentesis, it is amniocytes or fibroblasts. ठीक है बच्चा? चलो. Coming to level 2 ultrasound. So when you talk about level 2 ultrasound, please remember it is also called as anomaly scan, and it is also called as TIFA, right? Targeted imaging for fetal anomalies. It is done between 18 to 22 weeks. Yes? Is it done universally? This is what I want to know from you. Yes. Level 2 ultrasound is mandatory, right, for all pregnant women. Okay, so it is mandatory for all pregnant women. So although we call it as an anomaly scan, remember we see other things also in it. For example, we can definitely look at cervical length. Second trimester is the best time for cervical length. We start commenting on amniotic fluid. We start commenting on location of placenta. We start commenting on fetal biometry. Matlab fetal parameters like BPD, like head circumference, abdominal circumference, femur length. So we're commenting on all these things as well. What about fetal echo? So number one question is, what is the time you do it? Again, the answer is 18 to 22. But is it mandatory? The answer is no. It is not mandatory. Okay. It is only and only done for what? High risk women. Can you give me example? Which high risk women? So typical answer should be women with pre-gestational diabetes, especially if it is uncontrolled. Then it is mandatory. Yes, is that clear? Okay. Also, since I am talking about ultrasound, this is the next application that I want you to know. So I want you to now tell me, if we are talking about early pregnancy ultrasound and I am talking about findings, can you tell me the correct sequence? So the first structure that you will see is gestational sac. What is the name of the sign? Intradecidual sign. Gestational sac is seen around 5 weeks. What is the next sign? Double decidual sac sign. Yes, can you tell me what are the two deciduas here? So it is not basalis, it is decidua capsularis and decidua parietalis. Okay. The next one is going to be double bleb sign. What are the two blebs here? So one is going to be yolk sac, the other is going to be amniotic sac. Okay. Now, if we ask you first sign of intrauterine pregnancy on ultrasound, you answer it as gestational sac. But if I ask you the first definitive sign of intrauterine pregnancy, you answer it as yolk sac. Okay, so then you will answer it as yolk sac. At what POG do you see cardiac activity? At around 6 weeks. Remember, these are values for transvaginal ultrasound. In transabdominal, all findings will be seen 1 week later. Okay, so all findings will be seen 1 week later. Are we clear with this? Okay. The next very important thing that we should know, which we were also doing in the first antenatal visit, whenever that is screening for diabetes. So we have already told you it is a universal screening. What is the name of the test? 2-hour OGTT. Your exams are asking even basics like, what glucose are you going to give? So don't get confused. It is 75 grams of oral glucose, right? Please remember it is done at the first antenatal visit. Yes. Now I want to ask you, when you talk about DIPSI, do we need fasting here? The answer is no. So please remember, fasting is not mandatory. Okay, it is not mandatory. Yes. If the test is normal, we will repeat the test between 24 to 28 weeks. The minimum gap between two tests should be 4 weeks. Okay. Remember, if the patient comes beyond 24 weeks, which means her first antenatal checkup is beyond 24 weeks, then you will do the test only once, not twice. If the value turns out to be more than 140, it is labeled as GDM. If the value is more than 200, it is labeled as overt. Yes, please remember these are the guidelines that we are following in India. These are our national guidelines. We are no longer following IAP DSG. Earlier we were following the IAP DSG, but now no. Now it's DIPSI. For INICET, in case they ask you IAP DSG, it is still 75 grams. It is still 2-hour OGTT. But what is the difference? We need the patient to be fasting. We don't take one sample, we take 3 samples. So fasting sample, a 1-hour sample and a 2-hour sample. Can you tell me what are the cutoffs? So 92, 180 and 153. Okay. And how do we decide? We say even if one of these values is beyond cutoff, then you will label her as GDM. Okay. So even if one, we have 3 values. Out of 3, even if one is beyond the cutoff, you're going to label it as GDM. Yes, is this clear? So these are things that you should know about normal aspects of early pregnancy. Are we good with this part? So now we are going to move on to complications in early pregnancy. So far so good. Please give me a thumbs up if you are all okay. Yes? All right. So now when we talk about complications in early pregnancy, the first one that we are going to talk about is abortions. Important topic. We are getting it in the exams. We should know what we have to mark. Okay. Now, NEET PG is specially asking a lot of questions with respect to definitions. So you have to be very sure you know them well, right? For example, by definition, we use a pregnancy loss before 20 weeks. But there is another definition that WHO has given, which we don't commonly use. So you will answer that only when asked. Okay. Abortion is where the conceptus weighs less than 500 grams. Okay. Now, whenever we talk about abortions and if we are talking about early pregnancy losses. Do you know what is early pregnancy? Early pregnancy हम जब भी बोलते हैं, it means we are talking about first trimester or first 12 weeks. So whenever we say early pregnancy and we are asking you the cause, it is going to be chromosomal anomalies, right? Is the answer true even for RPL? Yes or no? Yes. Suppose we ask you most common cause of RPL in first trimester. What will you answer? You will still answer it as chromosomal anomalies. Very, very important. Okay. Please remember, cervical insufficiency never ever presents as first trimester RPL. Okay. So if we are saying first trimester RPL, don't mark the answer cervical insufficiency. It is classically second trimester. It has to be more than or equal to 3 losses, and the key word has to be painless. Usually abortions will have pain because the uterus contracts to expel it. Here it is going to be painless. Okay, is that clear? Okay. Now let us expand what we have done in the first slide. For example, I told you chromosomal anomalies are most common. Yes? So now what exactly in the chromosomal abnormalities is the cause? So usually these are trisomies. Okay? And among trisomies, please remember the single most common is monosomy X followed by trisomy 16. Okay? So please remember, trisomies is a big group. It includes everything. So within trisomies, if you have to answer single answer, then it is not Downs. I don't know. You go and mark Downs everywhere. So no, it is not Down syndrome then. You have to answer it as monosomy X. In fact, do you know Down is the most viable trisomy? Okay. Then, as I mentioned previously, even when we ask you about RPL and we are asking first trimester, you will stick to chromosomal. Please remember, Mullerian anomalies characteristically cause second trimester losses. So when you talk about uterine abnormalities, so whether it is Mullerian or cervical incompetence, second trimester RPL is more common than first trimester. They can cause first trimester, but not more common. More common is second trimester. Okay. As I said, typically when we mention second trimester, that's when we want you to think of Mullerian abnormalities, or rather as a group, uterine abnormalities. Uterine, as I said, could be acquired like cervical incompetence, could be congenital like Mullerian. Now you get confused. You tell me that, madam, both were in the options. What should you mark? What is the answer? Cervical incompetence is much more common than septate uterus. Is that clear to everyone? Yes? Okay. Similarly, you keep asking me about APLA. So you have to listen to me very carefully to ensure we are not doing some easy things incorrectly. Okay. Now, APLA may, we still need the same things. What? We need a clinical criteria and we need a lab criteria. Yes. Now, the clinical criteria can be any of these. There are so many things, but it could be any one. For example, the woman may have history of thrombotic episodes. Yes. Then the woman may have pregnancy complications. Now, this has what was recently updated. What is the update? Number 1, if it is a fetal death beyond 16 weeks, beyond or equal to, then even if there is one fetal death, I should start thinking of APLA. If there was a miscarriage up to 15 weeks, then I need at least 3 to think of APLA. Is that understandable? So beyond 16, even one loss, I have to think of APLA. Up to 15 weeks, I need at least 3 losses, and then I start thinking, oh, this can be APLA. Earlier, this cutoff was what? It was 10 weeks. So earlier, the guideline said up till 10, we need 3 losses. Beyond 10, we need 1. Now the cutoff has been made 15. So up to 15, 3, and beyond 15, 1. Is this clear? Give me a thumbs up, everyone. Okay. Now, please listen to me very carefully. Yes, Apart from abortions, what else can APLA do? Whatever I have written in red is like super important. So remember, APLA can also cause severe preeclampsia and uteroplacental insufficiency. What will happen if we are talking about UPI? So if you remember, uteroplacental insufficiency is what was the pathophysiology in preeclampsia. And because of this, the baby will become small and we might have to do a preterm delivery. Yes, so now the take-home message is what? The take-home message is, when your exams give you a combination like, what was the application number? Okay. Okay, so if your exams give you a combination like a woman had a combination of these problems, abortions, and in the next pregnancy she had preeclampsia, what should you think of? So if you see a combination like abortions and preeclampsia, or abortions and UPI, which could be in the form of IUGR, which could be in the form of preterm delivery. Whenever you see this combination, please think of APLA. And especially NEET PG is fond of asking this concept. You do not think of syphilis here. No. So when we are giving you combinations like abortions early, and then in later pregnancies there is preeclampsia or there is UPI, you have to think of APLA. Is this clear? Okay. Apart from the clinical criteria, APLA may we also need lab criteria. So what are the lab criteria we need? In the lab criteria, we need antibodies. You should remember the name. So there is lupus anticoagulant and there is anti-cardiolipin antibodies. For lupus anticoagulant, what test can we do? APTT is a common test, but you should know the Russell Viper venom test name. You should just know the name. For anti-cardiolipin and anti-beta-2 glycoprotein 1 antibodies, we look for IgG and IgM antibodies. So that is what we test. As I said, please remember we need one clinical, one lab criteria. This is what is called as modified Sydney or Sapporo criteria. Is this clear? INICET is fond of asking the names, especially if you have named criteria. That is a typical place INICET asks. So you should know the modified Sydney or Sapporo criteria are for APLA. Okay. Now listen to me very carefully. If you are asked in general treatment for APLA in pregnancy, your answer should be a combination. Low molecular weight heparin plus aspirin. But suppose INICET or NEET PG goes into more extreme. Yes, and they ask you this application. What? They are saying your patient has APLA. There are no history of abortions and no history of thrombosis. There has only been one preterm labor because of severe preeclampsia. So she has these findings. Now what will you give her? So now when they are typically saying that there was no abortions or thrombosis, then these patients do not need heparin. In this case, the answer will change to only aspirin. If no details are given, then you mark both. You mark low molecular weight heparin, you also mark aspirin. Is that clear? Please give me a thumbs up if it is clear. These drugs are started as soon as pregnancy is confirmed. Yes, is this clear? So as soon the pregnancy is confirmed, you will start the drugs and you give them throughout pregnancy. Yes? Okay. Yes. बेटा recurrent PTL खाली नहीं है. Preterm labor because of preeclampsia या UPI. Then we are talking about aspirin. See, preterm labor can be because of many causes. If the cause of preterm labor was uteroplacental insufficiency, then aspirin. No need of heparin. Okay? Alright. The other topic that your exams are asking is cervical insufficiency. Yes, now we will talk about these names in a moment, but before the names, this is what you need to know. We need more than or equal to 3 consecutive losses. They have to be painless. They have to be in the second trimester. Okay. Suppose your patient has, so this is the next application that I'm going to ask you. Suppose your patient has 2 recurrent pregnancy losses in second trimester and they were painless. Then what do? Then in this case, to make a diagnosis, you will have to do a ultrasound because it's not 3, it's only 2 as of now. So now you have to do an ultrasound and measure the cervical length. The cutoff is repeatedly asked. I'm sure everyone remembers. So if it is less than 21, you will have to put a cerclage. Yes. Remember, most commonly the cerclage that we put is actually McDonald's. And the ideal time to put it is 12 to 14 weeks. Yes. Is that clear to everyone? Okay. Your exams are also fond of asking when you will not put a cerclage. So please, this part is very important. Any MCQ which says your patient has ruptured membranes or your patient has uterine contractions, never put a cerclage. These are absolute contraindications. Apart from these, current pelvic infection and gross anomalies like anencephaly is also going to be a absolute contraindication. So you have to pay very close attention to what the MCQ is giving. Okay. Also, when do you remove the cerclage? So ideal time is 12 to 14, but 2 questions that I feel my students keep asking me. So I'll still keep it as application 38. What is the upper limit to put the cerclage, bache? General answer will remain as 24 weeks. So the upper limit to put the cerclage is 24. You will remove the cerclage at 37 weeks. Sometimes you may have to remove it early, especially, if membranes rupture or she goes into labor. Otherwise, you will remove at 37 weeks. Okay. Now coming to the names. So this is more for NESET rather than NEET PG. So listen to me carefully. When you have to put the cerclage in pregnancy, the most common we put is McDonald's, but we have 2 more options. One is Shirodkar's, one is worm stitch. Worm is put when it is an emergency. Shirodkar is put when McDonald's fails. So अगर McDonald's fail हो जाएगा and she is pregnant again, next time I will put Shirodkar's. Is that clear? Please give me a thumbs up if this part is clear. Okay. So please remember, right? Also please remember when we say Shirodkar, these days we do modified Shirodkar. Okay. It is still a vaginal surgery. Okay. We do minimum, okay, minimum bladder dissection. We don't use a suture here, we use a tape. Now remember, if we show you an image and the image is like a diamond, right, then it is the purse string suture or McDonald's. if we are giving you an image and you don't understand anything, but after application of the cerclage, it gives a circular image, then it is modified Shirokers. Okay. So this is what we do. As I said, a worm is emergency cerclage. Who is going to tell me what do you understand by emergency cerclage? What is the meaning? When you say emergency cerclage, it means cervix is already fully dilated, but membranes are intact. Can the membranes be bulging? Yes, the membranes can be bulging, but they are still intact. Is that clear to everyone? Yes. Also remember, a T-shaped appearance on ultrasound means a competent cervix, whereas a U-shape on ultrasound indicates incompetent cervix. Okay, so those are the things that they could also ask. They're one-liners. Sometimes you just forget, so you should not forget. Okay. Coming to surgeries that we can do in the non-pregnant women. Lash and Benson are old surgeries. Nowadays, if she is not pregnant and we are doing a surgery for her for incompetence, we will prefer which one? Laparoscopy. So please remember, treatment of choice in non-pregnant women now is laparoscopic cerclage. Remember, lash is an older surgery and it was a vaginal surgery. So vaginal surgeries are not very effective. So nowadays we can do lap surgeries which are very, very effective. Is that clear to everybody? Yes? Okay. So those are important things that you should definitely know about cervical incompetence. Let's move further and let's talk about these clinical entities now. Now, these are very simple questions. You only have to focus on keywords and you have to know how to use them. Because she had history of cervical incompetence, beta. Okay, so let's say she's already had 3 abortions. Do you want that she should get pregnant and become high risk and then you would operate? No. So if she is already a diagnosed case of cerclage and previous surgeries have failed, you want to treat her before she becomes pregnant again. थोड़ा सा common sense हमें लगाना पड़ेगा बच्चे. Okay? चलो. So now all abortions are generally going to come with these complaints. What are the common complaints? The common complaints are, okay, pain, amenorrhea and bleeding. Yes, what they have written after that becomes more important. Yes. So first focus has to be whether the os is closed or the os is open. If the os is closed, we have 3 probabilities. It could be missed, threatened or complete abortion. If the os is open, we have 2 probabilities, incomplete and inevitable. When we say os is closed, your next focus should be what have they written about, history of expulsion of products. Okay, we will take a break at 1:30. Don't worry, I've planned it so that you have breaks in between. So now let's look at this. So if there is history of expulsion of POCs, the answer automatically becomes complete abortion. If there is no history of expulsion, so if there is no history of expulsion, then it could either be a missed abortion or it could be a threatened abortion. How will you differentiate between missed and threatened? In missed abortion, the cardiac activity is going to be absent. Yes, so if it is absent, it is missed. If the cardiac activity is present, then it is threatened. Now, sometimes they may not mention about cardiac activity. Then you focus on size of the uterus. If the size is smaller, then it is a missed abortion, which means the baby has stopped to grow. If the size of the uterus is corresponding, then you answer it as, threatened abortion. Okay. So then you answer it as threatened abortion. Who is going to tell me why size is smaller in a complete abortion? Because all products are expelled. So because all products are expelled, the uterus contracts and becomes smaller. Now, when the os is open, how do you decide whether it is inevitable or incomplete? If there is no expulsion of products, then it is inevitable. If there is expulsion of products, then it is incomplete. Now again, sometimes they may not talk about, expulsion ho chuka hai ya nahi hua in a direct way. They may write it in an indirect way. What is an indirect way? If it is incomplete, you will see products in cervical canal, which means the process has started. If there is no expulsion, you will see products in uterus. Okay, so then you will see the products in the uterus. Is it clear to everyone? And hope you will not make mistake in this part. All right. So next we move on to what we should know about MTP. Again, a very commonly asked topic and not difficult, but yes, it's more memory based topic, right? But some important things that I see you people doing wrong in the exams. For example, the most important thing is, in the first trimester, what do we prefer, medical or surgical methods? Obviously, we prefer medical. So MMA is medical outpatient abortion, okay, and it is allowed up to 9 weeks. So up to 9 weeks, our preference is what? Our preference is medical method, okay. Once you go beyond 9 weeks, so beyond 9 and up to 12, our preference becomes suction and evacuation. Yes. Now, when you talk about outpatient abortion, you should know the dose, route, and the name of the drugs. So, mifepristone, also called as RU486, 200 milligrams oral. After 48 hours, it will be Mizo, and now it's just only one dose of Mizo, which is 800 micrograms, but the route can be any, okay? Buccal, oral, sublingual, or vaginal. Can you tell me what is the most commonly used route? So most commonly used route is oral because it is very effective, okay? You can change the route, but you don't change the dose. Yes? Now in suction and evacuation, we use the Carman's cannula, right? The MCQ that they will ask you is size of the cannula. So it should correspond to the size of the uterus. If size of the uterus is not given, then we take it as the size of POG, okay? What about MVA? So remember, manual vacuum aspiration, it is an alternative to what? To suction evacuation. We typically use it when we don't have electricity. Okay? So MVA में again the concepts remain the same. It is done up to 12 weeks. Should we use a Carman's cannula? Yes, we are again using MVA के साथ a Carman's cannula, right? As I said, there is no need of electric current. The size is often asked in the exam, so it is 60 cc syringe now. The pressure may be asked. So if 660 is in the options, you mark that. Otherwise, you stick to 600 millimeters of mercury. Some students get confused with DNC. Can you tell me what should you know about DNC? So remember, it was an older method of surgical abortion in the first trimester. It's not used now. Can you tell me why not? What is the problem? So if a lady undergoes multiple DNCs, she can develop Asherman's. So now we are not using DNC, but it was a method of first trimester abortion. Okay. In the second trimester, now the new guidelines say we can do MTP up to, so we have the modification in the MTP Act. So now we say it is done up to 24 weeks. Yes, but it is allowed up to 24 weeks only and only in certain cases, like in rape victims. What about contraceptive failure? Who is going to tell me? If the pregnancy is because of contraceptive failure, then it is only allowed up to 20 weeks, not 24. Okay? Then yes, consent of only the patient. But what is the rider? Who is going to tell me the rider? Yes, what is the rider here? The rider here is provided she is a major, right? So please remember, if your patient is minor, which means less than 18 years, whose consent will you take? Then you have to take legal guardian. Okay? If your patient is mentally unstable, then it is legal guardian. Okay? Also, please remember, is there a lower cutoff as well? No. There is no lower limit for MTP. So can a 10-year-old girl undergo MTP? Yes, she can. Okay, so we can even do MTP for a 10-year-old, provided we have the consent. For pregnancies which are beyond 24 weeks, then we are allowed to do MTP only and only for a anomaly, gross congenital anomaly. That is what is, important. And there also we need approval from the medical board, right, which is made up by an obstetrician, a radiologist, and a pediatrician. We don't need a lawyer. Okay, we are good to do this. Yes. Again, when you talk about second trimester methods, the most commonly used method remains as drugs, medical methods, and among drugs also we generally use misoprost. Remember, it is a PGE1 and it is the only prostaglandin that we are using and is available as a tablet. Yes, you can remember it as CT family. That's how I generally teach. Yes, so it is available as a tablet. Dose has not been asked so far, but it has already been asked in the FMG exams and your board is same. So it may come in your exam as well. So 400 micrograms every 4 hourly for a maximum of 5 doses. Is that clear? Any set has asked about these other drugs. So remember, we can use a drug which is called as ethacridine. It starts with E, so it is put extra amniotic. Hyperosmolar saline is put intraamniotic. Oxytocin can be used but is least preferred. Okay. Can you tell me why for oxytocin we have written least preferred? What would be the why? Because this early in pregnancy, the uterus will not have the receptors. So it is the least preferred method. Okay. Can we use other prostaglandins? Yes. In the second trimester, we can even use other prostaglandins, not in the first. Okay. We can use PGE2, we can use PGF2. Can you tell me what is the name of E2 and what is the name of F2? Because you do this wrong in NEET PG sometimes. So E2 is called as dinoprostone. It has a ONE1 in the end. F2 is called as dinoprost, which is same as carboprost. So don't do these mistakes in your exam. Is that clear? Yes. Then the surgical method we use in the second trimester is D and E. It's not D and C. There is a difference. This is dilatation and evacuation. You're not doing a curettage here. You are using a ovum forceps. Okay, I also want to ask you in application 40 itself, can we use methotrexate and can we use mifepristone? No. So in second trimester, we are not allowed to use mifepristone as per the Indian guidelines. So this is not called as MMA. Okay. MMA is a very specific word where we are using a combination of mifi and miso. It is only allowed up till 9 weeks. Is that clear to everyone? Yes? All right. So this is what you should know about abortions, right? So although I had planned a break at 1:30, but I think we can take it right now. So should we take a lunch break? And then it will be a half an hour break. Is that okay? And we will start at 1:45, right? So we'll come back and we will go further. I hope you're finding it effective for your revisions. Yes? Please do let me know. So we have tried to make the content super effective, especially for boot camp. Yes, we are also focusing on some concepts and some more extra points that you should revise so that you don't have to go back to your main notes again and again. Yes, so this becomes your resource for last 2 months. You don't need to do anything else. Perfect. So we will restart at 1:45. Okay. Hanji, is everyone back? Okay, so I give you a little more time so that you can relax after your meal as well. So now, will you be able to focus for next 2 hours? Can I ask that? Yes. So I want your undivided attention the next 2 hours. Yes. Okay. Chalo. Yes, because some students were asking for a 40-minute break, so I thought of listening to everyone. Yes. So everyone is important. If you need a little time, I should give you that. Theek? Chalo. So now, next 2 hours, focus. Let's try and learn and let's do it the best way. Okay? Chalo. So now we are going to talk about another very important topic. Usually in NEET PG, the exams are coming from management part. And in INICET, the questions are coming from diagnostic part. Okay. So remember, any question where the patient is in early pregnancy, I told you early pregnancy means first trimester. Yes. So if your patient is in early pregnancy and she is coming with pain, amenorrhea and bleeding. Okay. So if you have these 3 things, you have to think of ectopic. It has to be a probability. Remember, out of this, the order in which I have written it is the order of importance. So most common symptom is pain. Bleeding is mild or major. So please remember, vaginal bleeding is minimal in case of ectopic pregnancy. It is not an abortion where the bleeding is going to be more. Okay. Now, remember, when I said questions come on diagnostic part, this is what we want you to know. Suppose I ask you what finding on ultrasound is diagnostic of ectopic, right? The word here is diagnostic. Then you have to know that we should see a extra uterine sac, and this sac should also show us an embryo or a yolk sac, right? It may have cardiac activity, it may not have cardiac activity, but the sac should have an embryo. Okay, so this is what is diagnostic. On the other hand, if you see no intrauterine pregnancy and extrauterine also, you are not seeing a sac, but you are seeing a complex adnexal mass. So complex matlab solid bhi hai and cystic components are also there. Then, whenever we see a complex mass, we always are going to put Doppler on it, right? So what is the probability that we could see? We could see the ring of fire sign. Now please remember these 3 things that I have written here. No intrauterine pregnancy, complex mass and ring of fire sign. I want to ask you, are they diagnostic of ectopic? The answer is no. So these points that I have written as 1, 2 and 3. So 1, 2 and 3, they are only suggestive of ectopic. They are not diagnostic. So when the findings are suggestive of ectopic and the examiner asks you next step, right? What will you answer? Yes, you will answer serial beta HCG follow up, right? So we have to do serial follow-ups. What is the critical value we use? So remember, for vaginal ultrasound, which we do more commonly, it is 2000 international units. For abdominal ultrasound, which we use less commonly, we are going to use the cutoff as 6500. Okay. Now, please remember the named signs are sometimes asked in any set. So, as I said, ring of fire sign is suggestive of ectopic. Okay. Yes, because it can be seen in corpus luteum as well. Okay. Similarly, there is another sign which is called as tubal ring sign or bagel sign. You should know these named signs. They are markers of ectopic. Again, only suggestive, not diagnostic. Okay. Now, suppose you do the HCG, which was the next step, and let's say the HCG turns out to be less than 2000. This is a typical NEET PG MCQ. So you have findings suggestive of ectopic, okay, and the value is less than 2000. So what should you do? So this is, as I said, this has been a PYQ with NEET PG as well. So then your answer should be repeat HCG after 48 hours. Now you are going to tell me the applied part. Which A was it? Anybody can remember? 40 ho chuka hai. Okay. So A41. Remember, if the value comes out to be as a falling value, then it is a marker of non-viable pregnancy. Okay. If the value is increasing, but it is a slow increase, then it is suggestive of ectopic. Whereas if the value increases and it shows doubling, the minimum requirement for doubling is 33%. You know, the minimum requirement is 33. So if it shows doubling, then it is a intrauterine pregnancy. So you should know the follow-up as well. Now, once we have made a diagnosis of ectopic, we are in NEET PG specifically getting questions on management part. So please remember, when no detail is given to us, then our preferred management is always medical. So you have to know that in general, the preferred management is medical. But in order to do the medical management, I need these things to be met, and these are mandatory. Okay, so these are mandatory things. They are not that I preferably want them. So we want, what do we want? We want the patient to be hemodynamically stable. Yes, what else? We want that it should be a unruptured ectopic. That is very important. The sac size should be less than 5 centimeters. Okay. So sac size should be less than 5. HCG should be less than 5000 and cardiac activity should be absent. Now please remember, if in your MCQ any of the findings are not matching this, the answer will change. For example, if they have written unstable, the answer changes to surgery. If they have written ruptured, surgery. If it is more than 4 centimeters, surgery. If HCG is more than 5000, surgery. Anytime your MCQ says cardiac activity is present or family is complete. Yes, as I said, I want all the criteria to be met for medical management. Even if one criteria is not met, the answer will change. Yes, the others may meet. But if out of 5, 1 is not meeting, the answer will still change. Is that clear to everyone? Yes? Okay. Your exams have been asking the details of the management as well. For example, no doubt the drug of choice is methotrexate. Should I know the dose? Yes. Okay. So it is 1 milligram per kg. It is an intramuscular injection and we give a single dose regime. There's another way how we write the dose in terms of surface area, and that is 50 milligrams per meter square. But in India, we are usually using what? We are using more the dosing schedule of 1 milligram per kg. Okay. Now listen to me very carefully. I have decided I have to do a surgical management, but which surgical management will be the confusing point now? Okay. Remember this. If it is an unruptured ectopic, yes, then generally the answer has to be salpingostomy. You will be repeatedly asked when to do a jectomy. This is where they are confusing you. So now listen to me very carefully. As I said, anything more than or equal to 4 centimeters is surgical management, but which surgery depends on the sac size. If the sac size is bigger than 5, I should not be doing a ostomy. I should be doing a jectomy. Similarly, if it is a ruptured ectopic, I should not do a ostomy. It has to be a jectomy. If vitals are unstable, again, jectomy. Family complete, again, jectomy. So is this clear? Now is your doubt solved? As I said, hold on. All your doubts will be answered as we keep going forward. Is it good now? So you have to be very clear on, ye to decide kar liya that we will do a surgery, but now we have to decide which surgery. So you have to know when to answer ostomy, when to answer jectomy. Quickly give me a thumbs up if this is clear. Then both NEET PG and NESET are very fond of asking the named signs of other ectopic pregnancy diagnostic criteria. For example, for cervical ectopic, okay, we have to use now the Palman's criteria, but earlier we used to use Rubin criteria. Yes. For ovarian ectopic, which has been asked in NEET PG exam twice, okay, it is the Spiegelberg criteria. It has also been asked in NESET. For abdominal, it is Studiford. Now, knowing these names is the bare minimal requirement. In NEET PG, they are also going beyond the names. For example, I have given this to you here because I don't want you to fetch answers from here and there and then learn up wrong things. Okay? Please remember, in these Spiegelberg criteria, which are for ovarian ectopic, please remember the fallopian tube on the side of the ectopic should be intact. Okay? The gestational sac must be in the position of the ovary because it is ovarian ectopic. Because it is an ovarian ectopic and ovary is attached to uterus, obviously the pregnancy will also be attached to the uterus, but which will be the ligament? It will be attached to the uterus by ovarian ligament, not the round ligament. That is how they trap you in NEET PG with the options. Options are very close, right? When you remove the ectopic pregnancy, obviously you will send it for histopath. What will you see? So in the sac, the sac that you have removed, you will see ovarian tissue in the wall of the sac. So these are Spiegelberg. Similarly, in Studiford criteria, which are for abdominal ectopic, the fallopian tube and ovaries have to be normal. There should be no fistula between the uterus and the peritoneal cavity. Yes. And the sac has to be exclusively attached to the peritoneum. So those are the Studiford criteria. So you must remember these. So yes, ectopic is an important topic. Now also, because I am talking about NESET and they have been asking about, as I said, they have been asking about the diagnostic part. So I'm going to ask you something else with respect to diagnostic part, and I'm going to put it here as A42. So now I want to ask you, can we use serum progesterone levels for ectopic pregnancy? Yes, but be very careful. When we say serum progesterone is more than or equal to 25 nanograms, it is a marker of live and intrauterine pregnancy. When you say it is less than 5, then the problem is it could be abortion or it could be ectopic. So is serum progesterone diagnostic for ectopic? The answer is no. Can it be used? Yes, but it can only give us a hint. It is not diagnostic of ectopic. Is this clear to everybody? Yes. Another application, so I will still keep it as A42 because the topic is same. I want to ask you, for what purpose do we use chaldosynthesis? Can you tell me? So remember, in chaldosynthesis, we are doing what? We are doing aspiration from the pouch of Douglas. Yes, so we are doing it from the pouch of Douglas, and this is typically done for ruptured ectopic. Yes, you are right, because serum progesterone doesn't help us to decide whether it is ectopic or not. It is not usually done, right? It is not a useful investigation. Yes. So now I want to ask you, number one, which fornix will you pierce when you are doing chaldosynthesis? Posterior fornix. What would be the finding that you will say it is ruptured ectopic? So on chaldosynthesis, you will find unclotted blood. So if you get unclotted blood, then yes, the answer is ruptured ectopic. Okay. Somebody was saying, can you explain the last line? So we said, beta, the pregnancy should be early enough because majority of abdominal pregnancies are not primary abdominal ectopics. They are secondary pregnancies, which means they were initially at some other site and then they have come into the abdomen. So then it is not primary abdominal. When you say Studiford criteria, we are using it to diagnose primary abdominal, which means the pregnancy was in the abdomen right from the beginning. So that is why it should be diagnosed early enough. Suppose you pick up an abdominal pregnancy in third trimester. Can you be sure whether it is primary abdominal or secondary? No, in fact, most of these are actually secondary abdominal. Okay. Chalo. The next super duper important topic, okay, that we must know and is always asked in the exam is antepartum hemorrhage. Okay. So please remember, whenever you talk about antepartum hemorrhage, there are four things that should come to your mind. One is abruption, one is placenta previa, one is vasa previa, one is rupture uterus. The order in which you have to think about them is the order in which I have said. So what I always do is I teach abruption first, because what I say is if you know abruption, you know all others. They are just opposite of abruption. So we will do the same here. We'll try and talk about abruption first. Yes. Do you know it is more common than placenta previa? Yes. So APH में abruption is more common than placenta previa. What are the keywords that will be written in the MCQ? Because NEET PG is usually asking a clinical question where you have to first make a diagnosis that it is abruption. So the main complaint of the patient will not be pain. That is a very common mistake you students do. Please remember, the main complaint or main presentation is hemorrhage. Okay, so bleeding is required, right? Please remember, this is altered dark colored bleeding. It is never a fresh bleeding. Why? Because it is retained in the uterus for some time and then it comes out. Yes, pain is an important keyword which helps it differentiate from placenta previa. So usually there is pain. What is the reason for pain? Anybody who can tell me? The reason is tissue thromboplastin. So it causes, the uterus to become tonic, and that is what is causing the pain. Then it is a tense uterus. As I said, the reason again is tissue thromboplastin. Yes, it is a tender uterus. And very importantly, the fundal height is more. Why? Because majority of times the abruption is a mixed type of abruption, which means some amount of bleeding is revealed and some bleeding is concealed. So some blood clots are there in the uterus as well. Now remember that if the uterus is tense, will the parts be easy to feel or difficult to feel? They will be difficult to feel. Is that clear? Yes. Then, as I said, the nomenclature is important for any set. So the named classification is PAIDS classification. You should know the name of this classification. Okay, so it is a PAIDS classification. And what are you supposed to know when it comes to abruption? Some very important things. Now, please remember, overall, when we ask you what is the preferred mode of delivery, so once you say abruption, the management is delivery. We usually do not do a conservative management. So you will be asked about the mode of delivery. So generally, the preferred management is vaginal. Okay, so the preferred route of delivery for abruption is vaginal. So whether they write FHR normal, whether they write IUD. So these are two extreme conditions. Even in normal FHR, my delivery mode is vaginal, and even with IUD, my delivery mode remains as vaginal. Even if they write DIC, my preferred mode will remain as vaginal. So which means you should know when to change the answer to cesarean. You will change the answer to cesarean only if they write number 1, mother is hemodynamically unstable. Number 2, the baby is not dead, but there is fetal distress. Number 3, the patient is far from term and she is not in labor. Now, what do you understand far from term? Less than 32 weeks. So if she is less than 32 weeks, right, she is far from term, it is abruption, I have to deliver her, but do you think she will go into labor? No, the cervix will not respond. Then to save the mother and the baby, I might have to do a cesarean. So is this part clear to everyone? Please give me a thumbs up because it's a very important concept. Otherwise, you keep asking me the same questions again and again and you keep doing the questions wrong. Okay. Now, ma'am, can we ever do conservative management? So the general answer for abruption is delivery. We do not do conservative. Very rarely we will do conservative management. Only when we are saying patient is far from term, she has to be stable, the baby has to be stable, the bleeding should be minimum, there should be no DIC. So, no complications as well. So, if everything looks okay, then yes, you can still think of conservative management. Otherwise, generally the answer for abruption is delivery. Yes, and that is why when we talk about abruption, if she is already in labor, should you give tocolytics? Yes or no? No, because I have to deliver her. Why will I give tocolytics? So now let me see if you can answer this question. So I will go on to application number 43 and let's see if you can answer this question for me. So I am saying your patient is a case of abruption. There is an IUD baby. Let's say she is in DIC. She is 5 centimeters dilated. What should you do next? Can you tell me? Tell me. So, should you do conservative management? No. It's already a dead baby. She is in DIC. It is severe abruption. There is no role of conservative management. Should I do a cesarean section? No. So I have to deliver her. But now my question to you, you are saying vaginal delivery. It is okay. But let me confuse you further. Let me say option A, or rather option C is, let's say, wait and watch. And option D is do ARM. Option A is do cesarean. Option B is do induction of labor. Can you tell me now what is the answer? So I have made it like an MCQ for you now. She is abruption, she is in IUD and DIC. What do you want to do next? Should I do cesarean? No. Should I do induction of labor? No, she is already in labor. How will you induce labor? You do induction when someone is not in labor. Should I do wait and watch? No. No. She is severe abruption. She is already in DIC. You have to make the process go faster. Yes, the answer will be D. Are the concepts clear for everyone now? Chalo, very good. Then, as I said, abruption में DIC is very, very common. In fact, this is the one-liner you need to know. The one-liner is, what is the most common cause of DIC in obstetrics? What will you answer? What is the most common cause of DIC in obstetrics? The answer is abruption. Okay, so it is very commonly seen. Why? If they ask you why, the reason is tissue thromboplastin. Do you know where it comes from? It comes from the decidua. So placenta has separated and the decidua will release tissue thromboplastin. Okay. Then with abruption, we are fond of asking you an entity called as cubular uterus. You will see all these images. We have a special session on images as well, which we will do on the last day of Obs and Gynae, right? So cubular uterus, first important thing, how do you identify? It appears as if the uterus has bruises. So reddish blue discoloration. That is how you identify it. Why is there a discoloration? Blood has entered the myometrium. What is the other name for this? Sometimes they will ask you, where do you see this? And there is no option like abruption. Then what are you going to mark? You are going to mark uteroplacental apoplexy. Okay, is that clear? Now, please remember, cubular uterus is definitely a risk factor for PPH, but please remember, it is not an indication for hysterectomy. You manage PPH, but don't straight away proceed to hysterectomy. Okay. Now, once you know abruption, knowing placenta previa is easy because, as I said, it's the reverse. So what are the things that we need to know here? So keywords. Let's first see what keywords will we use if we have to talk about placenta previa. Number one, again the main complaint is bleeding like abruption. But the bleeding here is red or fresh. It's not an altered bleeding. The bleeding is typically painless. It is causeless. So there is no underlying risk factor majority of times. Can you tell me, so I'll keep it as A43 because it's still about abruption. Can you tell me what is a very important risk factor for abruption? Anyone? Preeclampsia. Generally, when they have to tell you about abruption, they will start with that patient was a known case of preeclampsia. Okay. Similarly, in placenta previa, if they have to give you some risk factor, what will they give you? Patient is a case of previous cesarean. Although it can happen even without cesarean. Yes. So, painless, causeless. Very important is warning hemorrhages. Warning hemorrhages are characteristic to placenta previa. These are small bouts of bleeding. So there are multiple episodes of small bleeding which have happened in the past. These things are not seen with abruption. Okay. On examination, the findings are also the reverse. So this time the uterus is not tense, it will be relaxed, it is not even tender, and the fundal height will correspond. Okay. The cause is same, bache. It is placenta which is in the lower segment. So it is on the internal os, and from the placenta the bleeding comes. Okay. All right. What happens if we talk about in placenta previa? Usually the fundal height is same. Sometimes, yes, the fundal height may be less, not more. If that is the case, then you have to think of transverse lie. In fact, we will ask this as a one-liner. So very important, we'll put it as A44. Most common cause of transverse lie at term. So if you see a patient at 37 weeks and she has transverse lie, please rule out placenta previa. Don't do a PV exam, okay? Rule out placenta previa. Now, how is placenta previa different from low-lying placenta? So when you say placenta previa, it means it is covering the os. It may be partially covering, it may be completely covering, it may be reaching. Everything is placenta previa. When you say low-lying, it means it is not reaching. It is near the os. You have to remember the cutoff. What is the cutoff? So when it is within 2 centimeters, yes, of internal os. Okay. Now many of you, I'm sure you know that we don't do a PV examination. Can we do a transvaginal ultrasound? Yes. Please remember, in fact, investigation of choice for placenta previa is transvaginal ultrasound. It is more sensitive and it is safe. We are only putting the probe in vagina. We are not going into the cervix. Okay. Management is also reverse of abruption. Like in abruption, I told you, we don't do conservative management. In placenta previa, can you do conservative? Yes, we can. So the conservative management in placenta previa has a typical name. Again, any set ke liye these names are important. So the name is Johnson's and McAfee's regime, right? That is what we use for placenta previa. Now, conservative management will be done only when all the criteria are met, which means the mother and the baby have to be stable, okay? There should be no active bleeding, right? And the patient should not be in active labor, right? So no active bleeding, no active labor. The patient and the baby are stable. Is that clear? In case your patient is admitted for conservative management, you will monitor, you will give steroids for lung maturation. Yes, you will give tocolytics, not in all cases. You will give tocolytics if there are mild uterine contractions and the POG is less than 34. Then yes, you can add tocolytics. And yes, the tocolytic of choice remains as nifedipine. Can I ask you up till what POG will you do conservative management? Conservative management is done up to 37 weeks. We don't go beyond 37. Yes, so please remember, when you get a patient of placenta previa, you have to first decide whether you will deliver or will you do a conservative. How will you decide? Anytime the MCQ says the mother or the baby are in jeopardy, right? Distress hai, mother is unstable, or we have to say in, for that regard, even if the baby is dead, we don't do conservative management. Please remember this, just opposite to abruption. The management, if you have to deliver placenta previa, it is always and always a cesarean. If you are doing it at 37 weeks, it is a elective cesarean, but it is still a cesarean. If she is coming to you with bleeding and distress, then it is an emergency cesarean, but it is always a cesarean. Even with dead baby, you will do a cesarean. Yes, because vaginal delivery is not possible. That is why I said it is opposite to that of placenta abruption. Okay. These are some of the basics that they want you to know. I am sure you will not do this wrong. No PS, no PV exam, no cerclage in a patient of placenta previa. Okay. What are the complications that you should know? Remember, if these two things come together, placenta previa and previous cesarean, what complication can happen? PAS, placenta accreta spectrum. What is the problem in PAS? Yes, the placenta has entered into the myometrium. Yes, so it has entered the myometrium. And always, again, once it is PAS, it is always delivered by a cesarean. Not just a cesarean, we will also do a hysterectomy simultaneously. So it is a cesarean hysterectomy. It may be elective, it may be emergency, but it is always a cesarean hysterectomy. Yes? Can you tell me which cesarean? So I will put it as application 44, I think. Yes. When you say we are doing a cesarean in placenta previa, which cesarean it is? It is LSCS. When you say I am doing a cesarean for PAS, which cesarean is it? Then it is classical cesarean. So for placenta accreta spectrum, it is a classical cesarean. Yes, very good. Okay. Sometimes they will ask you the histopathological findings in PAS. These are the two key findings that you should know. The decidua basalis is absent. The Nita-Bux membrane is absent. Yes, where is the Nita-Bux membrane present? It is present in all normal pregnancies. So normally this is a layer which is present between trophoblast and decidua. So this is like the Lakshman Rekha. Okay. So generally, as I said, this is present between trophoblast and decidua. In case of placenta accreta spectrum, this is absent or it may be incompletely present. Okay. If they ask you investigation of choice for PAS, the single best answer is ultrasound. Yes. Can we add Doppler? Yes, we can. It will increase the accuracy. But is it mandatory? No, it is not mandatory. Okay. Similarly, can we do MRI? Yes. Is it mandatory? No. Please remember, MRI is typically done when the diagnosis is uncertain with ultrasound or we want to know the depth of invasion. Yes. Then yes, we will do an MRI. So MRI is considered as gold standard, but it is not required in all cases. Something that I feel can be asked this year in your exam, so I will put it as again application. Till now they have asked you what is the investigation of choice. Okay. Now what they will ask you is what are the findings in the ultrasound. So remember these keywords. If they use words like heterogeneous placenta, also called as a moth-eaten placenta. If they say intraplacental lakes, what are these lakes? These are hypoechoic areas. Actually, there is blood there. Okay. So, this is all characteristic terminology for PAS. Doppler में बताओ क्या मिलेगा? What would be the finding? You will find blood flow, turbulent blood flow in the myometrium. Yes. So, that is what is going to tell you that this is PAS. Another very important finding that you should know is there will be loss of, ध्यान से सुनो, please listen carefully, loss of clear zone behind placenta. So if there is no clear zone behind placenta, it means placenta has gone into the myometrium. Okay. Who is going to tell me what is the classic finding in abruption? If you do an ultrasound, What is the classic finding in abruption? Anyone? So remember, when we talk about abruption, the characteristic finding on ultrasound with which we make a diagnosis is a RPC. What is this? Retroplacental clot. Characteristic finding on placenta previa is placenta over internal os. Characteristic finding in pus, I have told you, there could be moth-eaten placenta, there could be intraplacental hypoechoic areas or lakes, and loss of clear zone behind the placenta. So you should know these keywords so that if they give you these as hints, even if the image is not very clear, you know what NEET PG does is, if it is asking uncommon things, it will give you hint of keywords in the small history. If it's a very characteristic image, they will not give any history. Is that clear? So you should always know these words, right? Coming to the third cause of antepartum hemorrhage, and that is vasa previa. Yes. Now when we talk about vasa previa, it is the only condition where it is whose blood? There is APH, but whose blood is it? Fetal blood loss. In placenta previa and in abruption, it is maternal blood loss. Okay. Now fetal vessels are traveling over the internal os. If we ask you vasa previa is related to which, okay, is related to which placental or abnormality of the cord, the answer should be velamentus. This is the best answer. The second best answer is it can be seen even with succenturiata, right? So one is called as type 1 vasa previa, the other is called as type 2 vasa previa. Okay. Now, I want to ask you this, which they could ask indirectly in your exams, especially exams like INESET. So when you say fetal blood loss, how will you know whether the blood is fetal or maternal? So then you should do a APT test. Okay. It is a alkali denaturation test. The alkali we use is 1% NaOH. I want to know from you, if it is fetal blood, what will be the finding? What will be the finding if it is fetal blood? Anyone? The color of blood will be retained, which means it will remain red. What will happen if it is maternal blood? The color of blood will be washed away. Yes, so that is what is the finding. Yes, it is a bedside test. That is why we are doing it. Okay, so it is only a qualitative test. Now comes the very important thing. If NEET PG gives you a clinical MCQ, when should you think of vasa previa? The typical case scenario will be the patient is in labor and suddenly after rupture of membranes, there is severe distress and bleeding. This is when you think of vasa previa. Can you tell me, I have to ask you, if there is rupture of membranes followed by severe distress, what should you think of? You should think of cord prolapse. Now I am saying even in vasa previa there is rupture and severe distress. How do you differentiate? In vasa previa, it's not just distress, it is bleeding. In cord prolapse, it will be only distress and there is no bleeding. Please read the words carefully. Okay? Yes. What is the management? The management is you will have to do an emergency cesarean. Okay. Also, please remember, if I diagnose vasa previa on an antenatal ultrasound, okay, let's say at we have already made a diagnosis. She is now a known case of vasa previa. Then what do? You will still have to do a cesarean, but it will be now a elective cesarean, not emergency. So now it will be elective and it can be done any time beyond 34 weeks. That is the difference. Is that clear? So is vasa previa clear to everyone? Okay. So then the last possible DD for antepartum hemorrhage is rupture. But please remember, I say last because more commonly it presents as intrapartum hemorrhage rather than antepartum. Antepartum can also happen, but most of the times the bleeding happens when the woman is in labor. Okay. So this would be your keywords. The examiner will tell you that she is a known case of previous cesarean. Majority of patients will already be in labor and then she will have bleeding. Okay. Now, my question to you is, the bleeding per vaginum in rupture uterus, will it be large amounts or small amounts? So, it will be small amount. Unlike abruption where bleeding is the main complaint. Okay. Here the bleeding is small. The more important finding here is non-reassuring FHR, which is a fancy word for fetal distress. Okay, so it's a fancy word for distress. Please remember, this is the most common finding in rupture uterus. Don't answer it as pain or anything else. Most common is non-reassuring FHR. What would be the other findings? Yes, there will be generalized pain abdomen. The blood pressure of the patient may be low. Why? Because more amount of bleeding here is not vaginal. It is intraperitoneal bleeding. That is why the woman may be hypotensive. Okay. The findings are quite reverse again of abruption. For example, in abruption, fetal parts were difficult to feel. Here the fetal parts become very easily palpable. In abruption, the uterus was tense, so contour of uterus is very easily felt. In rupture uterus, it is the reverse. Uterine contour is lost. In abruption, the contractions increase because of thromboplastin, which is a uterotonic. In rupture uterus, the contractions stop. Yes. So as I said, if you know abruption, you actually know everything else. Now, if we ask you most common finding, yes, the answer is non-reassuring fetal heart rate. But if we ask you most specific, then it is loss of station. This does not happen with anything else. Okay, it is very characteristic to rupture. Okay. Now tell me, application 46. What is the difference between rupture and dehiscence? Anyone? What is the difference between rupture uterus and dehiscence? So when you say rupture, you mean all layers of myometrium plus serosa have ruptured. So the baby will go into the abdominal cavity. When you say dehiscence, it is myometrium has ruptured, but serosa is intact. Okay, so baby is still in the uterine cavity. Very good. So then you say it is dehiscence. So dehiscence is actually a intraoperative finding. It's not a clinical diagnosis. Okay. Then there is another term with which the examiners confuse you, and that is impending rupture. Matlab, it is about to happen. If we ask you the term impending rupture, and we ask you what is the most common finding, the answer still remains the same. What is the answer? Non-reassuring fetal heart rate or fetal distress. So most common or first finding with impending rupture remains the same. So these are all the important causes of antepartum hemorrhage that you should know. Is that clear? Yes, so give me a thumbs up. No, bache. Scar tenderness is not the most important finding. Okay, it is a lot of times falsely positive. So when we ask you most common or first, it has to be fetal distress or non-reassuring FHR. Okay, chalo. So then we move on to the next topic. Again, every session, every exam, there will be at least one, sometimes more than one MCQs on this, right? So that is molar pregnancy or gestational trophoblastic disease. Yes. So now please remember, as I have been saying, NEET PG initially has been asking you questions on definitions itself. So you should know what is disease and what is GTN. Now, remember, disease is a broad term, so it includes both. It will include molar pregnancy and it will also include neoplasia. So it's a general term. When you say neoplasia, then it does not include molar, right? So when you say neoplasia, what all is included in neoplasia? So we include invasive mole, okay, choriocarcinoma, PSTT and ETT. The order in which I have written is the order of saying which is more common. For example, if I ask you most common GTN, what is the answer? Invasive mole. If I ask you least common GTN, what is the answer? ETT. If ETT is not in the options, we go with PSTT. Okay, but be careful. If I ask you, if I ask you most common GTN after full term pregnancy, then now we are giving you a very specific thing. We are giving after full term. So now the answer is not invasive mole. The answer will change to choriocarcinoma. Okay. How do you differentiate invasive mole from choriocarcinoma? So please remember, invasive mole mein the villi are present. Very important. In choriocarcinoma, villi are absent. There is no villus formation. All right. So very, very important basics, but have been asked in the exam. Okay. Now coming to features. This slide, everything written on it is an MCQ. It's actually everything written in it is already a PYQ and some are potential questions. For example, karyotype. Most common it is 46XX. For any set, I can go a level higher. And what I can tell you is, it is most commonly 46XX. This is 80% of times. 20% can be XY up to. So up to 80, it can be 80 to 90 also, and it can be 10 to 20 also. So majority are XX. So you are going to answer it as XX. Majority are diploid and they are monospermic. It is very important. So yes, majority are monospermic, but again going to any set pattern. Can they be dispermic? Yes, rarely. So if it is XY, only in that condition it is dispermic. But generally speaking, complete moles are monospermic. Don't answer the general answer as dispermic. It is incorrect. Okay. What are the classic findings? So the findings are Yes, we will see a snowstorm appearance. The snowstorm word has been used many times, so you should know the other names like Swiss cheese pattern or a honeycomb pattern. Also, classically, there is no fetus in a complete mole. Yes. Also, in a complete mole, there is a very characteristic finding. Yes, in the adnexa. What is the finding? Theca lutein cyst. What are these cysts and where are these cysts? So these cysts are in the ovary and majority of times they are bilateral. Okay, so these are present in the ovary. Who is going to tell me why? Why do we see these cysts? The reason is very high levels of HCG. What then? HCG has alpha subunit identical to alpha of LH and FSH. So it stimulates the ovary to produce these enlarged cysts. Okay. Partial mole is the reverse. They are actually triploid. So the karyotype is 69XXY. Majority are dispermic. 90% are dispermic. There are no theca cysts. There is no snowstorm, and most importantly, a fetus is present. Now listen to me very carefully. So when I say snowstorm, do you know what is the reason behind it? This is a complete hydropic change of placenta. So in complete mole, there is a complete hydropic change. In a partial mole, there is only focal change. Only in some areas you will see hydropic change. A very potential new question that can come in the exam. If we talk about immunostaining, P57 positive is partial mole. P57 negative is complete mole. So how should you remember? Remember all P's are together. Partial mole, okay, comes with P for P57 and P for positive. Okay, so complete mole is negative. Okay. Please remember HCG values are high in both, but as I told you previously, they are very, very high in complete mole, less high in partial mole. If you are going for any set exams, they confuse you further. They will ask you what is the characteristic appearance of partial mole on ultrasound. Like, we say the appearance of complete mole is snowstorm. What is the appearance of partial mole? Majority cases of partial mole are misdiagnosed on ultrasound. Do you understand this? Yes. So when I say partial moles are mostly misdiagnosed, what is the diagnosis on ultrasound? The report will come as missed abortion. Do you know why? The reason is they are triploid and triploidy is incompatible with life. Okay, so they are usually going to come as missed abortion. But very importantly, suppose they are asking you on ultrasound, what is a specific finding? So you will say, in a case of partial mole, the sac is not symmetrical. Like a real sac, okay, a real or a true sac is symmetrical. In case of a partial mole, it is not symmetrical, which means transverse diameter is bigger than AP diameter. And as I said, you may see focal hydropic change. Yes, so we may see a focal hydropic change and the transverse diameter is bigger. So this is important. These are new areas that they could ask the MCQs on. Okay, so quickly give me a thumbs up if you are clear with this. The next set of questions you get are on treatment part, right? So this table I have already summarized, but yes, it's a good table to go through close to the exams if you want to revise everything. Okay. Now, coming to treatment. So in general, listen to me carefully again. The treatment of choice for molar pregnancy is suction and evacuation. The NEET PG people are going to confuse you. So a little while ago, we have already done suction evacuation. What did we say? We said suction evacuation is done up to 12 weeks. Do you remember? Yes? Now what NEET PG people will say, they will say, so I'll put it as application 48, they will say your patient is a case of molar pregnancy and her uterus is 16 weeks. What do you do now? Now some students get confused because they know that we can do suction only up to 12 weeks. So now you change the answer. Do you change the answer? No. Yes. So irrespective of what they are giving the size, the answer will remain as suction and evacuation. Okay. Only in cases of molar pregnancy, once I do suction evacuation, I will also do a sharp curettage to ensure that all products have been removed. So we will also do a sharp curettage. Okay. Super important PYQs, they have been asked. For how long will you do the surveillance in a complete mole? The answer is 6 months. कहाँ से गिनना है 6 months? 6 months from normal HCG. So please understand this. First you do weekly values till you get normal HCG. Once you get normal HCG, you will do monthly values and then the period of surveillance is 6 months. Yes. During these 6 months, you have to tell her not to conceive. So the contraception of choice is OCPs. The contraception which we should not be using is IUD. It is avoided. NEET PG is again going to ask you these things. They are important. Okay. Now going to one level higher, which can come either in any set or if NEET PG goes higher, then yes. In case your patient has high risk features, and it could be any of these, it doesn't have to be all. So high risk features are age more than 40, HCG more than 10 to the power 5, bilateral large which are bigger than 6 centimeters, theca lutein cyst, fundal height more than POG. So if your patient has any high risk features, then she will need prophylactic chemotherapy. So now, how should you understand this? One way of asking this is, do we give chemotherapy to everyone or selectively? So your answer is, we give it selectively to high risk patients. Second question, do you give chemotherapy after hysterectomy also? No. So this prophylactic chemo is given after suction and evacuation. Okay. If we ask you, can you do a hysterectomy for molar pregnancy? Yes. If your patient is more than 40 years of age, she has completed family or childbearing, and she has a complete mole, then yes, the treatment of choice will change to hysterectomy. Also, I am going to go one level higher for all of you. Just like I said, period of surveillance for complete mole is 6 months. What is the period of surveillance for partial mole? Can you tell me? The answer is only 1 month. But most of the times your exam will not mention partial or complete. They will just say, what is period of surveillance for molar pregnancy? Then what will you answer? Please answer 6. Whenever they are writing molar, it is complete mole because that is the most common type of molar. Okay. Partial mole is uncommon. So the general answer will remain as 6 months. Okay. Coming to neoplasia. So please remember, how do you make a diagnosis that your patient has become a case of GTN? So then either of these, one could be 3 consecutive values which show a rise over 2 weeks. So day 1, day 7 and day 14. So these are 3 values over 2 weeks if they show a rise. Second, if 4 values show a plateau over 3 weeks, which means day 1, 7, 14 and 21. Plateau किसको कहते हैं? If the value remains within plus minus 10% of the previous value, then you consider it as a plateau. Rise किसको कहते हैं? If the value increases by more than 10%. So up to 10% it's a plateau. The third way to make a diagnosis is you had tissue after suction, you sent it for histopath. Tissue already says on diagnosis that there is choriocarcinoma. Okay. As I said, after vaginal delivery, GTN overall is uncommon. Okay. It will not happen. But if it happens, which one is it going to be? Choriocarcinoma. Choriocarcinoma is much more common than PSTT. Now coming to the next important application points. As I said, in choriocarcinoma, it is the malignant form. It shows metastasis. What about PSTT? It does not show mets. Next question. When you say choriocarcinoma, the tumor marker is HCG. What is the tumor marker for PSTT? HPL and PLAP. Yes. Third, choriocarcinoma is highly chemosensitive. So you give chemotherapy. What about PSTT? It is chemo resistant. So what will you do for PSTT, batao? Don't answer chemotherapy. Answer it as hysterectomy. Is this clear? Yes? So then it is hysterectomy. These things we have already covered. Yes? Most commonly, choriocarcinoma will happen after a complete mole. What is the risk after complete mole? The risk of choriocarcinoma is 4%. Okay. With partial mole, it is negligible risk. All right. Also remember, risk of complete mole into GTN is 20%. And what about partial mole into GTN? 5%. Okay. Most common site of metastasis, I think everyone knows, it is lungs followed by vagina. But when you go to any set exams, they are even asking percentage. So when you make a diagnosis of GTN, 80% of women will already have metastasis in lungs. 30% of women will already have metastasis in vagina. Okay. So vaginal metastasis will be seen as blue nodules under the urethra. Please remember, no biopsy is to be done. They will bleed a lot. Lung metastasis, everyone knows, is going to be cannonball, but it can also be snowstorm. As I said, usually PSTT and ETT will happen after vaginal delivery, but are they common? No, they are highly uncommon. They are rare types of GTN. Okay. Yes, management is the part on which NEET PG asks you questions. So remember, As long as your patient is stage 1, you don't have to do a WHO scoring. She remains as low risk. If the patient is stage 2 and 3, you have to do a WHO scoring. So then if the score is less than equal to 6, it is low risk. Once your patient is low risk, you have to give a single drug, but you will have to give multiple doses. So multiple dose regime. Yes, the drug we use is methotrexate. We alternate it with folinic acid to reduce the toxicity. Okay. Now my question to you is, where do you use single agent, single dose methotrexate? कहाँ पढ़ा था? Single agent, single dose. Where did we read this? We have just covered it somewhere. This is ectopic. For malignancy, we can't use single dose. It has to be multiple doses. You have to use some common sense. Okay. In case your patient is methotrexate resistant, then you can use actinomycin D. Now, all patients who are stage 4, so metastasis to liver, metastasis to brain is stage 4. They automatically become high risk. For stage 2 and 3, if you do a scoring and it is more than or equal to 7, then they become high risk. They will receive a multi-agent chemo, which is IMACO regime. You should know what IMACO stands for. Most of my students do wrong what is the C here. So the C here is not cisplatin, it is cyclophosphamide. Okay. Please remember, for GTN, it doesn't matter which GTN, low or high risk, the period of surveillance is going to be 12 months. Are you clear with that? 6 months was for complete mole. Sometimes we give you basic questions like, yes, what stage is lung metastasis? It is stage 3. By itself, although it is stage 3, it is given a score of 0. So it is actually a low risk GTN. Vaginal metastasis is stage 2. Okay, and is again good prognosis. Yes, please remember, if there is metastasis anywhere else, then you make it as stage 4. Okay. Whatever I am telling you in WHO scoring is very important, and you can solve all MCQs if you know what is there in this slide. So remember, what is good prognosis, what is bad. So lungs is good, vaginal is good, but liver and brain mets is bad. So they will receive multi-agent chemo. Okay. No, you don't have to calculate. You will be, if you know the concepts, without calculation, you have the answers. But if you don't know the concepts, even if you mug up the table, you will not be able to answer it correctly. Okay. Most of the times, bache, you will not be able to calculate, because when we have to calculate, we use multiple parameters. There are 8 or 9 parameters. In your exams, they don't give you everything, so you can't calculate. They will give you keywords like, let me ask you, so I will put it as, the application part here itself. So let me ask you this. Suppose I say, on follow-up of suction evacuation for complete mole, your patient develops lung mets at 4 months and she also has liver metastasis. Okay. Can you tell me what would you want to do for her? Now, do you think you can do the scoring? No, you do not have all data to do the scoring. So what do you do here? Lungs is good. Early diagnosis is good. But she also has liver metastasis, which is stage 4 GTN. And I told you, if your patient is stage 4, you don't have to do the scoring. The answer becomes IMACO. Now do you understand what I was trying to say? Another place where you get confused. Your patient has choriocarcinoma. She has lung mets at 2 months, very early. Tell me, what would you want to do? Single agent, everything is good. Lung mets and early diagnosis, anywhere within 4 months is very good. So the earlier the diagnosis, the sooner you start the therapy. So this is a low risk patient. So you will start single agent but multi-dose therapy. Is it now clear how to approach MCQs? Chalo. So this is what we should know about molar and GTN. So now we are going to move ahead to the next topic. That is going to be hypertensive disorders. So again, a topic which has a lot of basics. So I'm going to, I've put them here so that you can revise. But this is something that, you know, I cannot go on to basics. This is more of a factual part. So you have to know it. For example, what is the cutoff we use to make a diagnosis? So BP should be 140/90. It should be recorded twice, 4 hours apart. Now, if your patient has hypertension, but there is no proteinuria and there is no end organ damage, and she has to be beyond 20 weeks. Yes? Then tell me. Then you have to label it as gestational hypertension. So, bache, you leave the question forming to us. When you make questions, your questions are incomplete and they cannot be answered. So, remember, examiners have much more knowledge. So, they know how to put the questions. Okay? So, remember this. So, beyond 20 weeks is going to be then gestational. But on the other hand, if your patient has proteinuria or she has end organ damage and she is also beyond 20 weeks, then you will label her as what? Preeclampsia. So for preeclampsia, we should have either proteinuria and or end organ damage. Is that clear? Now, when you say preeclampsia, and as I said, NEET PG is typically asking you questions on how to make a diagnosis. You have to know this. Suppose you know now that she is a case of preeclampsia, right? But along with that, if any one of this is written, you change the answer from only preeclampsia to preeclampsia with severe features. For example, what are the conditions which make it severe? So we call them as criteria. So what are the criteria? A creatinine level which is more than 1.1. Liver enzymes which are more than twice. Right? What is the normal value? In pregnancy, we say normal value is up to 30. So anything more than twice is deranged. Okay? Platelet count ka requirement hai, it should be less than 1 lakh. Now it may be 80,000, it may be 50,000, but it should be less. Pulmonary edema is definitely a criteria, but you people confuse it with peripheral edema. Yes? Is peripheral edema a criteria? No. Please remember this. Okay? Pedal edema is not a criteria for anything. It is not a criteria for preeclampsia. It is not a criteria for preeclampsia with severe features. Is that clear to everyone? Okay. Then if the blood pressure becomes very high, how high? More than 160/110. If the patient has headache or dizziness, so these are because of, what is the reason behind headache and dizziness? This is because of cerebral hypoxia and cerebral edema. Then yes, it is again severe. Or my patient have visual disturbances. Now please remember this very carefully. As I said, we don't need all of them. We need any one to say that it is severe. Sometimes I see My patients, sorry, I'm so used to of seeing patients. Sometimes I see the students getting even confused further when we use the term impending eclampsia. Yes, so I will talk about impending eclampsia in a moment, right? But as of now, you should know what is preeclampsia and what is preeclampsia with severe features. Okay, please remember IUGR, oligohydramnios and oliguria. Are they criteria for severe preeclampsia? No. They are again not criteria for severe. Yes, they are findings. Definitely, yes, they can be findings, but they are not criteria. Similarly, pedal edema can be a finding, but it is not a criteria. Okay. You get always and always MCQs on drug of choice. So remember, for hypertension in pregnancy, the answer is labetalol. You are asked what category drug is it. It is not a beta blocker. Okay. It is an alpha plus a beta blocker. Is that clear? Now, drugs which are contraindicated. You have been repeatedly getting questions on ACE inhibitors. But you should know about ARBs, about beta blockers, diuretics and diazoxide. So they are all contraindicated. Yes. Now listen to me very carefully. If your patient has very high blood pressure, let's say it is higher than 160 by 110, what are you going to give her? So we are going to give her labetalol, but it will be IV. Yes. What is the next thing? If labetalol cannot be given, then we give IV hydralazine. If that is also not available, then we give nifedipine. Yes, what are the other drugs that we can use? We can use other drugs also, but they are not the drug of choice. They will be used when these drugs are not able to control the blood pressure. For example, nicardipine. For example, nitroglycerine. For example, nitroprusside. So these can be used if the blood pressure is not controlled with the other drugs. Is that clear to everyone? Okay. Now please remember, if your patient has preeclampsia but there are no severe features, then when do you do termination? So super important. We don't go beyond the 37 weeks. NEET PG will repeatedly ask this concept. So once you reach 37 weeks, you have to do a delivery. Okay. Please remember, on the other hand, if your patient has preeclampsia with severe features, yes, then what do you do? Even if the blood pressure is controlled, you will deliver at 34 weeks. Now coming to a very important concept, and that is IE, impending eclampsia. Can you tell me when do you say it is impending? So look at this. Any MCQ which says your patient has new onset headache, vomiting or epigastric pain and visual changes. Now again, it should not be all. It could be maybe one of these or two of these things. It doesn't have to be all. So any MCQ where you see these alarming features, you call it as impending eclampsia. It is a super important concept which you can't afford to do wrong. Once it is impending eclampsia, there is no conservative management. And therefore, there are no steroids. You are not even going to wait for steroid cover. You have to immediately give her Magsulf. So next step is Magsulf. You give her labetalol, control the blood pressure. Once you stabilize the patient, you will deliver. Is that clear? You will see multiple MCQs on impending eclampsia. If you don't have these concepts, you are doing them wrong. Now, do we do termination irrespective of POG? Yes, it doesn't matter whether she is 30 weeks, 32 weeks or 34 weeks. The answer has to be deliver. The preferred mode of delivery will remain as vaginal. Okay. In case you are doing a cesarean, she is a high risk patient. In that case, the preferred anesthesia, the single best answer is neuraxial. Why? Because neuraxial includes both spinal also and epidural also. But if neuraxial is not in the options, then what will you mark, batao? So now spinal anesthesia is preferred over epidural. Is that clear? Yes. So spinal will be preferred over epidural. Okay. So these are important things. Please don't do them wrong. They are very important concepts. They are repeatedly coming in the exams. Okay. Now, as we said, what is eclampsia? It's very simple. Once she throws a seizure, from impending, she becomes eclampsia. Yes. The seizures are tonic-clonic. So there is a tonic episode and then there is a clonic episode. So we call them as which other seizures? Grand mal. Okay. Now, remember the reason for seizures is same, edema and hypoxia. Okay. What do you do? So it is an algorithmic management. You have to first stabilize the position of the patient. Then you will secure the airway by putting a mouth gag and you suction any secretions. Then you will give Magsulf and labetalol to stabilize the mother. Once you stabilize, you will do a termination, which means even in eclampsia, there is no conservative management. And you are not going to wait for steroid cover. Okay. So please remember this. What is impending eclampsia? It is the prodromal phase of eclampsia. I hope you have read seizures and you know what is the prodromal phase. So basically the prodromal phase is what is impending. Yes, beta, always the preferred mode of delivery in pre-eclampsia of any type is vaginal delivery. You do cesarean only when there is an obstetric indication. Okay. Now, Magsulf is one of the favorite topics of your examiners and we are going to ask it again and again. So, this is something that you need to know. Therapeutic levels are 4 to 7, but what they want to ask you is, do we routinely do magnesium levels? No. The levels are not done routinely. So, who is going to tell me when do you send serum magnesium levels? You send serum magnesium levels only when you see signs of toxicity. Okay. And what is the first sign of toxicity? The first sign of toxicity is loss of patellar reflex. If you see here, I have written, once you see loss of patellar reflex, then you send magnesium levels. Okay. Next important thing, what is the loading dose? Again, a lot of students do this wrong. A loading dose is a combination of IV and IM. So the total loading dose is 14 grams. It's not 4, it's not 10. Out of this 14, 4 is given intravenous and 10 is given intramuscular. Can I give loading dose even without knowing the kidney functions? Yes, it is given irrespective of kidney function. What is the mechanism of action? It acts centrally on NMDA receptors in the brain. Yes. Now, areas where they twist and ask you, please remember, oliguria is not a sign of toxicity, but be very careful. If there is oliguria, which means the urine output is less than 100 ml in 4 hours or less than 30 ml per hour, then don't give Magsulf. Why? Because you know the route of excretion is urinary. So if urine output is less, you are giving therapeutic dose, but it will become toxic. Okay. In case there is toxicity, you have to give the antidote, which is 10 ml of 10% calcium gluconate. We give it IV. Your exams are also fond of asking what are the other uses of Magsulf. So remember, it is used as a tocolytic, but it is a very mild tocolytic. And super important, we also use it for neuroprotection of the fetus. But your exams will ask, when do you give Magsulf? Only give it for neuroprotection if POG is less than 32 weeks. Okay. So these are things about Magsulf which are mandatory. Please remember, as far as India is concerned, we are only following one regime, which is Pritchard. Okay, we do not give loading any other method of loading dose. We use Pritchard. Also, please remember, in the Pritchard regime, when you give the maintenance dose, it is 5 grams. Okay, so loading was 14, the maintenance is 5 grams. What are the 3 things you check before the maintenance dose? Can you tell me? So, before you give the maintenance dose, what are you going to check? Check for deep tendon reflexes or patellar reflex, check for respiratory rate, and check for urine output. Yes, the urine output should be more than 100 ml in 4 hours. Respiratory rate should be more than 12. Reflexes should be present. Okay, so this is what you have to check before you give the maintenance dose. Is that clear? Okay, so yes, you have to give the loading dose irrespective. When we are saying oliguria, this is for maintenance dose. It has nothing to do with the loading dose. Bache, loading dose is irrespective of the function. Okay, right. Let's move forward and let's look at these. So these are some extensions of preeclampsia, especially coming in NEET PG, more commonly in NEET PG than in any set exams. Okay. Yes. Yes. IM dose that we are giving of maintenance, as I said, we are giving 5 grams IM. Okay. And it is given every 4 hourly. Endpoint क्या होता है? 24 hours after delivery or last seizure. So you will count the 24 hours either from delivery or from the seizure, whichever is later. So you will count 24 hours and that is going to be your end point. So you keep giving it every 4 hourly. Okay. Chalo. So now talking about HELP syndrome. So when you say HELP syndrome, named criteria are Tennessee criteria, and what is written here, everything is required. We don't need one of these. We need all of these. So what are the 3 things? We need hemolysis, we need elevated liver enzymes, and we need low platelet count. So we need 1 plus 2 plus 3. Okay. How do we look for hemolysis? You can look for bilirubin. Total bilirubin will be raised, but I am sure through medicine you know that if it is hemolytic anemia, the major component is indirect bilirubin. Yes. On the peripheral smear, you will find schistocytes or helmet cells. And I hope you know that when you talk about hemolysis, the LDH levels have to be high and haptoglobin levels have to be low. So when you look out for these things, you will know whether there is hemolysis or not. Liver enzymes, as I said, should be more than twice, and platelet count, as I said, should be less than 1 lakh, right? So please remember, once you say HELP syndrome, yes, is it severe preeclampsia or no? Yes, it is preeclampsia with severe features, and that is why you will have to do a termination at and beyond 34 weeks. You don't want to go further. Okay? Also, in HELP syndrome, the most common symptom is pain. Okay, it is pain. Epigastrium or right upper quadrant. It has to be in the third trimester. And please remember, the recurrence rate is up to 7%. Again, very typical things that NEET PG is fond of asking. Okay. A very close DD of HELP syndrome is acute fatty liver. Again, more common in NEET PG exams as compared to INHESET. What you have to know is it is a rare disease, so it's uncommon, but it has a very high mortality rate, significantly high. When you say AFLP is a close diagnosis, we say that because it also presents in the third trimester and the presentation is very similar to HELP. Yes. In fact, the women are also going to have similar background, like these women may also have underlying preeclampsia. They also may be multifetal pregnancy or gravidas. These are risk factors even for preeclampsia and HELP syndrome. So they have common risk factors and a common symptom presentation. So it's a very close DD. Especially if we go a level higher, they would want to ask you which enzyme deficiency has been linked to AFLP. Then it is LCHAD, long chain hydroxyacyl dehydrogenase. What you need to know is not the full form. You have to know, when we talk about this enzyme deficiency, the deficiency is in the fetus, not in the mother. So, a deficient fetus can cause fatty liver in the mother. Okay. As I said, the presentation is very similar. So, these women will also have what? They will have pain. They are in the third trimester. But how do you know if it is HELP or AFLP? Now, yes, this is important because most of the MCQs are coming as clinical MCQs. So if you read the MCQ and it looks like HELP, right? But when you read it in detail, you realize there are signs of liver failure. Anytime you see signs of liver failure, this helps you differentiate acute fatty liver. So these are present in AFLP and not present in HELP. Remember, HELP is mild liver injury. Acute fatty liver is acute failure. Okay. So what would be the keywords written there? They will write things like, patient has hypoglycemia. Patient has raised ammonia or altered sensorium. Patient has coagulation failure. Now see, platelet count can be low in both. So don't decide on the basis of platelet count. BP can be high in both, right? But DIC will not be present. DIC is much more common in acute fatty liver. Okay. Patient may also go into renal failure because of hepatorenal syndrome. The patient can also develop complications like pancreatitis. Okay. Now, in comparison to HELP syndrome, acute fatty liver is termination irrespective of POG. So, irrespective of POG, we will do a termination. Okay. Yet another topic which is going to be asked in your exams is intrahepatic cholestasis of pregnancy. What is the other name for this condition? Obstetric cholestasis. Right? Now, obstetric cholestasis, if they ask you which hormone is responsible, don't answer HCG or progesterone. It is actually estrogen. Right? Again, it's a DD for HELP syndrome because it also presents in the third trimester. The risk factors may be similar, like multifetal pregnancy, like gravidas. Okay, but how is it different? AFLP was with male sex, right? So if the fetus is male sex, that's what we say is linked to AFLP. Here, obstetric cholestasis is related to female baby. Why? Because the estrogen levels are higher. Sometimes they will ask you which genetic mutation is responsible. So you should know the gene is ABCB4 gene. It can be B11 also, but the single best answer is B4. Okay. How is it different? Remember, when I talked about AFLP or HELP, I talked about pain. Yes, here there is no pain. Rather, the patient has pruritus. Yes, the bilirubin levels will be raised just like HELP syndrome. But what is the difference? Here it will be direct bilirubin or conjugated bilirubin. HELP में कौन सा था? Unconjugated. Although the bilirubin levels are high, but it is not a diagnostic test. So be very careful. NEET PG confuses you. When they ask you how do you make a diagnosis, the answer is serum bile acids. Anything more than 40 is considered as raised, 40 micromoles. Okay? Then, is it more dangerous for the mother or the baby? So remember, it is actually more dangerous for the baby. Mother only has pruritus, right? But the baby can have a sudden death. The baby can have mass. Do you know what is mass? Meconium aspiration. Then the baby can land up in prematurity. Okay, so it is more complicated for the baby. The drug I think you will all know is Udilif, which is the common name. It is ursodeoxycholic acid. It reduces the serum bile acids. So now if I ask you, will it improve fetal outcome? Yes or no? Yes. So all the problems in the baby are because of bile acids. So if you reduce the bile acids, it will also improve the fetal outcome. It will reduce the pruritus. Okay. So please remember, once you say it is obstetric cholestasis, you are not going to do a preterm delivery. So delivery will only be done beyond 37 weeks. No preterm delivery for the babies, even though there is a risk of IUD, but no premature deliveries. Okay, is that clear? No, you can't say that. Okay, because they have a recurrence risk as well. So please remember, obstetric cholestasis is a recurrence risk up to 70%. So in the first pregnancy, if it was a female baby and she had cholestasis, next time it may be a male baby, but she can still have cholestasis because of a very high recurrence risk. Is that clear? Yes. Very quickly before I go to medical disorders now, I want you people to quickly let me know something about vascular remodeling in pregnancy because it is linked to preeclampsia and NEET PG may ask. So you have to quickly answer. Can you tell me which cells will do the vascular remodeling? Which cells? So they are going to be the extravillous endovascular cytotrophoblasts. And can you tell me which arteries undergo remodeling? It is, yes, the spiral arteries, right? So please remember the remodeling happens in 2 phases, right? So the first phase is by 12 weeks. The second phase is by 16 weeks. Now, you should remember that if there is absent remodeling, what all can happen? So if there is absent remodeling, remember there is preeclampsia. Remember there is UPI, so it can result in IUGR, and it is also one of the reasons for development of PAS, placenta accreta spectrum. Okay. Lastly, I want you to know what things are going to increase or decrease. Remember, increase में आता है SFLT1, SENG, thromboxane A2, right? So these are going to increase. Decrease में क्या आता है? Vascular endothelial growth factor, placental growth factor, prostacyclin and nitric oxide. They are going to decrease. So you can use these biochemical markers for prediction, and you can also use uterine artery Doppler for prediction, which I will talk about as we go forward, right? Who is going to tell me what is early onset preeclampsia? You say early onset preeclampsia if it happens before 34 weeks. Then you say it is early onset. So uterine artery Doppler is typically done to predict early onset preeclampsia. It is done at around 11 to 13 weeks. Is that clear to everyone? So this is yet another part which is important and you should know. Okay? Chalo. Now, as far as medical disorders are concerned, we are not going to go very vast. We are going to restrict ourselves to what is exactly asked in the exams. Okay? So these topics are going to be shorter and they are going to focus on key things because you barely get one odd MCQ and that too not all the time, right? So only sometimes you may get, and you could get possibly one odd MCQ from these topics. So for example, cardiac disease, most of this we have done. The most important part that they ask in the exams is about prosthetic heart valves. So this is what you need to know. When your patient is in the first trimester, what do? You switch from warfarin to low molecular weight. As per the new guidelines, you will do this switch over if the dose of warfarin is more than 5. Yes? So as per the new guidelines, if the dose is less than 5, can you continue warfarin? Yes, then you can continue warfarin. What do you do at 12 weeks? At 12 weeks, you have to again do a switch over. Okay? So what is the switch over now? So now you have to switch over from low molecular weight heparin to again warfarin. So at 12 weeks, you have to restart warfarin. Yes? And what do you do at close to term? So at 36 weeks, you have to switch back again to low molecular weight. So please remember, as I said, what is the important part here? Between 12 to 36 weeks, you are going to give warfarin. In extremes, okay, extremes mein, matlab less than 12 and more than 36. What are you going to give? I told you, na, 2 hours. You can't even sit for 2 hours. Whose exam is it? Yours or mine? We started at 2 p.m. and I said I need your attention for 2 hours. I know when to give a break. Don't be like little babies who can't sit for 2 hours. Yes? How will you do your duties where you have to focus for 24 hours? What will you tell the patient? No, I need a break. I'm going. Yes? Okay. So extremes of conditions. So less than 12 and more than 36. What are you going to give? You are going to give low molecular weight heparin, but please remember, as per the new guidelines, with heparin, you will also add aspirin. Okay? So with heparin, you will also add aspirin. Is this part clear to everyone? Give me a thumbs up quickly. So prosthetic heart valves, and what are you going to do? An important topic, repeated multiple times. Yes? Now, generally, please remember, whenever we talk about heart disease, the preferred mode of delivery for these patients is what? It is going to be vaginal delivery. Yes? And please remember, in case you are doing a cesarean, then the preferred anesthesia is epidural, right? Normally, what is the most common anesthesia we use? Most commonly, we use spinal for cesarean section. In heart disease, we will answer it as epidural. Okay. Very, very important. If your patient has heart disease and she is having PPH, which drug is not to be given? So when we say not to be given, it is going to be methergine. Yes. Please remember, preeclampsia is also contraindication for methergine. Why? Because methergine causes hypertension. Yes. Suppose you could not do a switchover and the woman goes into labor. So let's say she is on warfarin and she goes into labor. What do you do then? So if she goes in labor, then you will have to do a cesarean and it will be GA. Because warfarin is an anticoagulant. So you can't give epidurals or spinals. Okay, you will have to do what? You have to give her a GA. Now, please listen to me very carefully. Conditions like Eisenmenger's, okay, conditions like severe aortic stenosis or aortic regurgitation, conditions like aortic dissection, and condition like, typically Marfan's with aortic root dilatation. In all these conditions, we don't do vaginal delivery. They are very risky conditions, so we do a cesarean. So the general answer was vaginal, but not in these conditions. Here it will be a cesarean and it will be under GA. So in high risk conditions, we will not give, spinal or epidural. We will keep it as general anesthesia. Okay? Also remember, if we are doing a vaginal delivery, should we cut short the second stage of labor? Yes, so we should do a assisted vaginal delivery. We should use instruments. I can use both instruments, forceps and vacuum. Yes, but overall we prefer forceps over vacuum. Please remember, vacuum is not contraindicated. It can be used. It's just that forceps should be better. Okay? Another topic which NEET PG specially asks, not any set, is peripartum cardiomyopathy. Now, the first important thing for this is your patient should not have, okay, there should be no underlying heart disease. If she has a heart disease, you can't call it as peripartum cardiomyopathy. Second, how will we make a diagnosis? The patient has a systolic heart failure. So what I need to do is do a echocardiography and focus on the ejection fraction. So this should be less than 45%. Then, just like they've been asking which hormone is linked to this, which hormone is linked to this, if they ask you which hormone is linked to peripartum cardiomyopathy, the answer is again something very different, and it is prolactin. That is why when we treat peripartum cardiomyopathy, we will give treatment of heart failure, whatever we do routinely, and we will add bromocriptine. Okay? Also, please remember, importantly, when you say peripartum, it means it is happening around delivery. So you will make a diagnosis if the patient develops heart failure anywhere from 36 weeks up to 5 months postpartum. So it can happen in this time frame. Although most commonly it will happen in the first week after delivery. So जिसको होना होता है, most patients will develop it in the first week. Okay. Also, you should know the risk factors. So, advanced age, multiparity, preeclampsia and multifetal pregnancy are important risk factors. Generally, if you realize these risk factors are common. So, जो preeclampsia के risk factors हैं, they tend to be common even here. The only difference is preeclampsia was more common in primi gravidas. Most disorders are more common in primi. That's the rule of thumb. Okay, except some. So like this one, when you talk about peripartum, it is more common in multigravidas. All right. Chalo. Diabetes, we have already done quite a bit in terms of diagnosis. So we are going to go in the first slide a little faster because we've already covered this slide. For example, we have already talked about OGTT when it has to be done. So first antenatal visit and then 24 to 28 weeks. We have done the cutoff values as well. What I want you to know here is if the value is more than 140, you start only diabetic diet, okay, which is also called as MNT. What is MNT? Medical nutrition therapy. But if you do a 2-hour OGTT and the value is more than 200, then you have to straight away start insulin, and that too 8 units. Okay. Any diabetes which is controlled on diet alone is called as A1-GDM. If you add any kind of drug therapy, then it is called as A2-GDM. Among drugs in gestational diabetes, you should know the drug of choice is insulin. Don't answer metformin. Yes, OHA can be given in GDM, and in OHA we give metformin, but it is not the drug of choice. Okay, is that clear? No, OHAs can be given in GDM. OHA should not be given in pre-gestational. All right, is that clear? Okay. The second important part that they are asking in exams, especially in ESET, is what are the targets you have to maintain? So remember, our target level is that our 2-hour PP value should be less than 120 and the average capillary glucose value should be 100. Now, how the exam will ask you? They will ask you, patient is on diabetic diet, she is checking her blood glucose and it is more than 120. What are you going to do? So after you have put her on a diet and the 2-hour PP is more than 120, what should you do? You should start insulin, right? So you have to know the indication to start insulin. Is that clear to everyone? Give me a thumbs up quickly. The second part is also very important. So this slide again, repeated PYQs from this slide have come in your exam. For example, remember, anomalies are not seen in GDM. Yes, they are seen in which type of diabetes? Anomalies are seen in pre-gestational or overt diabetes, right? Second thing, which is the most specific anomaly? So when we use the word specific, the answer is sacral agenesis. What is the other name for this? Caudal regression syndrome. Okay, but if we are using the word most common, then the answer is VSD. Okay, all diabetics, even if she is gestational, she should undergo level 2 scan because it is mandatory for all pregnant women. Okay, it is a high risk pregnancy, so you have to monitor the baby. The baby can develop macrosomia and can develop many complications. So you will start monitoring the pregnancies at 32 weeks. That's when you start doing fetal monitoring in a high risk pregnancy. Remember, in India, the cutoff for macrosomia is not 4.5, it is 4 kgs. 4.5 is an American guideline. Okay. What is a very important finding in ultrasound other than macrosomia, and your exams are fond of asking? Polyhydramnios. So if your patient develops sudden enlargement, especially beyond the period of teratogenicity, then you should definitely think of polyhydramnios and diabetes. Okay. We have already covered that echocardiography is not needed for everyone. We will only do it in pre-gestational. Do we give a high dose of folic acid? No. the folic acid dose remains as 0.4. Why? Because please remember, the reason for teratogenicity is not folic acid here. The reason for teratogenicity is hyperglycemia. What is the reason for macrosomia? Again, hyperglycemia. That is why, when you say macrosomia or polyhydramnios, they can happen in both gestational diabetes as well as pre-gestational. Okay. Now, irrespective of what is the type of diabetes, if her sugars are well controlled, you will not deliver before 39. Okay. In fact, you can go up to 40 weeks. You don't go beyond 40, but you even don't go before 39. If it is poorly controlled, which they will not give in the exams, then I can do a termination anywhere from 36 weeks to 38 plus 6 weeks. Okay. Then, as I said, we don't go beyond 40 weeks because there is risk of sudden IUD. Okay. Which type of delivery do you prefer? Vaginal. So, if the weight of the baby is more than 4 kg, that is when you will do a cesarean section. As I said, 4.5 is a American guideline. For India, it is 4 kg. Okay. Now, if I ask you what happens to insulin requirement during pregnancy, so insulin requirement will increase. Why? Can you tell me? So insulin requirement increases as POG increases. Why? Because resistance increases. On the other hand, if I ask you about insulin requirement during labor, then during labor, bachche, please be very careful. The answer will be decreases. So in pregnancy, it increases, but typically during labor, it will decrease because women are not allowed to take orally. Okay? If you are going to do induction of labor at 39 weeks, or you may be doing a cesarean at 39 weeks, remember, the night dose of insulin has to be given, but the morning dose on the morning of cesarean section or the morning of, induction, you will not give any insulin. Yes? Immediately after delivery, the baby is still at high risk of certain complications. What are those complications? The most important one is hypoglycemia. The second is hyperbilirubinemia. The reason for this is polycythemia. So yes, these babies have polycythemia. They have hyperbilirubinemia. In case the baby is born preterm, so if there is prematurity also, then they can develop hypocalcemia and hypomagnesemia. What is the reason for RDS? Diabetes में there is a delayed lung maturation. So they are likely to have RDS. Then please remember these babies may have HOCM, but this is not an anomaly. It is a physiological adaptation of the heart. What is the difference when we say physiological adaptation and we say anomaly? Anomaly is not reversible. Yes, but physiological adaptation is reversible. So after birth, this hypertrophic obstructive cardiomyopathy will improve. But anomaly cannot improve on its own. You will have to do a surgical correction for it. Is that clear? Yes? Perfect. So these are things that you should know typically from the medical disorders. So we are exactly at 4 o'clock. So now we will take a break, which is going to be a well-deserved break. So I'm going to give you 20 minutes of break. So we will restart at 4:20. Okay, is that clear to everyone? Okay. Okay, is everyone back? So quickly, a thumbs up if the audio video is good for everyone. Yes. And now I would demand the last 2 hours and the final lap. I would want you people to concentrate once again with me for the next 2 hours. Yes, can you do that? Promise. I will wind it up in 2 hours, but you have to promise that you are going to be alert. The problem arises when you are not alert. Then I have to repeat things. Yes, are we good? Okay, chalo. So next we will start with certain obstetric complications. Again, usually you will get one question from these topics, not too many, but yes, something or the other is asked. So let's look at first topic, and that is going to be multifetal pregnancy. Okay. Now when we say multifetal pregnancy, remember the most common variety are dizygotic and therefore they are DCDA. When you talk about monozygotic pregnancies, remember that their prevalence is fixed. It doesn't change. Right? So, the prevalence changes only for dizygotic twins. Now, depending on when the cell division happens, different kinds of monozygotic twins are formed. And this is the first set of MCQs that is very commonly asked. For example, whether it is INICET or NEET PG, you have to know that if division happens in the first 72 hours, the INICET would say in the morula stage. Then you have to say that these are dichorionic and diamniotic. Okay. If it happens between 4 to 8 days, and INICET would say at the time of blastocyst, okay, then it is going to be MCDA. MCDA is overall most common variety of monozygotic twin. Okay, please remember, once you say MC, okay, it can be DA also and it can be MA also. But once you say DC, it is always going to be DA. So DCMA possible nahi hai. ठीक है? Then if it happens between 9 to 12 days, which means INICET would say at the time of implantation, then it is MCMA. As I said, MC में MADA हो सकता है. With DC you cannot have MA. After 12 days, or INICET would say after embryonic disc, then the answer changes to conjoined twins, which are also called as Siamese twins. Right? The next set of MCQs that they ask you are about how will you know what is the chorionicity? Why? Because dichorionic twins are going to have less complications as compared to monochorionic twins, right? So we are wanting to know which are dichorionic, which are monochorionic. If they ask you what is the best marker, you have to say 2 separate placentas or opposite sex twins. The problem is in India, we are not allowed sex determination, right? So for us, it is 2 separate placentas. But that is only possible if we do an ultrasound early in pregnancy. Now, suppose the patient comes, later, then these things cannot be appreciated. So then between 10 to 14 weeks, we will rely on the lambda sign. Yes, what is it also called as? Twin peak sign. Now, if I say it is a marker of dichorionic, can you complete the answer? DC, आगे क्या लिखा होगा? Obviously, DA twins. Yes, as I told you, if it's DC, it has to be DA. Generally, when we ask you how many dividing layers should be present, if it is DC twins, the best answer is 4. But sometimes in image-based questions, you may not be able to count all 4. So if you are able to count even 3, the answer remains as dichorionic. Because if we talk about monochorionic, then they should have only 2 layers. So MCDMA, there will be 2 layers. Yes, T sign is, we will talk about it. It is actually a marker of monochorionic twins. Can you tell me DA or MA? Because MC can be DA, can be MA. T sign का मतलब है the membrane is meeting the placenta like this, but there is a dividing membrane. Whenever there is a dividing membrane, it has to be diamniotic, right? So T sign is MCDA. If you cannot count the number of layers, then you will focus on the thickness. If it is looking like a thick membrane, then it is dichorionic and diamniotic. If it is a thin membrane, then it is monochorionic. Also, if the image is showing you vascular connections, can you tell me if there are vascular connections on two sides, is it monochorionic or dichorionic? Vascular connections are a feature of monochorionic twins, not of dichorionic. Okay. Then the third set of MCQs that you get, especially in NEET PG, is twin-twin transfusion syndrome. This topic is also important with respect to any set, right? Now, there is definitely a single placenta, but there are communications. Yes. And can you tell me which type of communications? You will see them later. They are deep artery and deep vein. How do you make a diagnosis? Now you have to listen to me very carefully. To make a diagnosis, we need to do ultrasound. And on ultrasound, I have to see what? Oligo in one baby and poly in the other baby. Can you tell me which baby will have oligo? Donor baby. Whereas the recipient will have poly. What else? The recipient will also have polycythemia. And the donor will have what? Anemia. But anemia and polycythemia are not making a diagnosis. For diagnosis, we need what? Polyhydramnios and oligohydramnios. Okay. The name of the staging is Quintero. It has been asked in both exams, NEET PG as well as any set exams. Okay. Okay, just a minute. My screen, what has happened here? Okay, I'll just work on my screen here. Right, so now the staging is called as Quintero staging. So can you tell me when we talk about Quintero staging, ये इसमें कर देना बड़ा कुछ नहीं होता यार. Okay, so when we talk about Quintero staging, earlier NEET PG was only asking you about the name. Now they are asking you the staging as well, right? So very, very important. For staging, you need ultrasound and you also need Doppler, right? So let's look at this. Anytime an MCQ says Doppler is abnormal, then it is automatically definitely stage 3. Anytime the MCQ says either one or the other baby has hydrops, so one or both babies, if they have hydrops, then it is stage 4. If one or both babies die, then the stage becomes 5. So most of your exams are asking either stage 4 or stage 5. But you should know 1, 2 and 3 also. So Doppler abnormal is 3. How do you decide between 1 and 2? In both 1 and 2, the Dopplers are normal. So then how will you decide? You have to see if the bladder is visible or not. If bladder is visible of the oligo twin or the donor twin, yes, then it is stage 1. If the bladder is not visible, it becomes stage 2, right? So everyone clear with this? Yes, give me a thumbs up quickly. Okay, now please remember, we especially exams like INISET are fond of asking treatment. Yes, so what is the treatment? Treatment is going to be an intrauterine surgery. Okay, yes. So it is an intrauterine surgery, which means it is a fetoscopic procedure, right? I have to look at the baby. So this is going to be a fetoscopic laser ablation of the vascular anastomosis. How early can we do this? We can do it starting as early as 18 weeks. Okay, sometimes even at 16 I can start. I told you should know the type of anastomosis. So they are deep artery and deep vein. Some of the other complications that you should know of monochorionic twins that could be asked are TAPS and TRAP. Now TAPS में क्या होगा? It is milder form of the twin transfusion that we have talked. So listen to me. Definitely one baby will have anemia, the other will have polycythemia. But what will not be present, can you tell me? There will be no discrepancy in the amniotic fluid. Because if there is discrepancy in amniotic fluid, what does the answer become? Then it becomes twin transfusion syndrome. Okay. Please remember in TAPS, it is usually anastomosis between a superficial artery to a superficial vein. So these are superficial anastomosis, not deep. Now, when you talk about TRAP sequence, you should know this is the other name for acardiac twin. What is yet another name? It is also called as a parasitic twin or a monster twin. Yes. So, TRAP sequence is also seen in monochorionic twins. But here now it is going to be artery to artery anastomosis. So basically there is reversal of blood flow through the umbilical artery. So one baby is always getting deoxygenated blood. Usse kya hoga? Who's going to tell me? So this one baby who is getting deoxygenated blood, the upper part of the baby does not develop. So the baby doesn't have a thorax, no heart, no head, no brain. Right? So it is a cardiac. Is that clear to everyone? So it is surviving on the other baby. That's why it is a parasite or a monster. Yes? Now, please remember when you talk about another thing which is called as selective IUGR. Yes, have you heard about it? Can you tell me what is the criteria for selective IUGR? So one baby is IUGR but the other is not. So here the weight discrepancy should be how much? Should be more than or equal to 25%. That's when you say it is selective IUGR. Is that clear? Yes. What else? There can be death of one baby. So please remember in monochorionic twins, if there is a death of one baby, do you continue the pregnancy or do an emergency cesarean? Don't write emergency. You will say we will continue the pregnancy with close monitoring of the other baby. Okay. Right. Then when you talk about monoamniotic twins, which means there is no dividing membrane, the most specific complication here is cord entanglement. Again has been asked in exams and it will keep coming in your exams. Now, when we talk about conjoined twins, the best answer is parapagus. If it is not in the options, you can go with thoracopagus. Okay. How will you deliver a monoamniotic twin? So once you say monoamniotic, means no dividing membrane, they are always to be delivered by cesarean. Yes. And this cesarean section will be done between 32 to 34 weeks. Yes. Remember I mentioned the sign. Once you say MC twins, we said it is a T sign. But I told you a T sign would mean MC but DA. So T sign, is it a marker of monoamniosity? No. It is a marker of monochorionicity. ठीक है बच्चा? The next set of MCQs which NEET PG gives you is about the route of delivery. Yes, how will you decide, bache? So route is dependent on the presentation of the first twin. What do you understand as the first twin? The one that is closer to internal os, right? So if the first twin is vertex, then the answer will be what? Vaginal. If the first twin is non-cephalic or non-vertex, then the answer will be cesarean. Is that clear to everyone? Now, I want to ask you, if I draw a diagram here for you, okay, and let's say this is the internal os, and this is how I am drawing the babies. Can you tell me what would be the mode of delivery? Jaldi batao. So this is the os. So now tell me, is the first twin cephalic? Yes. So should you do a vaginal delivery? The answer is no. Why? Although the first twin looks cephalic here, the answer is still cesarean. Who is going to tell me why? I have not drawn a dividing membrane. I have drawn monoamniotic twins. Okay, these are monoamniotic. Had I drawn it the other way round, so if I had drawn like this, now what is the answer? So in this case, I have drawn a dividing membrane. Yes, and the first baby is cephalic. The answer will be vaginal delivery. Is that clear to everyone? I hope you will not make a mistake. Yes? Okay, perfect. Remember, if the first twin is breech, okay, and second is vertex, what complication can happen in case you do a vaginal delivery? What complication? It can be twin interlocking. So that is why you have to do a cesarean. Quickly tell me, if the second twin is transverse lie, what will you do? Kaun batayega? So if the first has delivered, okay, and the second is transverse lie, what would be your answer? Your answer has to be IPV, internal podalic version and breech extraction. This is a very probable MCQ for this year exams. Okay, so it will be IPV and breech extraction. Don't answer it as external cephalic version. Okay, perfect. So the next topic we go on to is going to be RH negative. Again, some very basic question comes and they're all conceptual. So if you know the funda, you will not do them wrong. Remember, any MCQ, yes, where they write ICT is positive. Yes, this means the woman is already sensitized. So she is making antibodies, and that is why there is fetal risk. On the other hand, if ICT is negative, it means she is not sensitized, and as of now there is no fetal risk. Now understand, as of now there is no risk, but it can happen later. So out of the two conditions, ICT negative and ICT positive, where would you want to give anti-D prophylaxis? So very, very important, and I will talk about it. Please remember, any time we write ICT is positive, there is no role of anti-D because she is already making antibodies. So you can't do anything now with prophylaxis. Perfect. Once you say the MCQ has written ICT is positive, you need to focus on the titer. Okay. Significant is anything more than 1:16. So please remember, if the if the titer is more than 1:16 and we are asking you next step, what will you mark? Now you have to see whether there is anemia or not. Right? So your answer becomes MCA Doppler. Can you tell me what do you understand by more than or equal to 1:16? So this is 1:32, 1:64. This is what is considered as more than. Okay? Now I want to ask you, suppose the titer is less than 1:16. Then what will you do? So if it is less, you don't need to do MCA Doppler. You will simply repeat ICT after 4 weeks. Is that clear? Now, moving further. Suppose you have done the Doppler studies. We are fond of asking you the cutoff. The cutoff we use is 1.5 and the units are multiples of median, MOM. right? That is the cutoff we need, and it is asked in the exams, because if it is more than this, it means there is anemia. So now what are you going to do? Listen to me very carefully. If the value is more than 1.5, focus on period of gestation. If the gestation is less, then you will do chordocentesis. If the gestation is more, then you will deliver. Is that clear? I also want to ask you, can you tell me what will you do if the MCA PSV is less than 1.5? तब क्या करना है? Then you will simply answer it as repeat Doppler. Okay? So you repeat Doppler at 2-week intervals. You don't need to do a cordo, you don't need to deliver. Yes? Then as far as INICET is concerned, they are very fond of asking these value-based questions. So you should know at what hemoglobin level can the baby develop hydrops. So if they are asking about hydrops, the hemoglobin level will be less than 5. If they are asking at what level should you do intrauterine transfusion, then the answer is 8 grams. So very, very important, students get confused. Okay. So 8 grams is the hemoglobin. Hematocrit is 30. For what? Intrauterine transfusion. For hydrops, what is the answer? Hemoglobin less than 5 and hematocrit less than 15. Okay, so I know these are factual things, but you need to recall them. They are PYQs. Also, hydrops is a new MCQ your exams are trying to ask. So understand this. When we ask you about hydrops, it can be immune or it can be non-immune. What is more common is non-immune. Okay, so it is non-immune. Now, in the non-immune, the most common cause is cardiovascular anomalies, but the second most common is anemia. When we ask you about non-immune causes, it can also be infections. Which are the 2 infections that you should remember for hydrops? You should remember parvovirus and syphilis. So yes, they are the most important ones. Remember, HIV and HBS, they do not cause hydrops. For that matter, even HSV, simplex, it also does not cause hydrops. To make a diagnosis of hydrops, what do you need? You need a ultrasound. Yes, so ultrasound पे क्या मिलना चाहिए? Ultrasound पे I have to see fluid in 2 compartments. So it could be ascites and pleural effusion or a pericardial effusion or a subcutaneous edema. I need in at least 2 compartments to say it is hydrops. Hydrops के pregnancy में और क्या मिलेगा? Anybody knows? You will also see placentomegaly and you will also see polyhydramnios. But please remember, placentomegaly and poly are not diagnostic. For diagnosis, I need fluid in 2 compartments. Yes? Okay. Coming to some important things that you should know about anti-D. Most important thing is you should give anti-D only when Coombs test is negative and blood group is positive. Now the Coombs test can be indirect or it could be direct, but the concept remains the same. Coombs test कैसा होना चाहिए? जल्दी बताओ. Negative. Blood group कैसा होना चाहिए? The baby's blood group should be positive. If we ask you the dose, the standard dose is 300 micrograms. If I ask you the best time to give it, it is 28 weeks. Yes? Now, please understand this application. When we are giving this 300 micrograms, this is 1 vial. It is effective for 30 ml of FMH, feto-maternal hemorrhage. So it can neutralize 30 ml of FMH, 15 ml of fetal RBC. Yes. So if the blood loss is less than this or up to this, the dose will remain as 300. If the value goes beyond, so as you can see here, so up to 15 ml and 30 ml. If the value goes beyond this, right, so it is more than 30 ml, then what do? Yes, then I have to do a special test. This special test is called as KB test. Okay, and it is a lab test. Okay, so it is a lab test. It's not a bedside test, and it is quantitative, not qualitative. And you always have to round off to the next dose. For example, if I say hemorrhage is 45 ml, can you tell me how much will you give? So will you give 1.5 vials or will you give 2 vials? So if you do the calculation, okay, thank you for reminding me. So if you do the calculation, then please remember it will be turned out to be 1.5 vial. Do we give 1.5? No. So your answer will be next higher dose. So yes, you will say give 2 vials. Perfect. Should I repeat anti-D after delivery? Yes, within 72 hours, provided the baby's blood group is positive and the direct Coombs test is negative. Okay, so these are very, very important things. Yes? Chalo. The next thing is preterm labor. So again, we will do it in a short mode because the concept is more important rather than the values here. The values which we are fond of asking is this. If your patient has a history of preterm labor, she is at risk of preterm labor again. So in all these patients, we should do a cervical length assessment in second trimester. So if the cervical length is less than 25 mm, then what do? This is another indication to put a cerclage. Yes. Also, you have done this with me before. Whenever we put a cerclage, we will also add progesterone for prophylaxis. How they will twist things for you is this. If there is only history of preterm labor but the cervix is not short, then what are you going to do? Then you will give only progesterone. Okay, you don't need to add cerclage. Can you tell me another predictor we use for preterm labor? Kaun batayega? Anyone? So another name of the predictor that you have to know here is FFN, fetal fibronectin. So if this is positive, then again your patient is at high risk. Please remember, should I give cerclage if labor has already started? No. Never put cerclage if contractions have started. Okay. Remember, I told you contractions are a contraindication. So cerclage is not the treatment of preterm labor. It is only used for prevention. Very good. Good job. Now, I am going to not go on to the details of what I have written because they are unlikely to ask you values because values are different in US, UK, everywhere. What I want you to remember is this. Any woman who has 6 contractions in, please correct this, 60 minutes, which means if she has 1 contraction in 10 minutes, okay, so if this is associated with any cervical dilatation, are you listening to me very carefully? So concept is, if there are contractions, even if it is 1 in 10 minutes and it is associated with cervical dilatation, should you consider it as preterm labor? The answer is Yes, we should. This is the take-home message. Although different countries are following different guidelines. For example, as far as UK is concerned, they want the cutoff to be 5 centimeters. If you consider US, they are taking it as 3 centimeters. If you consider older guidelines, the cutoff was 2 centimeters. So you can't remember all of this and they can't ask you this. So what you should remember is, even if there is one contraction in 10 minutes, bringing about cervical dilatation, you should consider it as preterm labor. Is this part good? You just have to remember this. Can you remember? Okay. The second thing which I want you to know, when we ask you high risk for preterm labor, is what cervical length? Then they are only asking you risk. The answer remains is less than 25 mm. If I ask you what length is used for diagnosis of preterm labor, then you should say length less than 20 mm. Okay, so length less than 20 mm. Yes, that is what we use for diagnosis. Now understand, what will happen if the length is between the two? It is between 20 to 30 mm. Then to make a diagnosis, we are going to use maybe some other criteria like fetal fibronectin. Is that understandable? So if the values lie in between, I would need more criteria. Is that clear? No, so preterm labor is any labor before 37 weeks, बच्चे. ठीक है? Now listen to me more carefully. Rather than diagnosis, we are more fond of asking you management. So what should you know? Now, what all are you going to give for management of preterm labor? Should you give steroids? Yes or no? Yes. We will give antenatal steroids for lung maturation. In India, the drug of choice is dexamethasone. All of you have to remember the dose. It is a PYQ twice. So 6 milligrams, 4 doses, 12 hours apart, intramuscular. What will be the dose of betamethasone? 12 milligrams, only 2 doses, 24 hours apart, again intramuscular. So that is for betamethasone. Should you give tocolytics? Yes, but listen to me carefully. You will give tocolytics when the POG is less than 34 weeks. We don't give beyond 34. And overall, the drug of choice is nifedipine, which is the calcium channel blocker. When will you add Magsulf? Batao? Magsulf is added only, I have taught you this before, only if POG is less than 32 for neuroprotection. Is that clear, bacha? This I have already covered for you. Indomethacin can be used if the POG is less than 32, because beyond 32 it will cause premature closure of ductus arteriosus. Can we use Magsulf? Yes, because it is a tocolytic, but it is a very mild tocolytic. So generally it is not effective as a tocolytic, but it does have some action. Then you should remember this new drug. What is the name? Atosiban. Okay. Atosiban is a oxytocin receptor antag. Don't confuse this with carbetocin. What is carbetocin? Oxytocin agonist or a analog. Okay. So it works like, remember, like oxytocin. Okay. Whereas atosiban is antag. Yes. So A for antag. Typically you will answer atosiban when we have to answer tocolytic in heart disease. Is that clear? Yes. Because in heart disease, you don't want to give nifedipine. So a better answer becomes atosiban. Can you tell me which tocolytic will you give before, let's say, external cephalic version? So now it is not nifedipine, it is not atosiban. Here we give terbutaline, which is a beta agonist. Okay. Similarly, if there is a hyperstimulation, if the contractions are more, which tocolytic will you give? Again, the answer will be terbutaline. Yes, is this part clear? So give me a thumbs up if it is clear, and I move to the next topic. Yes? Chalo. So next topic has been now being asked more and more in the exams. Earlier it was asked less. So it is about antepartum fetal monitoring. Yes. So when you talk about monitoring, one of the most important things is monitoring the amniotic fluid. Can you tell me why? Because if the amniotic fluid becomes less, okay, it is a marker of chronic uteroplacental insufficiency. Yes, and it is important for us. Similarly, if the liquor is more, it will also cause certain complications, right? Now, these are factual things and you should not do them wrong. Remember, when you are measuring amniotic fluid, we can use two things: single deep pocket or amniotic fluid index. 2 to 8 is what is normal for single deep pocket, and 5 to 24 is what is normal for amniotic fluid index. What do we use more commonly? More commonly used is amniotic fluid index, which should be used in a twin pregnancy, single deep pocket. So in multifetal pregnancy, we cannot use amniotic fluid index. We will use single deep pocket. Is that clear? Okay. Now, so if you remember normal, you will remember what is oligo, you will remember what is poly. Now, these days in the exams, they are more commonly asking you causes and associations. So, try and understand what I am trying to tell you. Whenever you have a patient of oligo, the first possibility is she is maybe having ruptured membranes. So if we ask you a patient has come with oligo, what is the first thing you do? What will you answer? You should answer as upper speculum exam, because you will see fluid coming out. Next important thing. If we are talking about oligo, and oligo is early onset, which means it has happened in the second trimester itself. Think of renal abnormalities. Okay, so it could be renal agenesis, or it could be a outflow obstruction like a posterior urethral valve. Yes. PYQ, what is the typical sign that you see on ultrasound if there is a posterior urethral valve? It is called as a keyhole sign. The bladder is distended and so is the urethra, right? So you will see the keyhole sign. Yes. Now is the most important part. So if you see oligo in third trimester, this is how NEET PG is asking you. In the third trimester, you have to think of uteroplacental insufficiency. In third trimester, don't think of anomalies. Okay, very, very important. Then, factual things. But if pregnancy becomes post-term, can you tell me what is post-term? At and beyond 42 weeks. Obviously, there will be oligo. Okay. If the baby dies, there will be oligo. Can you tell me why? So you have to know that the main source of amniotic fluid is fetal urine. Let me ask you, when does urine become the main source? It becomes the main source beyond 20 weeks. Okay. If I ask you what is the main way of removal, then it is swallowing. Yes. So please remember, as I said, these days your exams are asking clinically applied MCQs. So they are more fond of asking the associations. For example, any set will ask about Potter's syndrome. So what is Potter's? Potter's may there is severe oligo because of renal abnormality. Because of this oligo, the baby has pulmonary hypoplasia and the baby has compressed facial features, right? So typical facial features of compression. So this is what is Potter's. NEET PG on the other hand will ask you about amniotic band syndrome, also called as Streeter's syndrome. Now, as I said, for Potter's, the key word is renal abnormality. Can you tell me for amniotic band, what is the key word? The key word here is constriction rings. Okay, constriction rings or digital amputation. This is what you see with amniotic band syndrome. Yes. Now, okay. Potter's sequence is when the same combination is seen, but the cause of oligo is not renal. There is some other cause of oligohydramnios. Then you say Potter's sequence. When the cause is renal problems, then you say syndrome. Okay. Now, in amniotic band syndrome, please remember the main problem is limb defects, so distal amputations, okay? And the second is craniofacial anomalies, okay? Then, important, clubfoot. Clubfoot is also a compression defect. So, whenever there is a, oligo, there is compression of the fetus. So, this will cause clubfoot or CTEB. Very, very important, NEET PG will ask you. Remember, whenever there is oligo, there is compression. So, can there also be a compression of the umbilical cord? Yes. So, if they ask you a patient of oligo, so I think 54, there is a patient of oligo. Today, I am doing a NST. Which abnormality will you see? What will you answer? You will see variable decelerations because of compression of the cord. Then, very common associations are IUGR. Can you tell me why oligo and IUGR are seen together? Because the pathophysiology of both is same. It is uteroplacental insufficiency. Okay, are we good? Give me a thumbs up because these are very important recent pattern MCQs. Yes, coming to associations of polyhydramnios. So when you say polyhydramnios, the first thing you have to understand is, remember, it happens when the baby can't swallow. So you have to think of GIT abnormalities and maybe neural tube defects, because basically swallowing is a reflex, right? So if there is anencephaly, there will be polyhydramnios, okay? Second very important thing for poly that you have to think is diabetes. So whenever we are saying your patient is in the third trimester, now she has developed poly, what test should you do? Should you say it is because of anomalies? No. Okay. Rather think of diabetes. Yes. Then, whenever there is hydrops fetalis, there will be polyhydramnios. Why? I have written the reason as well. The explanation is, in fetal hydrops, the baby will do polyuria. Then some uncommon things like Bartter syndrome again has polyuria. So not only reduced swallowing, excessive urine will also cause poly. Yes. And I have always asked you to remember syphilis and parvovirus for high drops. Twin-twin transfusion is very unique. Can you tell me why? Twin-twin transfusion syndrome is one condition where I have taught you, you will see poly also and you will see oligo also. There is poly in one baby, oligo in the other. What are important associations? So remember, if there is gross polyhydramnios, my patient will come with breathlessness. So they will say your patient has come with breathlessness and they will say AFI is 30. What should you do? The answer will be do amnio reduction. You will have to reduce the fluid. Remember, poly is a very high risk factor for abruption. It is a very high risk factor for preterm labor and rupture of membranes. Okay. It is also a very high risk factor for cord prolapse. Why? Because if membranes rupture, the cord will fall out. A standard and a very important thing. Whenever we talk about cord prolapse, you have to know the general management is emergency cesarean. But I want you to tell me what would be the next step in cord prolapse. So remember, the most important thing is relieve the pressure on the cord. The cord is being compressed by the head. So what do? Number one, you put your finger in the vagina and lift up the presenting part of the baby. You push it up. What is the second thing? You can do a retrograde filling of the bladder. Yes. What is the third thing? If you can't do these things, then you can put her in certain specific positions. Which positions? Yes. So Trendelenburg position, or I can even put her in a knee chest position. So while doing these things, you shift her to OT and then you will do a emergency cesarean. Okay. Chalo. The next way how we monitor the baby is by doing a biophysical profile. Yes. Can you tell me, when we say biophysical profile, is it more reliable than any other method? Yes, it is a very reliable method of fetal monitoring. Okay. It is also called as Manning score and it is done using a ultrasound. Yes, so you have to do an ultrasound for 30 minutes. Now when you are doing a biophysical profile, you are going to measure these 5 components of fetal well-being. Okay. So what are those 5 components of fetal well-being? Remember this. Okay. Number 1 is fetal breathing. Then it is gross body movements. Sometimes the students get confused. Is it same as daily fetal movement count? No. This is not DFMC. Daily fetal movement count is what is perceived by the mother. Here when we are writing gross body movements, they are seen on ultrasound. Okay. Then we do a tone assessment. We do amniotic fluid. Again, in biophysical profile, I don't need to do a amniotic fluid index. I can only do SDP. A single measurement is good enough. And we also add NST. Now, so far they haven't asked you about interpretation, which can come now in the exam. So please remember this. If a score is between 8 and 10, you take it as normal, especially if the amniotic fluid is normal. Okay. If the score is 6, you call it as equivocal. Okay. And you will repeat the profile on same day. So within 24 hours, you have to repeat the profile. If the score is written as anywhere between 0 to 4, then it means the baby has acidosis. In fact, we say if the score is less than or equal to 2, there is 100% acidosis, right? So between 0 to 4, we have to do a immediate delivery by cesarean section. Okay. Something which INICET has repeatedly asked in their exams, what is modified biophysical profile? So when you say modified profile, it is NST and amniotic fluid. Here, yes, we usually measure amniotic fluid index. Yes, very good. Okay. Can you tell me if there is hypoxia? Okay, so if there is hypoxia, which parameter of the baby will first become abnormal? It is NST. So the first thing that you will see here is loss of acceleration. Then it will be breathing movements. They will become absent. Then it will be body movements. They will reduce. Then it will be tone. What is the last thing? Can you tell me? The last will be, you will see loss of beat to beat variability and decelerations. Yes, that will be the last thing, which means the baby is about to die. Yes, so when I ask you last, it is loss of beat to beat variability with decelerations. So you should know the order of damage when they ask you about hypoxia. Is that good? Give me a thumbs up if you're good with this. Then we proceed on to the third method of monitoring the baby, which is going to be by umbilical artery Doppler or other Dopplers, right? Now, remember, umbilical artery Doppler is what is used most commonly for picking up uteroplacental insufficiency. Who is going to answer? If I am suspecting UPI, yes, what parameter do I study? So we will study PI. What is PI? Pulsatility index. So if there is UPI, this index will be more than 95th percentile. Okay. Now, you should know apart from PI, what else can we study? So we can study the SD ratio, blood flow in systole to blood flow in diastole. Okay. Normally, if it is a normal pregnancy, the SD ratio should decrease. If you see an SD ratio which is increasing, then yes, the baby or pregnancy has UPI. So it is not more than 3 weeks. ये weeks नहीं होना चाहिए वहाँ पे. It is just a value of 3. So SD ratio more than 3 beyond 28 weeks is UPI. Okay. These graphs we will cover in the image based topics as well. So but very quickly, I am sure you should be able to pick it up. What graph is this, bache? So answer is already written there. Yes, this is a graph of absent end diastolic flow. Are you all able to appreciate? Yes. So there is no flow during diastole. Yes. So this is AEDF. Remember, the cutoff we use for AEDF is 34 weeks. So if pregnancy crosses beyond 34, we will do a termination. Can we do vaginal delivery? Yes, we can. It's not contraindicated. Okay. What will you do if she is less than 34? Then simply you give steroids, you monitor, right? So this is what you do if she is less than 34. Okay. Similarly, your exams are fond of giving you graphs of reversal. It's a very characteristic graph. Are you able to see this one? So do you see this flow which you see in the bottom part? Below the baseline there is a flow. Focus on that part. So once it is reversal, the upper limit for continuing the pregnancy is now 32. So once she reaches 32 or crosses 32, we have to do a termination. And here again, we will prefer cesarean. Okay. Be very careful. They will give you a POG less than 32. So if it is less than 32, as I said, what will you do? You will do this. You will give steroids. You will do monitoring. But now we have also added Magsulf. Can you tell me why? Neuroprotection. Yes, neuroprotection. Be very careful. Your exam, so I'm going to give you the next application, I think 55. If she is less than 32 weeks with REDF, but they are writing she has late decelerations. What do you do now? Please don't answer it as conservative management. I have just now given you the concept. If you are seeing late decelerations, it is a bad sign. Now you should not wait. What will you answer? Emergency cesarean. Yes, is this concept clear? Very good. I'm so proud of all of you. Very nice. Okay. Some of the other Dopplers that I have already talked about is, yes, uterine artery Doppler. So we usually use it for prediction of early onset preeclampsia. And I told you we do it between 11 to 13 weeks. Can we use it anywhere else? Yes. We can also use it in diagnosis of IUGR. And it is the same concept. We use pulsatility index. If it is more than 95th percentile, it is abnormal. Okay. MCA Doppler we have already covered. If we ask you what is the best use of MCA Doppler, don't answer IUGR. Okay. Please remember, in IUGR, MCA will initially show you what? Can you tell me? It will initially show brain sparing, which means the flow will not be reduced. It will be rather increased. So, if in IUGR, if MCA Doppler is abnormal, it's actually a very late finding and it's not good at all. Yes. So therefore, if we ask you best use, you have to answer it as fetal anemia. Okay. Remember the cutoff, it is NEET PG PYQ. The cutoff is 1.5 multiples of median. Yes. So these are some of the important things. The NST graphs we will cover in, the visual session that we will hold for you. Okay. Now, coming to the next part, which is important, postpartum issues that we should know. Okay. The first thing which is most commonly asked is postpartum hemorrhage. So this is what I'm going to talk about initially. Remember, the standard definition still is followed. What is the standard definition? Blood loss more than 500 ml after a vaginal delivery or more than 1000 ml after a cesarean. But do you know that recently there is an update? Yes. So in the update, now the guidelines say another definition is if the blood loss is more than or equal to 300 ml, okay, and there is any one of the following. Can you tell me what are those things? So there are 4 things. Number 1, heart rate more than 100. Number 2, systolic blood pressure less than 100. Number 3, diastolic blood pressure less than 60 or shock index more than 1, right? So even if blood loss is 300 ml, but any of these happen, will I still call it as PPH? Yes, we will still call it as PPH. Okay. Always NEET PG is asking questions and definitions. They keep coming repeatedly. So you will call it as a primary PPH If it is happening within 24 hours, can you tell me what is the cause when I say primary? So for primary, remember the cause is atony. Okay. If we ask you about secondary, this is where some students do a mistake. It is not up to 6 weeks. So it is beyond 24 and up to 12 weeks. So if I ask you cause of secondary, then what will you answer? Answer it as retained placental tissue. Okay, for secondary it is retained placental tissue. Yes, the update is for both. Obviously, na beta, if there is hemodynamic instability, you can't wait for 500 ml. You have to wait, you have to then decide that it is PPH. Okay. Now, one place where directly risk factors are asked is PPH. So, you need to know this. Now, I will ask you certain things which you need to know. So, number one, when you say retained placenta, the diagnosis is made beyond 30 minutes. The management is MRP. We will talk about it. Yes, it is by itself a risk factor. Okay. Second, any patient who has had a manual removal in the previous pregnancy also becomes a risk factor. When would you say it is precipitate labor? If it happens within 3 hours, if the total duration is less than 3 hours, it is precipitate, it is a risk factor. Even prolonged labor is a risk factor. Anytime you do instrumental delivery or you induce labor or augment labor, they are all risk factors. I told you generally primary gravida is a risk factor for everything. Only very few places the answer is multigravida. What was the previous one place I taught you? So previous one place where I taught you multiparity was peripartum cardiomyopathy. The second place is PPH. Any patient who has any placental abnormality, it could be placenta accreta or it could be other types of placental abnormalities. For example, it could be succin curiata, okay, it could be Battledore. So, placental abnormalities are a risk factor. Obesity is a PYQ in any set exams. Yes, it is a risk factor. Certain medical complications like preeclampsia is a very important risk factor. Diabetes and anemia are risk factors. Okay. Any kind of placental abnormality, whether it is abruption or placenta previa, they are risk factors for PPH as well. So you should know this. Okay. So now somebody was asking me, ma'am, when would we answer genital tract trauma? So very important. In the exams, if we are saying a patient is having PPH, but uterus is well contracted, that's your keyword. When we say uterus is well contracted, then you answer the cause as genital tract trauma. Is that clear? Yes? Okay. Now we will talk about prevention of PPH. Again, some recent changes are there, so I will also give you the changes. So this is what is AMTSL. So now, please remember, as per the new guidelines, which are the only drugs allowed in AMTSL? So now, only 3 drugs can be given. It can be oxytocin, it can be carbetocin, or it can be misoprostol. Okay? We are not supposed to use methergin now. We are not supposed to use sintometrine now. We are not supposed to use other prostaglandins like PGF2 alpha. We will not even use Tranexa for prevention. So these are the only 3 drugs approved now. Okay, the doses are quite the same. So let's look at this. For oxytocin, it remains as 10 international units. Which is preferred? Can you tell me? IV infusion or IM? Although IM is given, but IV infusion is preferred. Why? Can you tell me why? Because of faster action. So remember, in oxytocin, IV infusion is to be preferred over IM even as per the new guidelines. Okay. Also again as per new guidelines, should I be doing Ritgen maneuver? No. No routine Ritgen. Also, no routine massage of the uterus. So no routine massage for prevention, no routine Ritgen maneuver. These are all important things. We have taught you this, but I am reinforcing. Okay. NEET PG goes into a little more depth of these drugs. So please remember, they will ask you, why do we not give IV bolus? Because it will cause severe hypotension. Okay. The doses of other drugs. So I will now focus on carbetocin and miso. Carbetocin dose is same as mentioned here. So 100 micrograms. Slow IV over 1 minute or 60 seconds. Misoprostol, the dose is 600 micrograms oral, but as per the new guidelines, we can even give 400. So they are saying 400 to 600 micrograms. Okay. Are we supposed to do a delayed cord clamping? Yes, delayed cord clamping is universal guideline. I am reinforcing. This is how I have taught you. Even the new guidelines have taught the same thing. When would you do early cord clamping? Early is to be only done if we need neonatal resuscitation. Is that clear to everyone? Yes? Okay. Please remember, no routine uterine massage. What is the important thing in controlled cord traction? Yes, you have to know the name. The name is modified Brand-Andrews method. But please remember, for controlled cord traction or modified Brand-Andrews, we need what? We need trained obstetricians or birth attendants. So if you have trained obstetricians or other birth attendants, then yes, we will do controlled cord traction. We are not supposed to do massage, but can we do intermittent tone assessment? Yes. Intermittent tone assessment should be done every 15 minutes. Okay. This is a standard PYQ, many times asked. They give you a question on not a component. Okay. And if both are in the options, early component and massage, both are incorrect. But what is the better answer? Early clamping. Okay. Can I do bimanual compression in AMTSL? Never. हम मसाज ही नहीं कर रहे, बायमैनुअल तो बहुत दूर की बात है. So please remember, in AMTSL, never ever answer bimanual massage. Okay, good. This is the same algorithm that I have taught in class, so I have put it here. Okay. In early, as far as Indian guidelines are concerned, NACO guidelines say avoid clamping, delayed clamping, but WHO is sticking to what it has taught. WHO says delayed clamping in HIV. Okay. So if the word WHO is mentioned, you answer it as delayed. Otherwise, you can mark early. Okay. Now, whenever there is PPH, the first thing is call for help. start uterine massage, secure IV cannulas, start fluid and give oxytocin, and at the same time start uterotonics. Now in the management of PPH, now we are managing, it's no longer prophylaxis. So in the management, I can give more drugs. So I can give oxytocin, miso, Tranexa. In fact, Tranexa has to be given to everyone, 1 gram within 3 hours. So when we are treating PPH, Tranexa has to be given to everyone. Is that clear? Give me a thumbs up. Now, if these drugs do not work, she is still bleeding, then you can give more uterotonics like carboprost. You can even give methergin. Yes, so we can give carboprost, we can even give methergin. Yes, is that clear? Carboprost pe you have previously got questions in NEET PG. So you should know the dose. Carboprost is 0.25 milligrams or 250 micrograms. Okay. I can go up to 8 doses at intervals of 15 to 30 minutes, which means a maximum dose is 2 milligrams. It's a PYQ, NEET PG, very important. Okay. Now, please remember, as I said, I can give carboprost also and I can give methergin. How do we decide which one do we give? So, remember, for methergin, preeclampsia is a contraindication. So, if the patient is preeclampsia, you answer it as carboprost. For carboprost, what is a contraindication? Asthma. Okay. So, if they are saying patient has asthma and she is still bleeding, then you answer methergin. Is it understood? I have already taught you that carboprost is not used in AMTSL. I have also taught you do not use it in induction of labor, or in MTP you still can use it. Now listen to me very carefully. Suppose you have given all these uterotonics and the patient is still bleeding. Yes, along with uterotonics, you should do balloon tamponade. Okay. What is the maximum fluid I can give? 500 ml. I want to ask you, can we put gauze pieces in the uterus, which is called as uterine packing? The answer is no. So even as per new guidelines, uterine packing is not to be done. Okay, nahi karna. Yes. Okay. Next. Suppose you have done a balloon tamponade, she is still bleeding. Then you focus on vitals. If the vitals are unstable despite a tamponade, you will begin stepwise pelvic devascularization. I hope you remember, in stepwise pelvic devascularization, the first artery is uterine. The second is ovarian, but it's not the main ovarian. It is basically utero-ovarian anastomosis. Okay? What is the third artery? The third artery is internal iliac ligation. Yes, so that is what is stepwise devascularization. You have to know it. Okay? Yes, so if you have ligated both uterine artery and ovarian artery, how is the blood flow coming to the uterus? So then through the artery of the round ligament, it is still getting some blood. Okay, later collaterals will form. Yes. Now, if you have done balloon tamponade and the vitals are stable, then you can do embolization. But embolization may not be available. So then we can move on to uterine compression sutures. The most commonly used compression sutures are B. Lynch. Can you tell me where do you put these sutures? Kahan lagane hain? Who is going to tell? The When I say uterine, it doesn't mean uterine artery. It means on the uterus. Okay. Also, please remember, compression sutures are only useful if it is atonic PPH. It will not work for traumatic PPH. Okay, is that clear? Atonic. Can you tell me what is this arrow that I have drawn? Suppose the vitals were stable. Yes, and you have put a compression suture and she is still bleeding. So if she is still bleeding despite your compression sutures, now again you will have to do a stepwise pelvic devascularization. So is the algorithm clear for everyone? Yes? Chalo. Next, some of the important things that your exams are fond of asking. I told you, you will mark trauma to genital tract. Yes, when the uterus is contracted and she is bleeding. The risk factors are precipitate labor and instrumental delivery. How do you prevent perineal tears? Very important. As I said, you will give warm compresses. You can give a perineal massage. Obviously, you will support the perineum. And you have to control the rate of delivery. How do you control the rate of delivery? It is maintain the head in flexion. Yes? Now, earlier we were saying we can do modified Ridgen to prevent this delivery. So what are the new guidelines I have told you? I have told you new guidelines say not to be done routinely. Is that clear? But if they still ask you, what is modified Ridgen maneuver done for? What will you answer? Batao? You will answer prevention of perineal tears. Give me a thumbs up if this is clear to you. Yes? Okay. Retained placenta. As I said, NEET PG is fond of asking this. What would be the key word here? More than 30 minutes have passed. Okay? So the reasons for retained placenta could be placental abnormalities like a Battledore or a placenta accreta spectrum. In general, when they ask you treatment of retained placenta, I have told you the answer is MRP. Suppose your examiner goes a level higher, okay, and they are saying on MRP, zone of separation not found. Then what do you think you are dealing with? So if you cannot find the zone of separation, this is what tells you you are dealing with PAS. So don't force. Rather go and do what? Go and do hysterectomy. Yes? So you will have to go ahead and do a hysterectomy. Is that clear to everyone? Very good. Uterine inversion is a recent topic which is being asked in all exams. So I'm sure you would know most of the things, but I have to ensure you don't do them wrong. So when you say uterine inversion, when will it happen? It will happen if you are pulling on the cord without giving a counter traction on fundus. So you have to pull the cord out and push the fundus up. So if you don't do that, then you will pull out the uterus. Very important. What would be the clinical presentation? The MCQ will say shock immediately after delivery. Also remember the shock is out of proportion to blood loss. So it is not a hypovolemic shock. Yes? Can you tell me? Yes, this is neurogenic shock because of the pull on the ligaments. Yes, beta, I have already written it in risk factors. Placenta succinuriata and Battledore are all risk factors for PPH. Succinuriata is not a risk factor as such when we say for inversion. Okay. Yes, the smaller lobe is left behind, so it causes PPH. Yes. Then, as I said, the bleeding will be mild, right? Usually the bleeding is less, but shock is more. What would be the local examination finding? You will see a reddish mass lying outside vagina. What is the typical finding on per abdomen examination? Very, very important. Fundus is not felt. Yes? Now, please remember when we talk about management, the first thing that you are going to do is stop oxytocin, and you will immediately do what? Manual repositioning. Can you tell me what is the name of this method? So manual repositioning is Johnson's method. Yes. If placenta is still attached, do you remove it? No. So do not remove the placenta. Let it be attached. Okay. Where is manual repositioning done? It is done in the labor room, not in OT. Now I want to ask you this. Suppose you have done a manual repositioning and it is successful. Now what are you going to do? Are you going to now separate the placenta or do something else? Do not separate placenta. The next step will be begin oxytocin. Now you want the uterus to contract so that it doesn't fall out again. Yes, so that it doesn't bleed more. If this is not successful, then what do? So you have to see the vitals. If vitals are stable, you can try repositioning again. Okay, so you can give tocolytics and try repositioning again. Or you can even do a O'Sullivan's method. What is O'Sullivan? Hydrostatic. Remember, these are done when the repositioning is not successful and the patient is stable. If your repositioning is not successful and the patient is unstable, then what do? Then please don't answer tocolytics and O'Sullivan. Your answer should be now laparotomy. Okay, the name of the method is Huntington. So is the algorithm clear to everyone? Please give me a thumbs up if the algorithm is clear to everyone. Yes? Okay. The next important topic that is being asked in the exams is amniotic fluid embolism. Right? So now when you talk about embolism, the classic triad is sudden onset of breathlessness plus hypotension or shock and DIC. Okay. So if you see these three things together, this is how you say it is amniotic fluid embolism. Out of this, DIC is what you see in the second phase, as I have written here. So in the second phase, you will see DIC. In the first phase, you will see shock and breathlessness. Most cases will happen within 30 minutes of delivery. It's not a delayed complication. Okay. Cesarean delivery is the most important risk factor. Yes, there are other risk factors as well, but cesarean is the most important risk factor. How do you differentiate this from peripartum cardiomyopathy? There also there is cardiorespiratory symptoms, but in peripartum cardiomyopathy there will be no DIC. Please remember this. Okay, so there is no DIC, right? Now we are quickly going to cover the changes in purpurium, which is a very factual thing, but it has now started to come in the exams. Yes, so yes, please remember, anytime there is a maternal death because of specific things to pregnancy, like amniotic fluid embolism, like PPH, we call it as a direct maternal death. On the other hand, if the cause is, let's say, heart disease or anemia, then it is a indirect maternal death. Okay. Can you tell me for maternal death, what time period do we consider? Up to 6 weeks postpartum. Yes? Chalo. So as I said, changes in purpurium is a recent topic which NEET PG has started to ask. Earlier they were not asking, right? So remember these important ones. I have put the ones which are more likely to be asked. Okay. For example, immediately after delivery, the position of the uterus is at umbilicus, actually just below umbilicus. So we answer it as 20 weeks. Cause of after pains is oxytocin. So when the baby suckles, oxytocin is released and it causes uterine contractions. If your postpartum patient is having shivering, the reason is most likely blood loss or a drug which is misoprostol. So yes, misoprostol causes fever with chills, hyperthermia. Okay. If we talk about involution of the uterus, remember in the first 24 hours, there is no change in the position. So change will happen only after 24 hours. So if we ask you on the second day, where is the uterus? What will you answer? It is 1 finger breadth below umbilicus. Okay. So after that, it keeps reducing by 1 finger breadth per day. So on second day, it will be 1 finger breadth below. Okay. By 1 week, it lies exactly in the middle, midway of umbilicus and symphysis pubis. Okay. By 2 weeks, this is important, it will become a pelvic organ again. Right? Now, sometimes NEET PG asks this question. The option is not 12 weeks, 2 weeks. The options are like 10 to 12 days or 12 to 14 days. So then the precise answer is 10 to 12 days. Okay. Complete involution will happen by 6 weeks. That is why we call up till 6 weeks as purpurium. Okay. Order of lochia is a simple question. So for first 3 days, it will be rubra, red in color. Then between 4th to 9th day, it is serosa, usually yellow. And beyond 10th day, it is going to be alba. Now remember, lochia can be normal up to 6 weeks, although the average duration is 4 weeks. Yes, but it is normal up to 6. Anything beyond 6 is not normal. Okay. Then, once a woman delivers, do you know what is the shape of external os in nulliparous? So, in nulliparous women, the external os is circular. What happens after delivery? It becomes like a transverse slit. Can you tell me when does it become circular again? Never. It will never become circular again. It remains transverse. Okay. If we ask you neuropathy, then the general answer is lateral cutaneous nerve. Don't answer it as foot drop. Can you tell me when will foot drop happen? Prolonged lithotomy. Then common peroneal can get damaged. So foot drop is not a general answer. Foot drop will happen with prolonged lithotomy. Okay, is it clear? All right. Postpartum blues, NEET PG has already asked. You call them as blues because they are only mild symptoms. They will begin usually 2 to 3 days after delivery and they have to recover within 2 weeks. Anything if they go beyond 2 weeks, then what do you think of? So if the symptoms are persisting beyond 2 weeks, you no longer call it as blues. You have to now consider postpartum depression, which is going to be more severe. When we ask you the cause of these blues, There could be multiple reasons, but what you have to answer is fall of estrogen and progesterone. These are again some previous year questions which NEET PG can ask. For example, when does HCG return to normal? So usually around 2 weeks. When does cardiac output return to normal? Again around 2 weeks. Okay. When do menses return if she is a non-breastfeeding woman? Then usually by 6 to 8. What about breastfeeding? She may remain amenorrheic for longer time period, maybe 6 months, maybe even more. Okay. This is although a pediatrics question, but it's important. So pedia or PSM, but important. When should breastfeeding begin? It has to be started within 1 hour. Is this clear to everyone? Yes? Contraindications. The single best answer is galactosemia. But yes, if there is active as well as untreated TB, then yes, we can consider it. But if it is not active or if she is on treatment, then it's not a contraindication. Okay? Herpes lesions on breast. So then she should not breastfeed from that breast, but she can do it from the other one. Chemotherapy and radiotherapy in the mother. Yes? Again, as I said, more of typically a pediatrics question. So if you differentiate colostrum from later milk, remember colostrum ka main function is immunity. So it has very high levels of immunoglobulins and proteins. Okay. It will have less of fat. Then as I said, even the smallest thing in your DVT would come in the exam. So please remember, when can you put postpartum IUD? Can you tell me? Postpartum IUD can be put within 48 hours. Okay. So please remember, if I ask you what is the best time for IUD insertion after delivery, then you can answer it within 10 minutes. So it can be done up to 48 hours. But the best answer is within 10 minutes. This is what is called as post-placental insertion. Okay? No. ASAP is not the answer. Okay? The answer is within 1 hour. Alright? Then, please remember, as I have mentioned, if we are asking you contraception of choice in a breastfeeding woman, single best answer is progesterone only pills. The second best answer is IUD. Both can be given. Okay. When should you start contraception? So if your patient is not breastfeeding, start contraception by 3 to 4 weeks because ovulation can return. Okay. On the other hand, if we are saying she is breastfeeding, then you begin contraception by 3 months. So 3 weeks for non-breastfeeding and 3 months for breastfeeding, right? So these are some of the most important things from postpartum. I have already covered Sheehan's previously, so I have not written here again. Okay. We will talk about contraceptive methods in more detail in gynae. This is only about postpartum. Right? So we will talk about Pomeroy and other things in gynae DVT. It is there with images. Okay? Chalo. So then we move on to the last lap, right? Which is going to be labor. Now, very standard things are coming in NEET PG, but some of these are very conceptual. So other are more of memory based, right? So I will tell you where the things are conceptual, but the initial part where I'm focusing are memory based and they are like almost always coming in the exam. For example, your NEET PG is fond of asking diameters. So they could be diameters of pelvis or they could be diameters which are engaging diameters, but they are asking it. So the first part is going to focus on this. For example, I am sure you remember that the smallest diameter of inlet is obstetric conjugate. Can you measure it? Yes or no? No. Okay, it cannot be measured. So therefore, what we measure is diagonal conjugate. Yes, and you should know the formula. So the usual value of DC, as I have written here, is 12 minus 1.5 gives us the OC. Yes. Now, please look at these things that I am going to tell you. It is very important. When you talk about the pelvis, we talk about 4 planes. There is a plane of inlet. There is a plane of outlet. There is a plane of greatest dimensions, and there is a plane of least dimensions. Inlet and outlet are very simple. Why? Inlet may the dimensions are always going to go up to sacral promontory. Right? So if it is going to sacral promontory, you know we are talking about inlet. Outlet is similarly very simple. If you are talking about anatomical outlet, it will go to the tip of coccyx. So if we are showing a diagram going to the tip of coccyx, it is anatomical outlet. Okay. Plane of greatest dimensions, we have no interest because it is not a place of problem. If it is big, a baby will pass. But you should know the plane of greatest dimensions passes between S2 and S3 intervertebral space, which means out of all of these, which is the most important for us? The plane of least dimensions. That is the most important one. So remember, plane of least dimensions passes through the ischial spines, and posteriorly it goes to the 5th sacral vertebra. Can you all appreciate it? Give me a thumbs up. Now listen to me very carefully. Are you going to listen to me? Look at the yellow area. I will put a number there as 1. So the space which is above the least pelvic dimensions is called as mid pelvis. So number 1 is mid pelvis. The space number 2, which is below the plane of least dimensions. Yes, what is that? That is obstetric outlet. So obstetric outlet lies between what 2 things? Can you now tell me? Between least dimensions and anatomical outlet. Can you tell me mid pelvis lies between what 2 things? Plane of least dimensions and greatest dimensions. Yes, have I made myself clear? Okay, perfect. So this is important. Your NEET PG is asking these things. They color these areas and ask you. Remember, if we ask you what corresponds to the plane of obstetric outlet or what corresponds to the plane of mid pelvis, you will answer it as plane of least pelvic dimensions. This is the common part. Above it is mid pelvis. Below it is obstetric. Okay. Remember, the plane of least pelvic dimensions passes through the ischial spines. So which means this is the narrowest area of the pelvis. So if we ask you what is the shortest diameter of pelvis, what will you answer? The shortest diameter of pelvis, therefore, is to be answered as IID, interischial spine diameter. Yes? Okay. Now they give you these kind of images as well. So they will ask you which diameter is being measured. So remember, we are going to sacral promontory. So which means we are measuring the inlet. I told you, anytime we show you sacral promontory, it's inlet. Now, in the inlet, it could be 3 diameters. Yes, it could be diagonal, it could be obstetric, it could be true. But I have taught you, you cannot measure obstetric conjugate, you cannot measure true, you can only measure one, which is diagonal. So answer here is diagonal. So remember, diagonal goes from where to where? Can you appreciate? It goes from lower border of symphysis pubis to the sacral promontory. Okay, just a minute, a little problem. I can't see here. ये एक मिनट कुछ Okay, I'm back. Yes, so let's look at this. So, as I said, if it is going from lower border to sacral promontory is diagonal. When you go from upper border, so look at this very carefully. When you go from upper border to sacral promontory, then it is going to be true conjugate. Okay, then it will be true conjugate. Yes, and if you go from, this is what the NEET PG has recently asked. So if you go from inner surface of symphysis pubis to sacral promontory, then it is which conjugate? Then it is obstetric conjugate. So sometimes they have to ask the same thing, but they keep giving different methods of asking. So you should know which conjugate goes from where. Yes. Now, the next thing that they have been asking is the shape of the pelvis and something related to it. So, remember these things. If it is a round shaped inlet, almost circular, it is gynecoid. If it is heart shaped, it is android. Also, can you tell me what are the other features in android that we should know? We should know that android will have convergent side walls. Yes, so we should have convergent side walls. Okay, what else? We should know that what is prominent? The ischial spines are prominent. Now, your exams are fond of asking that if you see android pelvis, what position will you see? So, you have to know OP or ROP. In fact, we will ask you, what is the most common cause of OP? What will you answer? So, most common cause of OP is android. Now, listen to me very carefully. If we say there is persistent OP or direct OP or face to pubes, now can you tell me what would be the pelvis? I have, yes. So please remember this. If we use a prefix like persistent OP or direct OP, then you should answer it as anthropoid. Okay. Then please remember, anthropoid is a AP oval pelvis. So sometimes exam twist how they ask. They will ask you which pelvis has a bigger AP diameter as compared to a transverse diameter. Then what is the answer? Then it is anthropoid. If it is reverse, transverse diameter is more, then the answer is platyploid. Okay. Platyploid made, you will typically see brow presentation or face presentation. Sometimes your exams are asking which pelvis is called as flat gynecoid. Then the answer is again what? Platyploid. Okay, so flat gynecoid is platyploid. Yes. Now, please remember another important area where they ask you questions is right. So as I said, in your exams, they have, especially again NEET PG, they have been asking about deep transverse arrest. So although it is seen in both android and anthropoid, what is the single best answer? It is a android pelvis. Is that clear? Now, can you tell me how do we identify this is ROP? So I have taught you. The first thing that you should do is identify the triangular fontanel. Then see if it is close to sacrum or symphysis pubis. So in this case, it is close to sacrum. So it is OP. It is our left. So for the patient, it is right. Yes. So this is ROP. Can you do this one? Although this is also answered. But remember, this is the triangular fontanel. Now it is close to symphysis pubis. This is 12 o'clock. This is 6 o'clock, right? So it is close to symphysis pubis. So it will be OA. It is our right. So for the patient, it will be left. Is it clear to everyone? Give me a thumbs up if this part is good for everybody. Okay. Now, the third thing that lambda is the name of the posterior fontanel. Okay. Please remember, when we talk about anterior fontanel, we call it as bregma. What shape it is? Rhomboid. Okay. We are not interested in anterior fontanel as of now. To find out the positions, we work on the posterior fontanel, which is triangle or yes, the lambda. Is that clear? Okay. These are repeated PYQs. I am sure you will not do them wrong. The most important method that I have to teach you here for the grips is this. In all grips, 1, 2, 3 and 4, you will see all grips have 2 hands except one. Can you tell me which one is it? Leopold 3. So if we are showing you a grip which is being done with one hand, it has to be Leopold 3, which is called as Pollock. Okay? Next, in all the images, okay, do you see that the fingers are directed upwards except one? Can you tell me in which image the fingers are directed downwards? It is 4, right? So when you see 2 hands and fingers directed down, then it is Leopold 4, also called as pelvic grip or deep pelvic grip. Can you remember now? The only confusion is which is first pelvic and which is second pelvic. So if they ask you this, then remember Leopold 3 is first pelvic and Leopold 4 is second pelvic, right? Fundal grip is what is the name of Leopold 1. But please remember, Leopold II is also called as umbilical grip or lateral grip. Is that clear? So these images are also very common. As I said, the third set of question comes from engaging diameters. So I have given all of the engaging diameters in this image, and as answers, you should be able to revise it from here. The only thing I want to highlight here is three things. If they ask you what will be the engaging diameter when the head is well flexed, you have to answer well flexed as vertex and it is suboccipitobregmatic. Now listen to me even more carefully. Especially NEET PG confuses this more and asks again and again. If they say deflexed, then you answer it as occipitofrontal 11.5. What NEET PG does is they exactly will confuse you by saying partially deflexed. When they use the word partial deflection, the answer will change to suboccipitofrontal 10.5. Is this clear? Yes. Also here I want you to remember, when you say deflexed head, what is going to be the position of the baby? Occipito-posterior. So generally in OP the head is deflexed. Can you also tell me which fontanelle will you be able to feel easily? Can you tell me which fontanelle will you be able to feel easily? In deflexed head, it will be anterior fontanelle, rhomboid. In well-flexed head, you feel which fontanelle? Posterior fontanelle. This is yet another question that exams are fond of asking. Then, if we ask you partial extension, you will answer it as brow. If we ask you full extension, you answer it as face presentation. Is that clear? For face, the answer is submento-bregmatic. For brow, it is mento-vertical. And I'm sure we all remember, mento-vertical is the largest head diameter. Yes? This is only to ensure then that when any set is asking you basics, you don't do blunders. This is how we look for station. So point number 1. When you say head is engaged, what is the station? The station is 0. What is the meaning of the word or symbol plus? Plus will mean below ischial spine. Minus will mean above ischial spine. Okay. What is the meaning of the numbers that we write? So suppose I write -2. What does that mean? It means 2 centimeters above ischial spine. When you say crowning, it is at least +3. Yes, so when you say crowning, it is +3. This is the ideal time to give episiotomy if you have to give. Episiotomy, we know. Is it given routinely? No, it is not given routinely. But if you have to give it at the time of crowning. Yes, so is this all clear? The next diagram is also to give you a basic idea because NEET PG keeps drawing these hand-drawn things and keeps asking you. Please remember, when you see a straight line, that is the most important one. So look at graph C. Can you all focus on graph C? Graph C mein, the active phase has become a straight line which is horizontal. Yes? So now, please remember this. When you see a straight line, which is graph C, what does it indicate? Arrest of active phase. Now, I want you to tell me, if you can recall, what are criteria for arrest of active phase? Can anybody tell me? So, the criteria here is no change in cervical dilatation. Can you tell me for how long? For 4 hours with adequate contractions and 6 hours with inadequate contraction. But please remember, when you say arrest of active phase, the patient has to be in active phase. So can you tell me the new guidelines for active phase? More than or equal to 5 centimeters is active. So patient has to be in active phase. To call it as arrest, और क्या होना चाहिए? Please tell me, what are the other requirements of the criteria? Membranes should be ruptured. You cannot make a diagnosis of arrest if membranes are intact. So you will have to first rupture the membranes and then wait. Okay? Now, NEET PG is also fond of asking, okay, if you are seeing a straight line, the diagnosis is arrest, what do you think is the cause? Majority of times when you see arrest of active phase, the cause is CPD. Is that clear? So most common cause of arrest is cephalopelvic disproportion. Now you are going to tell me what would be the keywords that will be written to know it is CPD. These are the two keywords, caput and molding. So if you see them together, right, especially if the molding is +2, +3 along with caput, you know it is CPD. Now comes the next part. If CPD is present, should you ever do an instrumental delivery? Never. So no instrumental delivery in CPD, which means if they show you this graph where it is a straight line and they're asking you management, what will you answer? You have to answer it as emergency cesarean. Yes, is that clear? I will go one level higher with you. Suppose there is arrest, okay, but now it is arrest in the second stage. First of all, I want to know from you, how do you know it is second stage? The cervix is going to be fully dilated. Is that clear, bacha? So the cervix will be fully dilated. Yes, so then I know it is arrest. But now I want to ask you, what are the criteria in primi and in multi? So in primi, you have to wait for 3 hours and in multi, you have to wait for 2 hours. So this is the criteria for arrest of second stage. But now you will tell me this. Suppose there is arrest of second stage. How do you decide the mode of delivery? Batao. So you have to see whether CPD is present or CPD is absent. If CPD is present, the answer will again be cesarean. If CPD is absent, then the answer is instrumental delivery. Now you will tell me, in instrumental delivery, how do you decide whether it is forceps or whether it is vacuum? So remember, if we are writing fetal distress, the better answer is forceps. If we are writing there is a big caput but no molding, then again a better answer is forceps. Yes, is that clear? Yes. So in these cases we will use forceps, we will not use vacuum. Is that clear to everyone? Yes. But if you don't know how to use forceps, then obviously you will mark the answer as vacuum. Is this clear to everyone? Give me a thumbs up. Then I will confuse you. So you have to tell me. Now I am saying she is having arrest of second stage and a fetal distress. Should you answer it as cesarean? No. In the second stage, even if there is distress, our preferred mode is instrumental, provided there is no CPD. Okay. So provided there is no CPD. Is that clear, bache? Okay. And since I am talking about this, you should now know for new pattern exams, contraindications of vacuum. So please remember prematurity, face presentation, after coming head of breech, and a big caput. Okay, so please remember these are contraindications only for vacuum. Can I apply forceps here? Yes. So in all these conditions, forceps can be used. Okay, but let me ask you, if there is a deep transverse arrest, okay, and the cervix is fully dilated and there is no CPD, can you tell me what will you do in this condition? So this is what I want to ask you. Tell me, there is a deep transverse arrest, cervix is fully dilated, there is no CPD. Now what do? Here specially the answer becomes vacuum. Can you tell me why? Why? Because the head is number 1 high up. It is still at station 0. At station 0 we don't apply forceps. Okay. Second, the head is not rotated. So when the head is not rotated, we don't apply forceps. Okay, we will apply vacuum. Vacuum can bring the rotation. Is that clear? What is the minimum requirement for station for forceps? So for forceps, minimum requirement is +2 station. This is what we call as low forceps. Okay. On the other hand, if it is outlet forceps, then you should know the station is +3 or more. Yes, is that clear? Are you good with this? Okay. The other aspect with NEET PG is fond of asking is to make a diagnosis of occipito-posterior. So these are the key words. There will be infra-umbilical flattening. The limbs are in the midline. The back and the fetal heart rate is in the flanks. Okay. Head is usually high up. Can you tell me why? Why is it not engaged? Because it is deflexed. So bigger diameter has to enter. Labor is prolonged, but the management will be wait and watch. Because the head is deflexed, anterior fontanelle is felt more easily. Okay. So OP. If NEET PG has to ask you something else from malpresentations, it will usually be breech, right? So when you talk about breech, remember the preferred method for breech delivery is what? It is cesarean. But before I go for cesarean, I should try external cephalic version. So remember, the ideal time for ECV is 37 weeks. In case you cannot do ECV, so as I said, if ECV is contraindicated, then as I have written above, what is the preferred mode? Then the preferred mode of delivery is cesarean. Is this clear? Give me a thumbs up very quickly. Okay. So now, once you know this part, you should therefore know what are contraindications of ECV, because NEET PG is asking this as an integrated MCQ between different topics, right? So if you don't know the contraindications, you will mark the answer as ECV and it will become a wrong answer. So anytime we say footling breach or a stargazer breach, very important contraindications. Okay. Multifetal pregnancy and ruptured membranes, very important. Fetal distress, contracted pelvis, placenta previa, very important. Now, the ones that I have marked orange or yellow, whatever you can see, they are what? Tell me. These are absolute contraindications. The others that let me say I will mark green, like previous cesarean, oligo, preeclampsia, IUGR, macrosomia. ये green वाले क्या हैं? Relative contraindications. Do you understand the meaning? Which means, although I can do ECV, but we usually don't do because the risk is high. So NEET PG will specially ask you, your patient is pre-eclampsia, she is 37 weeks, she has a breech baby, what do you want to do next? So do you want to do wait and watch, okay, for spontaneous labor? Do you want to do induction of labor? Do you want to do ECV or do you want to do a cesarean? What is the answer? So I said A, wait and watch. B, I said induction. C, I said ECV. And D, I said cesarean. What is the answer? Yes, the answer is only and only cesarean. You can't do wait and watch because she has already reached 37 weeks. You cannot do induction because she is breech. In malpresentations, we don't do induction. You can't do ECV because she is pre-eclampsia. Okay? Very nice. Good job. The last topic that I want to definitely highlight for NEET PG is induction of labor. Always an MCQ, right? So when you talk about induction of labor, you should know kahan nahi karna. For example, any condition where vaginal delivery is not possible, like contracted pelvis, placenta previa. Okay. Similarly, conditions where there are malpresentations like transverse lie or for that matter breech. Okay. Conditions like vasa previa, placenta accreta, spectrum. Yes, so in all these conditions, cord prolapse, classical cesarean ka history, in all these conditions, we cannot do a vaginal delivery. That's what is common to all of them. And therefore, we cannot do induction. Recently, they have asked about active lesions of herpes. They may also ask about category 3 fetal heart rate. It's an absolute indication for cesarean. They may ask about VVF repair. Now, it's very obvious. Whatever I am writing as contraindications for induction, can I say they are indications for cesarean? Yes or no? Yes. Okay. And overall, do you know what is the most common indication for cesarean? Malpresentations, right? So overall, you know, mostly cesareans are done for malpresentations. Now, whenever we talk about induction of labor, yes, you should know about Bishop scoring. So Bishop score is going to use these 5 parameters. Yes, the total score is out of 13. If it is less than 6, we say it is unfavorable. If it is more than or equal to 6, we say it is favorable. If it is favorable, we will start oxytocin. But if it is unfavorable, we will have to do cervical ripening. For ripening, most commonly we use prostaglandins. So it could be E1 or E2. Out of the two, can you tell me which is more common? In India, more commonly we use E2, Cervi Prime Gel or Dinoproston. ये नीट पीजी का फेवरेट क्वेश्चन है. कैन आई यूज कार्बोप्रोस्ट और डाइनोप्रोस्ट? नो बाबा, नो. Remember, dinoprost and prostone are different drugs, right? So PGF2 alpha is not used. Okay, is that clear? Now you should know what are the 5 components. So dilatation and other things. You should know that in modified bishops, we are replacing effacement with cervical length. So instead of effacement, we will write length. I have taught you yesterday in my, or not yesterday, maybe day before, I made a short video, I put it on Instagram as well, how to try and remember this. Have you all seen that? So I'll just give you a highlight of it. I want you to only remember the columns where we are giving the score of 1 and 2. And it's very simple. Look at this. So dilatation is 1 to 2 centimeter and then it is 3 to 4. So after that is effacement. So 1, 2, 3, 4 and then it goes to 4, 5. So 40%, 50% and then 6, 7. So 1, 2, 3, 4, 4, 5, 6, 7. Then I have taught you for station, you can never have the same number, which means if the station is -2, you cannot give a score of 2, you have to give a score of 1. If the station is -1, you cannot give a score of 1, you will give a score of 2. Yes? Then medium and mid position are 1, soft and anterior are 2. Yes, length mein, how did I teach you? It is reverse of dilatation. So even if they ask you to calculate modified bishops, everything is same. The only difference here is, I will write length here. And then I have taught you it is reverse of dilatation. So for length, what did I teach you? For length, here it will be 3 to 4 centimeters and here it will be 1 to 2 centimeters. Okay. So once you know this 1 and 2, everything else becomes very simple. So anything more than 4, which is 5 centimeters, is 3. Anything less than 1, which is closed, is 0. Anything more than 70%, which is 80 or more, is 3 score. Anything less than 40, 0 to 30 is 0. As I said, station can never have the same score. So if it's -3, you can't give a score of 3. You have to give a score of 0. Yes? And +1 and +2 will be 3. So that's how you calculate bishop score. It has come twice in any set exams. It may come in NEET PG to calculate. Components we were anyways asking. Yes? So these are important things with respect to what you should know or must know from labor. Somebody was asking me about transverse lie. It is very similar to breech. So if you see transverse lie at 37, you answer it as ECV if no contraindications. If contraindications are present, then again your preferred mode is cesarean, never ever vaginal delivery. Do not forget neglected shoulder presentation. So some of you confuse shoulder presentation with shoulder dystocia. So when you say neglected shoulder, it is basically obstructed labor. And even with IUD, the answer will be cesarean. Once you say it is obstructed labor, it is going to be a cesarean section. You cannot do a vaginal delivery. Okay. Lastly, yes, I would want you to know this about shoulder dystocia. Can you tell me the correct sequence of maneuvers? What should you know? So the first thing is, definitely you call for help, you give episiotomy, you empty the bladder, but the first maneuver is McRoberts. So I'm sure you all remember the helper. Now helper is what is the older mnemonic, and for NEET PG it is still okay to follow helper because they may not ask the updates. For example, L is McRoberts, then it is suprapubic pressure. If they fail, you do the enter or rotational maneuvers. Can you recall the name of the rotational maneuvers? Yes. So Woods, corkscrew and Rubin. If this also fails, then you remove posterior arm, which is called as Jacqui-Mears maneuver. And R is what? Roll over or Gaskin maneuvers. Yes, Z is the last alphabet. So obviously it is last, Zava, Nelly. So this is what is the standard protocol, but recently, if you have done my classes, I've told you there is an update on this, and in any set they may ask you the new guidelines. So now we say you do McRobert, you do suprapubic, but if this fails, then you should first do removal of posterior arm. Then you can do the Gaskin maneuver, because all these maneuvers are external maneuvers and they don't need anesthesia. If these fail, then you should do the internal rotational maneuvers, because the interval duration maneuvers will need what? They will need anesthesia. Is that clear? Yes. So these are things that you should know with respect to shoulder dystocia, right? So with this, we come to an end. Yes, it is DVT boot camp for a reason, right? So we have to ensure that you are able to do well in the exams no matter what. And especially, you know, DVT boot camp is also for anyone who has never ever attended DAMS classes before. So even if you have studied from somewhere else, if you do the DVT boot camp, it is like a power pack. It has concepts, it has application, it has memory based things, it has algorithms, it has keywords, it has multiple tests, it has combo test, grand test, everything in one. So it's like a complete package by itself. We want to ensure that you don't need anything else after it and you can revise it multiple times as well, right? So I hope I have done justice for your time. It was an absolute pleasure to be with you all. So thank you so much. Yes, tomorrow we will be doing the obstetric PYQs and the obstetric TND. Please give the test paper. Tomorrow's class will definitely be much shorter than this because we've taught you everything today in OBS. So tomorrow we will learn the application. Yes, is that okay? So we will start tomorrow's class maybe at 10:30. Is that good for everyone? So we will start at 10:30. We will do the PYQs of OBS and we will do the PYQs in and we will do the test paper discussion as well. Okay? So take care everyone. See you tomorrow at 10:30 in the morning. You were a great batch and I thoroughly enjoyed teaching you all. Okay? Take care. Go rest. Try and revise whatever you can. Okay?